Good morning. I welcome all the faculty and delegates for today's TAPISR ECME. This time we have selected different topics tackling of ART in special situations. And we have selected the speakers from Andhra, Telangana, Tamil Nadu, Kerala, Karnataka, Maharashtra, and Delhi states. And they're all young, energetic, dynamic speakers, experts in their field we have taken. I hope from tomorrow onwards, the way you are going to practice is going to change after listening to these webinars. So these are the topics. I request our president, Dr. Kamala Selvaraj, to introduce. She is the director, GG Hospital, Fertility Research and Women's Specialty Center, Chennai. She got trained in IVF in Monash University in 1985. After that, in Singapore, she has commissioned the first test tube baby of South India in 1990. She has published many papers in national and international journals. She had received many awards. That's why the communism has entered into the India, because one person has taken all the awards. Last but not, she is the delivered more than 25,000 IVF babies. I request Dr. Kamala Selvaraj to introduce our moderators for today.
Thank you, Dr. Sanjeev Reddy. Let me introduce Dr. Vijay Ganesh, MBBS, MSc Human Genetics, Congrats. Wellness Center, Alvapet, Chennai. From MMC, Chennai, 1980, Masters in Human Genetics, Department of Human Genetics, Sri Ramchandra University, Chennai, 2005. PhD Fellow at the Department of Human Genetics, Sri Ramchandra University, Chennai. Achievements felicitated on Doctor's Day at Madras Medical College by TIMA, 2018. Committee member, Tamil Nadu and Pondicherry Chapter of Indian Society for Assisted Reproduction, 2012. Best Doctor Award bestowed by Dr. MGR Medical University, presented by the Governor of Tamil Nadu at Raj Bhavan, 2014. Lifetime Achievement Award given by MIF Line S. Kalamati, Regional 7 District, 2012. And the best award, she has worked with me for more than 7 years.
Yes, ma'am. Yes, ma'am.
That is the biggest award.
Means because of you.
Now, Dr. Sarath Bhatia, my very good friend, Director and Senior Consultant, Reproductive Medicine, Integra Women's Center, Chennai, IVF Training in National University Hospital, Singapore, and College School of Medicine, London, and Executive Member of TAPISR, actively involved in conducting ISHA 2015 and UVA ISHA 2018 in Chennai, in charge of IVF program at Apollo Hospital, Chennai from 1989 till 2016. Wow. Responsible for the first gift baby of Tamil Nadu in 1989. Responsible for the first IVF twins of South India, 1991. First IVF baby from frozen semen sample in India. Very good. Now coming to Dr. K.S. Jairani Kamraj, MD DGO, DIP, Reproductive Medicine, Germany, Chief Consultant in Infertility and High Risk Pregnancy. It's not coming fully. Okay. Chief Consultant, Akash Fertility Center and Hospital, MBBS, Madurai Medical College, 1998, DGO, Tanjavur Medical College, 1992, Madras Medical College, 1998, Medal and Awards, Rajamani Janaki Raman Prize in Gynecology and Obstetrics, Dr. Vada Malayan Endowment Prize Gold Medalist in MBBS and OBGYN Examination, University First, Dr. Anantachari Prize for being University First in Medicine, Gold Medal in DGO University Examination, awarded the Woman of the Year 2010 by Lions Club, and Achievements of Human Service awarded by SNORA 2010, Mega TV Women Achiever Award 2011, Nalam Hospital Women Achiever Award 2011, Best Doctor Award 2012, given by Tamil Nadu, Dr. MGR University, Medical University. So welcome all the moderators My dear friends, all three of you, have a nice time and high educational conference. Let's enjoy.
These are the pillars of TAPISAR. Because of them only, all of these people, the TAPISAR is gaining popularity. I request Dr. Vijaya Ganesh to take over the session and conduct the proceedings of first session.
Yes, sir. Thank you for giving me this opportunity, President Ma'am, Secretary Sir. I'm here. Good morning to everybody. And on this Sunday, I welcome all the speakers, moderators, and the delegates who's attending, sacrificing time on Sunday. And I first of all welcome Dr. Ramesh, who is MCH in Reproductive Medicine and Surgery. He passed out his MBBS in Government Medical College, Kottayam, and MS MKCG Medical College, Berhampur, Orissa, and his DNB also from the same college, and MCH Reproductive Medicine Surgery in Amrita Hospital, Kochi, Kerala. He worked as consultant and academic coordinator of DNB Fellowship and FNB program at CIMAR, Idapadi Hospital, Kerala from 2008 to 2017. He's got a lot of qualification. Now, his area's interest is reproductive physiology and clinical research. I call upon Dr. Ramesh to talk on the interesting topic of role of. So, one second, this topic. And risk of cancer from ovarian stimulation, which we all are feared on because of repeated stimulation. That is the important topic. Thank you very much for choosing this topic and choosing the speaker, sir. Here I welcome Dr. Ramesh.
Good morning. Am I audible?
Yes, yes.
Yeah, a warm welcome and good morning to all. Because being the first talk, even I can give a welcome to all of the speakers and all of the delegates who are attending this wonderful meeting. At the outset, I would like to thank Dr. Sanjeev Reddy and the team TAPISAR for providing the opportunity to speak to you all regarding this thing. We had attended many, we have been meeting in many conferences offline. Right now, everything is being online, so it's being a wonderful platform. We can speak to you all at home and at the convenience and comfort of home. At the same time, we are able to get enough information from the academic extravaganza. So today, I will be speaking about the risk of cancer from ovarian stimulation. Is there a real association between the ovarian stimulation drugs and cancer? This is we are going to check. So we will be covering briefly about cancer etiology. How does infertility per se increase the cancer risk? How does ovarian stimulation causes cancer? Does oral agents and injectables are different regarding the cancer risk? Does IVF cycles per se increase the risk? And we will be touching the current evidence and controversies. Etiology of cancer ovary first, it's multifactorial and epithelial ovarian cancers are the most common. Advanced age, infertility, nulliparity, environmental and genetic factors do contribute to increased ovarian cancer. There has been some postulations about incessant ovulation theory. That is, repeated ovulation might disturb the surface epithelium of the ovary. That can be mitogenic. That can lead to epithelial ovarian cancers in a large scale. And that was a biggest thing which was coming against clomiphene citrate. But of late, this has been challenged by the new theory of fallopian tube origin of epithelial ovarian cancer, where they are telling the epithelial ovarian cancer is originating from the fallopian tube. So even if the ovary is repeatedly ovulating, the cancer incidence may not be that much high as which has been postulated before. Borderline ovarian tumors is a new subset of ovarian tumors which is not having that much malignant potential. These are characterized by early age diagnosis and favorable prognosis. To be noted, parity, sterilization, hysterectomy, endometriosis do not affect the incidence of borderline ovarian tumors. Fertility drugs are recently linked to borderline ovarian tumors in many studies, but mostly this has been attributed to surveillance bias because those who are undergoing fertility treatment may be having excessive surveillance compared to the general population or the other people. So there may be just a detection bias rather than an actual true incidence of increase in borderline ovarian tumors. We'll be discussing it later. Breast cancer is multifactorial. Endogenous estrogen exposure is the thing which is mostly attributable to increase in breast cancer risk. But along with that, progesterone, the role of progesterone is very much contradictory. Some literature is saying progesterone is protective to breast cancer, like endometrium, but many people are telling that progesterone is mitogenic to the breast tissue. So progesterone, the effect of progesterone based on the distribution of its receptor is very much contradictory. So there is no clear-cut consensus whether progesterone as such increase the chance of breast cancer or decrease the chance of breast cancer. But estrogen, without any dispute, estrogen do increase incidence of breast cancer. But when we are doing ovulation induction agents, if they are becoming pregnant, this parity itself, which is the biggest thing against the incidence of breast cancer. So any multiparous lady, they are having very less chance of having a breast cancer. So the parity per se might be having a big effect on decreasing the chance of breast cancer. So in a nutshell, we can even think that the fertility treatment might be going to decrease your incidence of breast cancer. CA endometrium, again, unopposed estrogen is the biggest thing. Progesterone is protective without any doubt. Anovulation, infertility, obesity do increase the incidence of CA endometrium. So also genetic factors and other factors. Thyroid cancer is more common in women with high parity. CA cervix does not have any possible direct hormonal effects. Melanoma, lymphoma, and colon carcinoma also has been studied with relation to various fertility drugs. How does cancer risk increase in infertility? As such, the parity, if there is less parity, there is more chance of cancer, especially ovarian cancer, endometrial cancer, as well as breast cancer. Anovulation, associated obesity can lead to increased cancer. Plus, hormonal agents like clomiphene, gonadotropin, so all these things might be a reason for increased cancer associated with infertility or infertility treatment. Drug-induced multiple ovulations, as proposed by Fatala's theory, but it is not being popular right now, may be a reason for increased ovarian cancer. Estradiol is directly responsible for breast cancer and endometrial cancer. Gonadotropins, FSH and LH. Epithelial tumors express gonadotropin receptors, and this might be having direct action on the epithelial tumors, increasing the proliferation as well as inhibiting apoptosis, which are much mitogenic and cancerogenic. Clomiphene citrate is controversial. It may be having anti-proliferative effect, especially in breast cancer, because it is a drug which is similar to tamoxifen. But we have to think, can the limited exposure of 2 to 3 cycles can alter the lifetime risk of having a cancer? And the pregnancy resulting from the pregnancy fertility treatment will negate the risk or even decrease the risk of a cancer. So whether we have to promote the fertility treatment to prevent as a preventive measure to reduce certain cancers. Clomiphene citrate can produce multiple ovulation. Previously, it was attributed for ovarian cancer. Hyperestrogenism, as we have already discussed, may be causing endometrial as well as breast cancer. Letrozole does not have any clear evidence that it may be even protective because it is belonging to anti-cancer group anastrozole. Gonadotropins do elevate estrogen levels to supraphysiological levels, but single cycle exposure, how much is the risk? It is not clear. There is no data on the total dose of exposure of gonadotropins, which would be an ideal thing to compare with the outcome. And there is no clear-cut differentiation between the human products and recombinant products. But human products, because apart from the gonadotropin, it is having many other contents and proteins that might be even responsible for increased cancer risk associated with HMG. And there has not been clear-cut any comparison between recombinant and human products in relation to cancer. Even in relation to stimulation outcome, the results are controversial. So, relation to cancer, we don't expect much possible outcome in the future. GnRH analogs, HCG, progesterone, these are almost never used alone, always used along with stimulation agents. So isolated risk for these drugs is questionable. What are the main issues in the literature? Main issues is a methodological issue. The methods, there is no proper methods in the study. So that is the biggest thing which is going to tell you that many of the studies are not reliable in relation to the cancer chances. There is inability to pinpoint to specific medications like clomiphene or gonadotropin, as I already discussed. Insufficient follow-up. Cancer is a long-term disease. We need to have a very long-term follow-up. Very few studies are having long-term follow-up, but many of the studies does not have that much follow-up. So this data is also insufficient. There has been many confounders like infertility per se is the biggest confounding factor, parity, late onset childbirth, everything has become confounded. There is imprecise outcomes in various studies, and there is a surveillance bias because infertility patients are undergoing clear-cut or close surveillance, and they might be undergoing more detection of cancers compared to the other cancers. So the surveillance bias do play a big role in the possible increased incidence of cancer in infertile patients. RCTs are not practical to address the issue. Case control and cohort studies are there. but long period follow-up is very much important for detecting the cancer. But borderline ovarian tumors need short follow-up, so that may be the responsible for the increased reported incidence of borderline ovarian tumors in many fertility treatment patients. Cohort studies basically have selection bias. This can be minimized by selecting a proper control group. So what should be the control group for a cancer study in a cohort group? Ideally, it should be infertile patients. Those who are undergoing the fertility treatment should be the cases, and infertile patients, those who are not undergoing treatment, should be the control. But any infertile patient which is coming to your clinic, most of them will not go without any treatment. So infertile patient without any treatment is almost a virtual reality. It almost never exists. So ideal control is not possible usually in a cohort study. If you are taking general population, there does not have infertility, which is the biggest confounder factor for increasing the chance of ovarian cancer for any cancer. So general population, if you are taking, that may not be an ideal control group, and you will be able to get only the standardized incidence ratio or the SIR. You won't be getting the actual ratio. And if you are getting data from this registries, many confounding factors might be missed out. So cohort studies who have confounders, they need long-term follow-up, which is not there in many studies, long latency, no ideal controls, and cancers are as such rare. So cohort study is not a good design for assessing rare diseases. For rare diseases, you do have case control studies, but these are suffering from recall bias as well as selection bias. We don't have a good selection group, and recall bias will almost affect your outcome. The patients who are already having cancer might be attributing excessively to the fertility treatment, because they will be looking for some reason to tell you that they got cancer with these drugs. So there may be recall bias, and there has been so many confounders in case control studies, and detection bias already do exist in case control studies, and you won't be able to accurately estimate the incidence of cancer in case control studies. You will be getting only an estimate of risk, that is odds ratio. Will be this getting an estimate. The correct risk we won't be able to identify in case control studies. So good study design is cohort study, but that is not practical for case control studies. But that not practical for long-term follow-up conditions. So case control studies do help us a lot in this scenario. If you are searching the literature, lot of studies are reported. Almost all are methodologically inferior. Meta-analysis and systematic reviews are there. Cochrane 2013 had come up with reports, and it was being updated in 2019, and ASRM had put guidelines in 2016. We will be discussing basically these two. Cochrane in 2019 basically talked about ovarian cancer and borderline ovarian tumors. It includes 13 case control studies and 24 cohort studies with including 44 lakhs plus women. They concluded that slightly increased risk of ovarian cancer may occur in infertility drug use compared to general population. Risk is higher in nulliparous women. So if you are conceiving with fertility treatment, there is no risk at all. If you are not conceiving after fertility treatment, you are using the drugs, or you are not conceiving, the advantage of parity does not happen. In that scenario, you are at a slightly higher risk. And risk is higher for borderline ovarian tumors, which is possibly attributed to surveillance bias. However, they concluded that the evidence level is very, very, very low. Only a few studies, number of cancer cases were very less. Information on the drug dose and type was insufficient. So it was not clearly, you were not able to come into a conclusion, but you can basically tell your patient that at present you are not having much increased risk of having a cancer after ovarian stimulation. ASRM has clearly given the evidences. There is no increase in ovarian cancer level B evidence. There is no difference between various drugs used, such as clomiphene or gonadotropins. Increase in borderline ovarian tumors is possible, but evidence is insufficient. Insufficient evidence to recommend against the use of fertility treatment to avoid borderline tumors. So you can easily go continue your ovarian tumor, your fertility treatment, because there is at present there is no increased risk of any cancers. There is no associated increase in breast cancer, endometrial cancer, thyroid cancer, colon cancer, and cervical cancer. Insufficient evidence for melanoma and lymphoma. So, does the ovarian stimulation increase the cancer risk? What is the verdict finally? It may be yes, it may be no, or it may be maybe. These are the controversies which I already discussed. The controversies do exist, do continue to exist. In carcinoma ovary, previous reports were, all the reports were telling it is associated with increased risk, but right now it may be associated, that's the first choice, or we can almost tell there is no risk of increased CA ovary in ovarian stimulation. What about borderline ovarian tumors? It may be associated, but many reports are telling it is associated. That can be placed in second and third places, but might be due to surveillance bias, so that has to be taken care of. CA breast, you can clearly tell there is no association with ovarian stimulation for CA breast as such. CA endometrium also, there is no association. Even this might be protective in CA endometrium because you are treating anovulation and you are supplying progesterone. So, are we really safe to stimulate? What are the things which reports which have come after the Cochrane review in 2019? In medically associated reproduction, there is increased risk of cancer in the children conceived after ART. So, if you are going for the childhood cancer, there has been some recent reports that childhood cancers are also on the rise after medically assisted reproduction. Again, in some neurological journal, there is increased risk of multiple meningiomas after fertility treatment. So the debate is ongoing whether it is increased risk or not increased risk. It is not clear, but at the current scenario, we need to wait for further evidence. We can tell most of the evidence is against the increased incidence of cancer in fertility treatment. So most of the cases when the patient is coming to you, we can clearly tell at present the evidence says that there is no clear increased risk of any cancer with ovarian stimulation treatment or fertility treatment. Borderline ovarian tumors might be slightly high, but close surveillance will be able to help to identify, and these are relatively indolent, so you need not worry. Because we infertilologists cannot live without fertility treatment, so these outcomes or these study outcomes has become a biggest boon to us to counsel the patient that at present there is no clear-cut evidence of supporting the increased risk of cancer following fertility treatment, but still we need to wait for further evidence because evidence is medicine and medicine is evidence. So thank you everybody for the patient hearing.
Thank you, Dr. Ramesh, for the crisp and nice talk on risk of menopause and ovarian stimulation. And the question and answer session will be at the end of this. Now, I welcome Dr. Ashish Ramchandra K, who is very active laparoscopic surgeon, infertilologist, and he completed. Sorry, sir. Sorry for the disturbance, sir. And he's the director, Ashkiran Hospital, Pune, and director, Arunachal Test Tube Baby Center, founder member and librarian, Maharashtra chapter, IAGE, 2019-2020, executive member of National IAGE, executive member of Maharashtra chapter, ISA MISAR, 2018-2020, executive member of National ISA, 2018-2022, published many papers, posters, research articles, and many national and international journals. So now I'll call upon Dr. Ashish to talk on risk of early menopause following IVF.
Thank you, Chairperson, for inviting me. At the outset, I am really thankful to Tapi sir, President Madam Kamla Selvaraj, and Secretary Sanjeeva Reddy sir for inviting me. Today, we'll be talking about, just a minute, I'll just share my screen. Yeah. It's visible?
Yes, Doctor.
Yeah. So today we'll be talking about the risk of early menopause following the IVF. All of us knows that the IVF is basically, nowadays we talked about individualized stimulation, we talked about the age group, we are talking about the BMI, and we are talking about the oocyte retrieval rate, that is called as FORT. But why we should be talking about whether the IVF is really responsible for the early menopause, whether we are really doing something good, and whether we are having a stipulated time, and in those time if we are going to get more eggs, do that particular things or that particular stimulation will cause the patient for going for the early menopause. So my talk today will be talking about really why we should be worried about early menopause and what is the menopause. Premature menopause or early menopause may be a spontaneous or may be induced. A premature menopause refers to the menopause that occurs at the age of 40, and early menopause refers when it is come at some around 40-45. Why it is that much important? Because if you're talking about the normal age of the menopause is at the age of 50 or 51, But if the same patient, because of the certain things, maybe a spontaneous or maybe induced, will come down to the menopause at the age of 40, we call as a premature menopause. And when it comes down to 45, we call as the menopause is coming too early. Why we should be worried about this particular entity? Because there is always a risk to the future for this particular lady. She has a risk of cardiovascular diseases, neurological disorders, psychiatric disorders, osteoporosis, sequelae. What it causes is like when we are talking about the IVF perspectives, we must take care of certain entities. Nowadays we never call as a POF, we call as a premature ovarian insufficiency. These are the patients, maybe a young or maybe a older age group, where we know the predictive response of the patient. We know there is a paucity on criterias which will come into the group 1, group 2, group 3 and group 4. But mind well, when you're talking about the stimulation strategies, and these stimulation strategies will going to affect her early age of menopause, because she's a case where there is a oocyte quality as well as the number of the oocyte or primordial follicle is low. We know the predictive response of the patient, and if like that, and we are going for the stimulation for IVF, really this particular factor is going to cause early menopause or not, that we are going to discuss today. All of us knows why the patient has a menarche and then she will land up into a menopause. We'll not go into the details of the physiology, but mind well, every cycle or when she is into the come into the birth of the female child, there is a fixed number of the oocyte which is there in the her ovary, and these oocytes going to get the every menstrual phase and every menstruation, these oocytes are going to deplete. We have known that now, if there is only 1000 primary follicles are there, or and then the patient is likely to go for the premenopause and they will likely to go for the menopause. Only in the reproductive age group we have a certain number of eggs or certain number of primordial follicles which are become active, and then will go into atresia in a later phase, and they will go into the aneuploidy of the oocytes. And this is why when we talking about the Posidian group of the criterias, we need to understand there is a chances of aneuploidy, there is a chances of a bad quality oocytes which is coming up. And why we are worried about? Because when we are going to start a stimulation in those patients, we likely to know the oocyte quality may be a good or maybe a bad, but is there is a really risk, and we can predict the age of early menopause. We can talk to the patient for her betterment of her life. Does the number correlate with the age of the menopause? This is the particular slide which will tell you at the age when the female fetus is inside the utero, we have the higher number of oocytes. But as the age advances, the number of oocytes and primordial follicles goes down, and at the age of 40 or 45, the number of oocytes, when it depletes to the 1000, and it will cause a natural menopause or maybe a induced menopause in the patients where they are having a POI or PO patients. What actually we do in IVF? We must know we are having a different strategies. We are having a down regulation cycles. We have a long agonist protocol, antagonist protocol. We have a short flare up or ultra flare up protocol. All these things will cause, first is a down regulation of the pituitary, then it causes a stimulation of the primordial follicle or the AFC, which is what we looked on day 2. And these strategies nowadays, all of us knows that depending upon the age, depending upon the AFC, depending upon the AMH, we stratified the patient, we stratified them into different groups, and then we start our deciding the stimulation strategies. Does this particular strategies will affect the age of the menopause? If we have the patient at the age of 40 or 42 coming to us for the conception, and we are going to do a certain things like a down regulation or a long protocol, does that particular thing will affect her age of a menopause? We need to talk about what it gives the information for the predictive of the age of the menopause. Why it is important to predict the age? Because all of us knows that the prediction of the age of the menopause is good to know. If she is advancing to the age of the menopause, there is a hormonal disturbances, there is a neurological disturbances, and psychiatric disorders may set in. Or for that matter, if at all we are really concerned for the, not only for the conception, we are concerned for the total well-being of the patient. Does the prolonged use of the COCs, if you are talking about the of the down regulation, that is the first stage of any follicular stimulation or maybe IVF stimulation, we give a OC pills for down regulation. We give a GNH agonist or we give a long protocol. Previously, because I searched on a PubMed, and there are the fewer articles that will be helpful for us to understand this. If you are giving the COCs for a longer time, there was a previous thought that they given the COCs even for the premenopausal age group, and they thought that the age of the menopause can be prolonged, but it never happened in that way. Usually when you give a OC pills, the long term and high dose of the OC pills usually affect the age of the menopause. So if you are doing the some things or like stimulating those patients of POI, poor ovarian insufficiency, and if you are giving the OC pills for a longer time, you will going to harm them. You are going to not achieve, you will achieve the good cohort of the follicles, but at the end you will end up into causing the age of the menopause will be a little bit closer in that age group. What is the correlation of the oocyte retrieved and early menopause? If I am stimulating the type A, A group of a person, and those are at 25 years poor ovarian reserves, and the 42 years with the poor ovarian reserves, we know the AMH, we know the AFC, and we started a stimulation in the both the patients. Those are the patients, even if they have the normal AMH, if we compare the group A with the normal AMH and normal AFCs, but at the time of the retrieval, we get the lesser oocytes. These are the particular patients we need to talk about. It's not only a failure of the clinicians to get the higher, lesser number of the oocytes. It is not that our stimulation protocol is wrong. It means that there is something else we are dealing with, and this is something else is like the patient is dealing with the early menopause. The number of oocytes at the age matters. If you see the number of oocytes retrieved and the age on the on the downside, when the patient is young, all of us knows that we should have an ideal age is 20 or 30. The number of oocytes, ideal number of oocytes should be retrieved is 12 or 14 eggs. But in the same age group, if we are going to retrieve the lesser eggs, and if the patient is old, where we are knowing the predictive outcome of the oocyte retrieval rate is low, and she's also giving us a low oocyte retrieval, that means she's a good patient and she will have the menopause at her particular age. But if the younger patient gives us a lower oocyte retrieval, that is called as a FORT, is a follicle output rate. If the FORT is less in the younger or in the normal age group, then we are going to predict the menopause. It is not always a wrong stimulation or abnormal response. It is always gives us some hint that this particular patient may land up into early menopause. The number of age, if you see, this is the there is a black, I can see this is the point where you can have only 5 number of oocytes is here. This is the age of the patient, this is the number of oocytes retrieved. So if my age of the patient is somewhere around 30 31, and only the 5 oocytes or 4 oocytes been retrieved, that means the this is a not a good patient. These are the patients who are likely to go for early menopause. These are the patients who are not giving me a good follicle output rate. Even if on a sonography I've seen a major follicles or good follicles, and the oocyte retrieval rate is low, that means these are the patients are likely go for early menopause. And this is the article in Human Reproduction also in 2003. They compare the groups where they know the follicles are seen on the ultrasonographic scan on a higher side, but actual oocyte retrieval is less, and they compare the age of the menopause in these patients, and they found out that if your oocyte retrieval rate is low, they are the patients who are likely go for early age of menopause. And if you are talking about poor responders, and whether it is really corresponding to the early or menopause, all of us know the pure patient is categorized now into a Positidian group, group 1, group 2, and group 3, and group 4. All these groups are known for their lower oocyte yield. So these are the patients where we need to think a little bit on a different line. If what previously I was talking about is the normal patients with the normal AMH, with the normal AFC, but still we are getting a lesser eggs or lesser oocyte retrieval. In the same patients, if the patients are all this Posidian group, and we are having the lower, we know that the lower oocyte retrieval is going to happen. And then there is a this particular they compare the IVF in a normal responders and IVF in the poor responders, and they found out that there is acceleration of a menopause in the patients, in the POR patients. So we need to talk to the patient when the POR patient come down to us, whether it is young or whether it is old. The chances of them to go into the early menopause is little bit on higher side. So the conclude to my talk is we should think about the strategy of the stimulation. Always not it is our fault that whenever we are going to stimulate the patient and getting a lesser number of oocytes, that doesn't mean our stimulation is wrong. We need to think in a parallel lines. There may be a patient which is going to for early menopause. The patient is coming with the POR. That means that already there is a setting of a menopause is there. We are just trying for stimulation of those patients where we are knowing the aneuploidy rate is on a higher side, but still we are going to stimulate her. But on the back of our mind, we know the patient is going to go for early menopause. The age advances, there is aneuploidy of the oocytes which sets up and which will also predict the age of the menopause. So the stimulation, IVF stimulation per se, will not cause early menopause, but this will can predict for the patients, those who can have prediction about the menopausal age, and where we can talk about it. Thank you very much.
Thank you, Dr. Ashish, for a very nice, well informative talk on the menopause. Now, I call upon Dr. Madhupriya, who completed her MBBS from Tanjavur Medical College, DNB from Apollo, Diploma of Gynec Laparoscopy in Apollo, Fellow Reproductive Medicine at Triple M, and best accolades to her best papers, posters, and a lot of publications is done, and also co-author of a UI book. And her special interests are biological hair for poor ovarian respiration and onco infertility. Now I call upon Dr. Madhupriya to talk on the HIV positive male and female. Dr. Madhupriya.
Good morning, madam. Good morning, everyone. At the outset, let me thank the TAPISAR organization, Dr. Professor Sanjeev Reddy sir, Madam Kamala Selvaraj ma'am, and thank you, Vijaya Ganesh ma'am, for that such a good introduction too. Thank you very much, everybody. And getting into the topic today given to me, it's about tackling the ART situation in HIV, male and female. I'm starting this share screen. In 1990, the CDC recommended against the use of any reproductive assistance to the HIV serodiscordant couple, thinking that it is the only way in which the horizontal and the vertical transmission of HIV can be aborted. Since this, in 1990 until 2002, a group of European physicians actually experimented with more than 3,000 inseminations after appropriate sperm washing technique and found that there were no seroconversion which happened in the uninfected female partner. This observation led the ASRM to think about the use of reproductive assistance in the HIV concordant as well as discordant couple. Since 2004, when the European Ethical Task Force and in 2010, the ASRM Ethical Committee agreed to the above guidelines, there was a new set of revised guidelines made by ASRM which suggested risk reduction strategies in the reproductive treatment of HIV concordant and discordant couple, and thus now HIV couple can still have reproductive assistance to have or beget their own reproductive biological progeny. Before going ahead with the risk reduction strategies, let's see about the transmission risk percentages. The transmission risk of HIV in general per contact is 1 by 1000. And this is high when the vital load of the infected partner is more than 10,000 copies per ml. It's important to note here that even in the HIV discardant couple, the transmission of HIV from male to female is more compared to female to male transmission, with an average of 0.3% of risk transmission per contact, while the risk of transmission with anonymous contact increases from 3.1 to 8.2%. Let's see how HIV and infertility are correlated. Apart from the systemic problems which can be caused by the antiretroviral group of drugs leading to infertility issues, HIV per se can lead to early gonadal aging, both in the female and in the male, with early ovarian aging and early testicular aging leading to primary gonadal failure, and the sexually transmitted infections, which are high in these group of people, leads to tubal factor, tubal infertility, increased risk of tubo-ovarian abscess in female, and orchitis and epididymoorchitis, which can be acute to acute or chronic in men. And apart from these, sexual dysfunction in male in the form of erection and ejaculation issues can all lead to infertility in HIV couple. Apart from these, even when they conceive naturally, there are challenges to the mother, which is begetted during the pregnancy, childbirth, and parenting, which are told to them during the preconceptional counseling. And many of them, about 43% in an Australian study, found that they wantedly went ahead with a termination of pregnancy. Coming to ART in HIV concordant couple where both male and female partner are HIV positive. It is of course important to assess the fertility potential of both of them because of the chances of primary gonadal failure due to HIV per se, and the combined ART treatment to the infected partner or partners is essential. Periconceptional use of combined ART has come a long way in reducing the risk of HIV transmission, and this has resulted in a very negligible risk of HIV superinfection or HIV-resistant virus co-infection. Coming to HIV discordant couple where the male partner is HIV positive and the female partner is uninfected, there lies importance of giving combined antiretroviral therapy to the infected male partner to keep the CD4 count on the higher average and to barely minimize the amount of HIV viral load. And also the use of pre-exposure prophylaxis with a combination of emtricitabine and tenofovir, which is called the Truvada. This has helped a long way in preventing the uninfected partners in the serodiscordant couple. Combined with these, sperm washing techniques done appropriately reduces the risk of HIV transmission to less than 0.1%. Whenever the normal tube and normal semen analysis are encountered, an appropriate sperm washing technique along with an IUI is recommended. No recommendation nowadays on the sexual intercourse which is timed and without the use of barriers. And tubal occlusion and the presence of severe oligoasthenoteratospermia can be tackled with sperm washing appropriately to reduce the HIV viral load, followed by IVF or ICSI procedures. Use of sequential density gradient, the Percol's technique followed by the swim-up technique, is accepted as a standard protocol to decrease the risk of HIV transmission. And checking the post-sperm washing semen with a PCR test for HIV RNA helps to identify that nearly 99.9% of the infection is removed. Alternatives to these would be donor insemination and adoption techniques, which of course we need to compromise on the biological gametes. So here, the aim of treatment in HIV discordant couple will be to keep the CD4 count more than 350 cells per microliter, and to decrease the HIV viral load to a bare minimum, though at least less than 10,000 copies would be comfortable, and use of Truvada as a pre-exposure prophylaxis is highly helpful with guaranteed 90% reduction in the HIV transmission in those who are at risk of HIV transmission through sexual activities and 70% reduction in the HIV transmission risk in those who are at risk of acquiring HIV through the shared needle techniques. So this needs a lot of compliance from the uninfected partner with daily pre-exposure prophylaxis with daily tablets of Truvada. Coming to the HIV in discordant couple where female partner is HIV positive and the male partner is uninfected, apart from the combined antiretroviral therapy to the female partner and the pre-exposure prophylaxis with Truvada to the uninfected male partner, it is also important to give them a lot of conceptual, preconceptional counseling to understand that not only is there a horizontal transmission risk, which is not completely eradicated, and there is still a risk of vertical transmission from the mother to the baby, though use of elective cesarean sections and avoidance of breastfeeding have come a long way to decrease the risk from 30 to 35% to less than 2%. But still, the risk is not eliminated. This needs to be counseled to the couple. So, the strategies to reduce the risk of HIV transmission would be to give either an IUI or an IVF and ICSI according to their fertility history, and to avoid timed sexual intercourse, which was previously allowed for the reproductive assistance, and avoidance of breastfeeding to decrease the vertical transmission from the mother to the baby, and the use of tenofovir with emtricitabine combination, that is tenofovir plus emtricitabine given as a pre-exposure prophylaxis. The Truvada as a daily tablet prophylaxis helps to decrease the risk of transmission to the uninfected partner. Coming to the heart of fertility treatments, the lab. Of course, safety matters here not only on the safety of one's own gametes, but also safety in avoiding transmission of HIV to other patients' gametes. And the safety of the lab personnel is also important. And there are certain safety precautions that needed to be followed as an SOP to avoid needle stick injury and the splash injuries due to HIV. From many studies, it is found that appropriate universal precautions when observed, such as use of appropriate PPEs, periodic decontamination of the surfaces and the place where the workstation is there, appropriate biomedical waste disposal, and an appropriate hand washing technique themselves lead to no special expertise or equipment needed further to avoid HIV risk transmission. And it is found that the risk of infection of HIV in those who have had a needle stick or a splash injury has been less than 0.3% when universal precautions are followed. That emphasizes us on the use of universal precautions in all the conditions. Specific precautions that needs to be followed to avoid the HIV transmission risk is, of course, proper disposal of biomedical waste from the lab, avoiding mouth pipetting technique, use of closed centrifuges for the semen preparation in order to avoid the splash injuries, separation in both space and time, such as scheduling the HIV positive patients at a different time to give an undivided attention to them, and to take time to completely sanitize the workstation before working on the gametes of the other patients. And also separating the space, physically a separate area for these people to collect the sample, processing of the risky samples within a biosafety cabinet can all help to reduce the risk of transmission. And it is indeed important to have separate frozen storage for the HIV infected semen, even after special sperm washing technique and viral check prior to cryopreservation. Storing of these samples in liquid nitrogen vapors instead of the liquid nitrogen per se, and use of the double bagging method where the infectious waste cover doesn't come in contact with a clear surface. This will help prevent direct contact of the cryo containers with the liquid nitrogen cylinders. So avoiding mouth pipetting as shown in the figure and use of suction bulb or automatic pipette helps to reduce the risk of transmission in the lab personnel. Appropriate disposal of the hospital waste, which is segregated and then coded in the appropriate bags, will help a long way in preventing the transmission of the HIV infectious waste. And use of closed centrifuge in the semen treatment or processing, either for the IUI or for the IVF or ICSI treatment, to avoid the splash injury and risk to the lab personnel. And storing separately the frozen samples to avoid the risk of transmission to the gametes of the other patients who are uninfected. And the use of the double bagging technique as shown here. Here, as we can see, this lady is in a clean surface. This person who is appropriately PPE donned, this healthcare worker takes a contaminated bag from the infectious person and puts the contaminated bag into the clear bag which is held by the other co-worker. This person does not touch the infected bag. This person will not come in contact with a clean bag, and use of this double bagging techniques has been helpful in preventing the transmission of infection through the infectious wastes. Of course, before making any informed reproductive decisions, the HIV couple need to have an appropriate preconceptional counseling regarding the chances of transmission from one partner who is infected to the other who is uninfected, the chances of vertical transmission to the baby from the infected female partner, though the risk is bare minimum with various studies proving the same, there is still an element of doubt because it is not completely eradicated. Apart from this, the risk that the lady can have systemically because of use of combined antiretroviral therapy for the long time, and importance of taking a pre-exposure prophylaxis daily tablet of Truvada by the uninfected partner, and the consistent use preconceptionally and periconceptionally of the highly active antiretroviral therapy, and the liaison with the HIV physician or the infectious disease consultant throughout their pregnancy and in the pre-pregnancy stages and throughout their reproductive treatment is a long way important to make informed reproductive decisions. Thank you very much for the opportunity.
Dear delegates, you can post your questions in the question and answer thing, so that after the end of the session, we'll take up our question and answers. You can get your good answers from our expert speakers, whatever you want.
Thank you, Dr. Madhupriya, for a very good information on HIV patients. Now I call upon Dr. Tamilarasi, the MD-OG from Stanley Medical College, former senior resident of JIPMA, and former associate professor of Department of Reproductive Medicine Surgery, Sri Ramchandra Medical College and Research Institute. Now currently she is consultant in charge of Suha Well Women and Fertility Center. Right. Dr. Tamilarasi, I welcome you to the APISA meet.
Good morning. I'm just going to share the screen. Good morning to all of you. I thank the organizers for giving this wonderful opportunity. Thank you, ma'am. Thank you, Vijay, ma'am, for the nice introduction. The topic is ART and hepatitis B and C virus carrier couples. Madhupriya has really helped me to I mean, she has helped, she has eased my job. So it's going to be a repetition. The aim of the management of this couple is to give birth to a healthy baby without any perinatal transmission and without contaminating the partner or other patients through cross-contamination. The learning objectives of this presentation is going to be pre-IVF counseling, evaluation of both the partners, and methods to reduce viral load before ART, and reduce the cross-contamination in lab, embryo transfer, antenatal management and antiviral therapy if necessary, involving the hepatologist, birth dose vaccination for the baby to reduce the mother-to-child transmission, and long-term follow-up of the infected partner. That has to be with the hepatologist. Coming to pre-IVF counseling, when the patient comes to you for ART, we should reassure them that the pregnancy is not contraindicated unless there is a compromised liver function or acute exacerbation. We should insist to them that IVF is done when the viral load is low. If the viral load is high, we have to involve the hepatologist to reduce the viral load before ART. We need to get informed consent, informing them about the available evidence and the risk of transmission, and the risk of transmission to the partner. The partner is not immunized, or if the partner is negative, that's a discordant couple. So we need to counsel them, and we have to take the consent from the couple. Counseling and education concerning the safe sex practice, especially when the couple is hepatitis C, the partner is hepatitis C positive, and the male or female partner is negative. They need to follow this advice. In hepatitis B virus patients, the partner is till the partner is vaccinated, they need to follow the safe sex practice. Need to involve the multidisciplinary team involving the psychologist, hepatologist, and obstetrician for the better management of these couple. Hepatitis B virus is a DNA virus. It's one of the major causes of liver disease. It causes both the vertical transmission as well as horizontal transmission. It occurs in acute and chronic forms, but what we are going to take is only inactive form of chronic carriers. Hepatitis B infection is 100 times more infectious by parental exposure. So the precautions, whatever Dr. Madhupriya has mentioned just now, has to be followed. When the infertile couple comes, we need to assess, we need to take a proper history and review all investigations. And then we need to know the status of the partner, whether the partner is vaccinated, is the center equipped to handle such infective cases, whether the medical staff or laboratory staffs are vaccinated, and the risk of, whether they have any ways to reduce the vertical transmission to the baby. It's very important. So the infertility center has to have a safe operating protocol, to minimize, either to minimize or eliminate the risk of transmission. Coming to the effect of hepatitis B virus on sperm, this has been proven beyond doubt that hepatitis B virus has adverse effects on human sperm motility by affecting the sperm mitochondrial potential, and also affects the fertilizing ability of the spermatozoa. And hepatitis B virus integrates with the sperm genome and causes lots of aberrations, especially decrease in the morphology in these patients. These adverse effects may also apply to the oocytes and embryos with integrated HPV DNA sequences. See, this article which was published by Rini et al. In 2011. The article was published in Fertility Sterility, which raised lots of concerns. The study concluded that the sperm and oocytes act as a vector for the vertical transmission of infection to the embryos. So this gave lots of fertility specialists whether to go ahead with the treatment or not to. The same authors published again in 2016, and the author concluded that the presence of hepatitis B virus surface antigen in oocytes and embryos may not result in vertical transmission of hepatitis B virus in the offspring. They used fluorescent in situ hybridization to detect the presence of HPV genome in the human embryos, but the fish was not able to detect whether it produces infected virions or not. But the babies born with hepatitis B positive virus oocytes or embryos, which is transferred, they did not carry the virus following birth. They did not become chronic carriers. So the study says that integrated genome may not produce fully competent virus or infected virions in human embryos. So this may not be the cause for perinatal transmission. So there is a good evidence to support if the male partner is positive, female partner is vaccinated, the sperm wash to reduce the hepatitis viral load is unnecessary. But before ART, we do a sperm wash procedure before ICSI. Coming to the investigations, you need to evaluate this patient, whether they have normal liver function, hematology, blood clotting, whether are there any evidence of a liver cell injury. These patients, like usually the hepatitis B surface antigen positive, whether these patients are having active viral replication or not, that has to be checked. Test for hepatitis B virus replication. So you need to give hepatitis E antigen and serum anti-hepatitis E antigen. So if E antigen is negative, anti-hepatitis E antigen, that is antibody to hepatitis envelope protein is positive, that means the patient is in inactive stage of chronic carrier state. When you quantify hepatitis B virus DNA, if it is less than 2000 international units per ml, that is 10,000 copies per ml, and persistently normal ALT, SGOT and SGPT level, then we can go ahead for ART in these patients. And then we need to test for co-infections like HIV, hepatitis C virus, and HTV, because hepatitis B virus, like in 25% of the time, it's a ghost virus. It cannot replicate alone. The hepatitis D virus needs hepatitis B virus. So the risk of, these patients, viral co-infections has to be checked. Ultrasound to look for normal level parenchyma and look for any evidence of portal hypertension. HPV DNA quantification is very essential in the evaluation of patient with chronic hepatitis B virus. It also helps to assess the efficacy of antiviral treatment. Real-time PCR can also be used, which is which is highly sensitive. It can detect even 25 to 50 copies of HPV DNA per ml. So, we can utilize real-time PCR technology. Risk of perinatal transmission with the hepatitis B virus is not different. ART conception and natural conceptions are not different. In natural conception, 2 to 15% risk of perinatal transmission is there if only hepatitis B surface antigen is positive. When the patient is in active replicating state, that is rises to 80 to 90% if hepatitis E antigen is positive and HPV viral load is more than 1 lakh international units per ml. This can be effectively prevented by immunoprophylaxis for the baby within 12 hours of birth. But the efficacy of immunoprophylaxis, that is immunization failure, happens when the woman has high viral load. The infection is prevented by, as I've already mentioned, the partner has to be vaccinated. The vaccination, whether the partner is vaccinated or not, can be assessed by asking for hepatitis B virus surface antibody titer. If the titer is 10 or more than 10 milli international units per ml, that means the partner is immunized. All laboratory staff has to be vaccinated. Hepatitis C virus is RNA virus. It affects 1% of the global population. And in 90% of the cases, a CV RNA is positive. The viral load is above 10,000 international units per ml. So we need to quantify, again, hepatitis C RNA before taking the patient for ART. Hepatitis C virus is an RNA virus. It cannot integrate with the host genome, so to cause chromosomal instability. So usually doesn't. Sperm parameters are not affected in HCV infections. That's what, when I reviewed the literature, I found blood contamination. So when we do a oocyte retrieval, there's a blood contamination, so that increases the viral load. Rinsing the oocyte seems to discard the CV RNA. Hepatitis C virus receptor is not found on the oocyte, but on the granulosa cells surrounding the oocyte. So deloading the oocytes would really reduce the viral load. The risk of perinatal transmission with HCV again increases when there is a co-infection with HIV, and also when there is a RNA, when we do a quantification, if HCV RNA is positive, the infection rate increases to 11%. There is no vaccine available for HCV virus. So it's very difficult to reduce the HCV infection for the baby. So how are we going to reduce? There's a current treatment option is available, directly acting antiviral therapy with PEG interferon alpha and ribavirin. It is 90%, 98% effective in achieving sustained virological response within 8 to 12 weeks of treatment. That means almost complete cure for these patients after following 12 months of treatment. So this has to be recommended for all patients who are having HCV, SCV, RNA positive patients. Ribavirin is teratogenic, so washout period of 6 months has to be given before ART. Antiviral treatment has to be started only by the hepatologist. Hepatitis C virus, chronic hepatitis C infection in women could alter both preantral follicle and granulosa cell function. So so that leads to increase in the demand for FSH during ART. So during oocyte retrieval, less number of oocytes retrieved and decreased number of fertilized oocytes. Once oocyte is fertilized, embryo does not appear to be affected. So the pregnancy rate is not affected with HCV infection. This is a IVF lab protocol. This is going to be a repetition. So when the patient comes for retrieval, post the patient at the end of daily workflow. So we are to reduce cross contamination, culturing the gametes and embryos in separate incubator to isolate the patient in space. Cut away the granulosa and cumulus cells and wash the oocytes thoroughly in sterile media to dilute the viral titer. Move the oocytes to a new dish and with the fresh media and proceed with ICSI and embryo culture. Universal precautions has to be followed. So I'm not going to repeating it. Wipe the surfaces after the retrieval with 6% hydrogen peroxide followed by distilled water. Elective single embryo transfer is recommended to reduce the risk of higher than multiple pregnancy, because these patients, like when we have to go for fetal reduction. So any kind of invasive procedures has to be reduced so elective single embryo transfer is preferred. Freeze and store in separate tanks according to the virus. So closed vitrification is used to avoid direct contact of cryo containers with the liquid nitrogen. Coming to sperm wash procedures, double density gradient centrifugation is used, followed by sperm swim up to step. This is a same technique. This is a technique which is followed in all infected patients to separate motile spermatozoa from free virus and HCV, hepatitis B virus infected somatic cells. We need to use double gradient centrifugation. We can also use double tube method with the use of product called ProInsert. Here, the second tube that serves as a channel to retrieve the pellet from the bottom of the tube following centrifugation, so that it avoids the contact with the contaminated leukocytes or free virus. It is not necessary to perform nested PCR to detect HCV RNA or HPV DNA in the final swim up. The nested PCR is nothing but it's a specific DNA amplification specific to that particular virus. Density gradient and washing MESA or TC samples followed by ICSI appears to suppress the hepatitis C virus detection in final suspension. How do you reduce the cross-contamination in liquid nitrogen? The cross-contamination from liquid nitrogen has been proven. So use of specimen containers guaranteed by the manufacturers to withstand the freezing temperatures and thawing cycles has to be used. And use of double bagging or sealing technique to prevent direct contact of cryo containers with the liquid nitrogen. Again, storage of sample in liquid nitrogen vapors instead of liquid nitrogen itself. The use of sperm washing technique to decrease the viral load before freezing semen sample. How are we going to decontaminate the cryo tank? Use of 1% bleach to decontaminate the tank after the use. Coming to antepartum care, hepatitis B virus pregnancy has to be followed with regular HPV DNA quantification and liver function test. If the viral load is more, appropriate antiviral therapy, especially lamivudine, has to be given involving the hepatologist. Treatment should be initiated 28 to 30 weeks of gestation and continued for 3 months postpartum. Cesarean section is only for maternal indications, like fetal distress, like maternal indications. Breastfeeding is not contraindicated. So following birth, this is a part which is very important. All infants should receive immunoprophylaxis within 12 hours of birth, which includes both active and passive immunization. Active immunization with hepatitis B virus vaccine and passive with immunoglobulin, which has to be given 12 hours of birth, followed by 2 more injections of HPV vaccine in the first 6 months of life. So between 9 to 15 months of age, these infants has to be called for like evaluation, whether the babies are infected or not infected. So we have to ask for hepatitis B surface antigen as well as antibody to hepatitis B surface antigen. If HBsAg antigen is negative and anti-hepatitis B surface antigen is positive, that means the baby is infected. It's not going to be a chronic carriers. So like for adults, 1 to 2 months after the last dose of vaccine, we need to check the antibody titer. Hepatitis C virus peritoneal transmission is increased when there is a co-infection with HIV and when there is a high viral load and when we do invasive procedure during antenatal period. This has to be avoided. Cesarean section for delivery is not recommended. Breastfeeding is not contraindicated when the viral load is low. So in conclusion, those studies show chronic viral hepatitis as a possible cause of infertility and female suboptimal response in ART. There's no significant difference in live birth when compared to seronegative couples. IVF is done when the viral load is low to reduce the maternal complications and to reduce the mother-to-child transmission of infections. Thank you all very much for patient listening.
And Dr. Tamlasi, it was hepatitis B, hepatitis C, and all HIV, all these infections are very much, the topics on this are very much needed for day-to-day IVF practice. And both
can you stop sharing, please? Tamlasi can, okay.
So this was a very nice talk chosen by our secretary. Now we move on to next session, next speaker. Dr.
One second, dear delegates, you can post your questions. You will get your answers after this talk. And also you can download your participate certificates after 1 p.m. today up to evening. Okay, proceed, Dr. Vijay.
Yes, sir. So now the next topic is on the patients with autoimmune disorders. And the speaker is Dr. Jaspreet Kaur. She's a fellow of reproductive medicine, consultant in Milan Fertility Center, Chandigarh. She's editorial member of Onco Fertility Journal and reviewer of IGAI-FM, the Onco Fertility Journal. And she's a member of ASRM, ISHRE, IFS, ISAR, IACG, and Aspire, and executive member of FPSI. She's authored and co-authored a number of chapters in various speech and reproductive medicine, presented many papers at national and international conferences. Now I call upon Dr. Jaspreet.
Thank you, ma'am, for the kind introduction. At the outset, I'd like to thank the organizers for giving me the opportunity of being here. So without wasting much time, I'd like to start my topic. So the topic which was given to me was the patient with autoimmune disorders. So autoimmune disorders basically refers to a varied group of more than 80 chronic illnesses which involve almost every human organ system. And it is basically the body's immune system which becomes misdirected and attacks the very organ it was designed to protect. Now, why are we talking about autoimmune diseases here? Is because 75% of them occur in women and almost 70% occur during the childbearing age. Now, why women with autoimmune diseases might need ART? Now, that is because women with autoimmune diseases do have chronic inflammation, which leads to a dysfunction of the HPO axis. In many of the systemic autoimmune diseases, there's presence of anti-ovarian antibodies, which can decrease their ovarian reserve. The presence of antiphospholipid antibodies has been postulated to cause microthrombi in the ovarian vein, which can decrease the blood flow, leading to a decrease in the ovarian reserve. Also, if there are lupus flares, they are associated with hyperprolactinemia, which can lead to anovulation. And in many cases, there's generation of antibodies against the corpus luteum, which can lead to corpus luteal dysfunction. Also, majority of the women with autoimmune diseases are often on drugs like NSAIDs, and NSAIDs, specifically the selective COX-2 inhibitors, when taken in the pre-ovulatory phase, can lead to a luteinized unruptured follicle, though the effects are transient and reversible. Also, if glucocorticoids taken in a dose of more than 10 milligrams per day is known to suppress the HPO axis and trigger apoptosis of the ovarian cells. Now, cyclophosphamide is usually avoided these days due to the other alternatives available, but at times needs to be given in patients who have severe flares, and we all know that it brings about a burnout phenomena by triggering follicle activation and inducing apoptosis of the oocytes and granulosa cells, and the effects are irreversible. There are also other reasons for decrease in fecundity per se in women with autoimmune diseases because of a delay in planning conception, because the disease has been in the active phase, or they have a fear of disease-related pregnancy complications. And there are also other physical impediments to sexual activity like vaginal dryness and joint stiffness. Now, for us as reproductive endocrinologists, it is very important to understand when to enroll a patient with autoimmune disease for ART. Now, the American College of Rheumatology in 2020 has stated that women with uncomplicated autoimmune diseases who are receiving pregnancy-compatible medications and in whom the disease has been quiescent or stable for at least 6 months can be enrolled for ART. Also, we need to offer fertility preservation for women with autoimmune diseases at times. For example, if they are receiving gonadotoxic drugs, which is mainly cyclophosphamide in this case, and if these patients are at a risk of age-related ovarian reserve exhaustion. Now, next, I'll be talking to you about certain commonly encountered systemic autoimmune diseases that we come across in our day-to-day practice. So to top the list is SLE. Now, here it is important for us to understand that fertility in women with lupus in general is similar to that of the general population, except when these patients have severe flares or they have lupus nephritis or they have a premature ovarian failure secondary to chemotherapy or a decreased ovarian reserve. Now, studies have postulated that yes, though these women do not have a decrease in fertility, but fecundity can be lower because women with SLE do have a poorer ovarian reserve in comparison to control, regardless of the activity of the disease. So also it is very important for us to understand when not to intervene and when not to offer ART in women with SLE. So if the disease has been, if the patient has had a flare in the past 6 to 12 months, or if they have a badly controlled arterial hypertension, pulmonary hypertension, an advanced lupus nephritis, or if they have severe valvulopathy or a major previous thrombotic events, then they should not be offered ART services. Now, coming on to antiphospholipid antibody syndrome, it is a very controversial topic. Now, there were initial studies that suggested that women with lupus anticoagulant and anticardiolipin antibodies have a higher incidence of unexplained infertility and a poorer ART outcome, but recent studies have found to refute this. But yes, there are studies that suggest that women with antiphospholipid antibodies and antiphospholipid antibody syndrome do have a lower ovarian reserve in comparison to the healthy population. Now, this was a meta-analysis of more than 19 studies done by an Italian group, Chigizola et al., and they stated that while awaiting definitive conclusions on the relationship between APL and infertility, rheumatologists need to counsel these women to safeguard their fertility. Now, next is rheumatoid arthritis. Now, women with rheumatoid arthritis per se do not have a lower fertility, but yes, maybe a lower fecundity because of the prolonged time to conception in these women, since they are normally on drugs like NSAIDs and prednisolone, and they too have a lower ovarian reserve in comparison to healthy controls. And also, they have physical impediments to sexual activity because of chronic joint pain and other sexual dysfunction issues. So basically, I'd like to say that due to the necessity of well-controlled disease before conception and a decrease in the ovarian reserve, which is commonly associated in women with autoimmune disease, the time to pregnancy needs to be optimized in these women, and infertility investigations need to be commenced after 6 months of failed natural attempts. So if the patient is planned for an ovulation induction with IUI, it is preferable that we use aromatase inhibitors like letrozole, because these women per se are going to have high-risk pregnancy and we cannot complicate it further by giving them multiple pregnancies. So with letrozole, there's going to be a monofollicular development. The E2 levels are going to be lower, and therefore this prevents flares and decreases the risk of thrombosis. If, however, the woman is anovulatory despite giving letrozole, we can add low-dose gonadotropins. Now, if the patient is planned for an IVF-ICSI cycle, then adding letrozole with gonadotropins to lower the E2 levels has been found to be safer, like we do in hormone-responsive breast cancer patients. Then cycle segmentation needs to be done, which is an intact cycle with an agonist trigger, a freeze-all policy. To prevent, we need to take all steps to prevent OHSS in these women. Now, these women are often on immunomodulators and corticosteroids, which need to be continued during their ovarian stimulation, and anticoagulants need to be added at the start of stimulation if they have APL positive antibodies. If the woman is in need of urgent fertility preservation and we need to do an IVF cycle for them and the disease is in the active phase, then doing it in a natural cycle or a modified natural cycle or an IVM seem to be good alternatives, though their value will be limited. Then, as I mentioned, frozen embryo transfer is to be preferred, single embryo transfer to prevent the risk of multiple pregnancy in this group of women. Also, FET should be preferably done in a natural cycle. If, however, she is having anovulatory cycles, we can use letrose to form a follicle. If, however, an ET has to be done in an HRT cycle, it is preferable that we use natural estrogen through the transdermal route, and for luteal phase support, natural progesterone through vaginal route seem to be a safer option. Now, surrogacy can be offered to these patients if there's an absolute contraindication to pregnancy, like pulmonary hypertension. So what are the risks of fertility treatment in women with autoimmune disease? Well, they are at a higher risk of thrombosis, especially patients who have positive APL antibodies and a previous history of thrombosis. Now, the risk of OHSS per se is not higher, but the complications due to OHSS, like thrombosis, are definitely higher in women with autoimmune diseases. And there's also a risk of exacerbation of the autoimmune disease, especially if the disease has been poorly controlled and there's been a poor adherence to immunomodulatory therapy. So these are case reports which do scare us. For example, a case of a cerebral infarct in a patient with antiphospholipid antibodies and OHSS, and intracardiac thrombosis triggered by ovulation induction in patient with antiphospholipid antibodies. So what are the strategies that we need to encompass to prevent these complications? Now, the ACR 2020 guidelines have recommended that we enroll a patient for an ART cycle only when the disease is in the stable or remission phase. We need to continue all the immunomodulatory therapy. We assess her APL and APS status. If it is negative, we proceed with ART. If, however, she has positive antiphospholipid antibodies or a history of obstetric APS, we need to start them on prophylactic low molecular weight heparin during the ART procedures. And if she has a history of thrombotic APS, then therapeutic anticoagulation needs to be offered. So if the patient has to be offered prophylactic anticoagulation, the ACR guidelines suggest that we start enoxaparin 40 milligrams daily at the beginning of ovarian stimulation, and we withhold it 24 to 36 hours prior to oocyte retrieval, that is at the time of trigger, and then we resume it following the trigger until the E2 levels have returned to near physiological levels. Now, this is very important that we continue anticoagulation post the pickup as well, because there have been case reports in which cases have been reported of thrombosis because the patient stopped the anticoagulation post the OPO. Then for therapeutic anticoagulation, they've suggested that we give enoxaparin 1 milligram per kg every 12 hourly, again to be withheld 12 hours prior to the pickup and can be started 6 to 12 hours after the OPO. If the patient is taking low dose aspirin, it needs to be stopped 3 to 5 days prior to the pickup. Immunosuppressives like HCQ need to be continued, and the ACR guidelines recommend against an empiric dose increase of prednisolone during the ART procedure in patients with SLE. Instead, they suggest that we monitor the patient carefully and treat for flares if it does occur. Now, what are the fertility preservation options for these women? Now, GnRH agonists, though the efficacy is debatable, but yes, they have been used in many cases. And this was an American study done by Somers et al. And they stated that if started 2 weeks prior to cyclophosphamide, every cyclophosphamide pulse, it does decrease the incidence of POF from 30% to 5%. But we all know that the efficacy of GnRH agonists is still debatable, but it's the simplest thing that we can offer at times. Then oocyte and embryo freezing is the most efficient option, but then there are risks of aggravation of the autoimmune disease because of the supraphysiological E2 levels, and it requires around 10 to 12 days and cannot be offered in prepubertal women. Now, OTC, though still considered experimental, seems to be a feasible option in some of the cases in which there is a risk of exacerbation of the autoimmune disease and in prepubertal age and can be performed urgently. For men, sperm cryopreservation prior to starting cyclophosphamide is the easiest thing and should be offered to all men who have autoimmune disorders. Now, coming on to the effect of drugs on fertility, I've talked about NSAIDs, glucocorticoids, and cyclophosphamide. I'd also like to emphasize that drugs like methotrexate, MMF, and thalidomide need to be stopped at least 3 months prior to enrolling a woman for ART because that is the minimal washout period required for them. Also, biological disease-modifying drugs like TNF-alpha inhibitors, etanercept, and certolizumab are coming up in a big way in patients with, especially with rheumatoid arthritis, because they are found to have a very low transplacental passage. Now, HCQ is the main drug that we are using in almost all patients with autoimmune diseases, and they need to be continued during the ART treatment because they are known to decrease the disease flare and reduce the dose of glucocorticoids. So in the end, I'd like to conclude by saying that yes, women with autoimmune diseases might have an effect on their fertility through disease and drug-related mechanisms, and therefore infertility investigations need to be commenced after 6 months of failed natural attempts. ART to be offered only in patients in whom the disease has been in the quiescent stage and the patient is on pregnancy-compatible medications and is often offered for fertility preservation as well. A GnRH intact protocol with an agonist trigger and cycle segmentation with a freeze-all policy needs to be followed. Now, these patients are not at a higher risk of OHSS, but they are definitely at a higher risk of OHSS-related complications like thrombosis. FET, when attempted in these women, should preferably done in a natural cycle, and patients who have APL antibodies or antiphospholipid antibody syndrome should receive anticoagulation during ART treatment, and counseling these patients to adhere to immunomodulatory therapy to prevent disease exacerbation is very critical. Thank you so much.
Yeah, thank you, Doctor. Very informative. We'll proceed with the question and answer session, sir.
Yes, Vijay, you can ask the questions to the speaker.
The first question is from Dr. Radha Venkatachalam, Srivilliputtur. This is my native place. I think her question is to Dr.
This is to the moderator or speaker?
Speaker, sir. It's though she's from my place. So this is to the speaker. The question is on HIV patients. I think with Dr. Madhupriya. How long will it take to get PCR report? That is the question. PCR report for the HIV patients. Yes.
The rapid testing, the rapid antigen or antibody testing can be obtained within 30 minutes, though the false positive rates are going to be high. but it takes at least 24 to 48 hours to get an actual report. So in the event that the washing of the semen happens and they have to go ahead with IUI or with the IVF or ICSI, it would be better if they can go ahead in such patients with processing of the semen sample and checking it for HIV load and make sure that it is negative and cryopreserve the sample for use during the IUI or the IVF or ICSI egg collection process.
Hope it's clear enough, Dr. Radha. The next question is from Dr. Sashireka Kumaran. The question is to Dr. Tamilarasi. Can we give PRP treatment in HBsAg carrier?
There's no contraindication for PRP, injections for hepatitis B virus carrier patients, because if you follow universal precautions and if you're doing, then there is no contraindication for that.
Then second question also for you. It's from Dr. Rashmi Vora, Chennai. Does the dose of immunoglobulin given to the babies in mother with HBV positive differ according to viral loads of mother? Means it's if very high the titers are there, so we need to give higher dosage of immunoglobulin to the baby.
It's not based on the viral load, it's based on the body weight of the baby. For the 3 kg baby, 100 international units given as IM injection is able to neutralize hepatitis B surface antigen. It's based on the body weight. For 3 kg baby, 100 international units per ml is given as IM injection. The dose may be repeated after 1 month if zero conversion doesn't happen. I think I've answered the question.
Meenambal Nagarajan. Can you ask?
Yes, sir. Meenambal Nagarajan.
You can ask.
Okay, sir. So this question is for Dr. Ramesh. It's post-CA ovary treatment with oocyte preservation in hand. The appropriate time for restarting ART is when? Question is that post-cancer ovarian treatment with oocyte preservation in hand, what's the appropriate time of restarting the ART?
No, once generally we will tell that we will wait for the effect of the time of the chemotherapeutic agent to wean off. So depend on the chemotherapeutic agent per se, whether it is persisting in the circulation, whether it depends on the half-life and the pharmacokinetics and dynamics of the particular chemotherapeutic agent. But generally, for the well-being of the health of the patient as well, we will generally delay the treatment for 6 months to 1 year. So usually after 1 year only, we will think of starting the treatment. By that time, even the ovary would have got some time for rejuvenation, and we might be even able to get some oocytes from this fresh oocytes. If at all we are not able to use it, we can go for the frozen treatment cycles.
That's one question from me, sir. If the cancer is genetically transmitted, would you like to do a embryo biopsy and then do the transfer PGD?
Genetically transmitted cancer, if especially family history of cancers and the known mutations, then that mutations might be transmitted to. If you are able to pinpoint this distinct to a known gene, then we can go for the proposed pre-implantation genetic testing. But as such, right now it is not being widely practiced. But still, there's a scope that we can go for pre-implantation testing to identify whether the embryo is having that genetic mutation. But the problem is that suppose if all the embryos are having that mutation, then we are left in a position where we won't be able to transfer any embryos. Even if there is a mutation, there is not 100% chance that the baby will be going to have the cancer in the future. So it is we need to see the both sides of the coin and then go for the advanced techniques. Even if so many techniques and technologies are available, it may be still having limited scope in the present scenario.
Thank you, sir. And one more thing, it's to Dr. Tamilarasi. What I noted from you is an interesting point. See that HCV virus is an RNA virus, so it will not incorporate into the oocyte. So I think it's a blessing point in case of coronavirus being an RNA. I don't think it will enter into the oocyte, as we are all in the fear of RNA COVID infection, except it may infect the personnel who's been exposed to the patients if they are corona positive. So I think it should help.
It's reverse transcriptase for the
Yes.
attachment into gene.
So that's the gene. So maybe
Information.
we need more studies, and maybe next time we should discuss on this. I will put on to Dr. Reddy sir.
Okay.
Sir,
Ashish,
can we
one
close
question
this?
to you.
Yes, sir.
So with each stimulation, there are so many oocytes we will be losing. So how many, suppose a patient comes and asks you, how many cycles of IVF? There is no problem at all with money. So most of the times we will be stopping 1 cycle, 2 cycle, 3 cycles. No. Suppose there is no problem with the money, how many cycles you can advise a patient to for IVF or ICSI? Is there any time limit? Is there number of cycles?
Sir, the literature, if you go through the literature and the review, what actually they pointed out that the oocyte maximum number of oocyte that required for optimum pregnancies to carry on is 15. So those
Okay, this is decreased ovarian reservoir patient, you think?
Sir, in a decrease, what I gone through the literature, what they quoted to us is like whenever we are going for the stimulation in POR patient, for that matter, it's a maximum of 2 or 3 stimulations will be sufficed, because later on the chances of aneuploidies will be on a higher side.
In Israel, the state is funding the IVF program. So we have one Thailand, one this EOFOG conference. No, there we were talking when the speaker has come from Israel. He was telling like 28 cycles for one patient he has done. Like this, even though like 2 or 3 cycles maximum, after that, even if you go and do the like that, the number, the pregnancy rate will be very less. That is what we know.
Yes.
But they have given like this because state is funding. They're doing. I thank Dr. Vijaya, the moderator, and the speakers, Dr. Ramesh, Dr. Ashish, Dr. Tamilarasi, Dr. Madhupriya, and Dr. Jaspreet for your wonderful talks and making this session a memorable one. Thank you all. We'll go to the next session.
Thank you. Thank you, sir.
Thank you, sir.
Yes, sir. Thank you, sir.
Thank you, madam.
Thank you, all the speakers.
I'll request Dr. Sarath Batina to take over this podium and conduct proceedings of the next session.
Sure.
Can you see Sarath slides?
Dr. Reddy? Start my video, na? What to do now? Yeah.
No, just you see I projected Dr. Shalu Gupta's.
I know, yeah. So shall
just, you can introduce her and ask her to speak.
Yeah, sure. Thank you. Good morning, everyone. And I thank Dr. Reddy for giving the opportunity to moderate this session on IVF in special circumstances. And these conditions are not uncommon, but we do come across in our practice. And the various speakers are, the eminent speakers are lined up for this session, and they're going to explain to us about the physiological changes happening during the IVF procedure, the impact of these physiological physiological changes happening during IVF procedure on the existing pathologies. So the first topic will be on renal transplant patient and IVF by Dr. Shalu Gupta. So a brief about Dr. Shalu Gupta will be, and she's a reproductive medicine specialist and associate director at Cloud9 Hospital, Gurugram. And she is the joint secretary for Indian Fertility Society of Haryana chapter and co-convener for special interest group for poor ovarian reserve for Indian Fertility Society. Her interests are poor ovarian reserve, recurrent implantation failure, and PCOS. She presented papers in various national and international conferences and she's a eminent speaker. And I request Dr. Shalu Gupta to take over the session. Dr. Shalu Gupta? Hello?
Shalu, you can share. Shalu, unmute your mic. Unmute your mic.
Sir, you unmuted my mic, sir.
Okay.
Thank you, Dr. Sarath. I'm sharing my screen now.
Yeah,
So,
please.
1 second. I think you can see my screen.
Put in the slideshow mode.
Yes, sir.
Okay, okay, yes, perfect.
So I like to, at the outset, like to thank the organizers and Dr. Reddy for giving me this opportunity. Today, I will be speaking on renal transplant and IVF. So, sorry. So, what is the effect of CKD on reproduction? We know the chronic kidney disease, the pregnancy is very rare. It is only 0.3% because of high maternal and the fetal morbidity. CKD also leads to infertility, which is multifactorial. It affects the male as well as females equally. There is sexual dysfunctions because of the stress, psychological, and lots of them, which is almost 55% in these patients. Because of the abnormal GNRH pulses, which leads to hyperprolactinemia, elevated FSH and LH, both in the males and the females, can lead to anovulation as well as decrease in the sperm quality. Plus, these patients are highly anemic. It has been found that the patients with the chronic kidney disease have a high risk of premature menopause, almost 4.5 years earlier than the general population. Plus, the patients on peritoneal dialysis may have a high risk of tubal damage due to dialysis-related peritonitis and the risk of the damage to the ovum because of the hypertonic dextrose. Luckily, all these symptoms improving post-renal transplant, the pregnancy rate increases. 1 second. The pregnancy rate increases from 0.3 to 15 to 12%. Transplant restores the balance of the hypothalamic and the pituitary axis, improves anovulation within 1 to 2 months, and improves the sperm motility, but not the sperm count and the morphology in the male. In a study, they found in 665 kidney patients who were surveyed that 24% suffered from fertility problem. So immediate post-transplant, we need to give a patient a contraceptive advice because the transplant, the kidney needs to be stabilized for a year before we can offer them a fertility. Direct contraception, because of the high failure rate, are not to be given. We can offer these patients progestin-only pills or low estrogen progesterone contraceptives provided their hypertension is controlled. IUCD is to be avoided because of the risk of infection as these patients are on immunosuppressive drugs. So once the kidney transplant is stable, the graft is stable, the kidney function is stable, the proteinuria is stable, and they have achieved a level of immunosuppressive drug, we can go plan the pregnancy for these patients. This is the basic pathophysiology which we need to understand what happens and how do we need to treat these patients. Pre-existing kidney disease is an independent risk factor for preeclampsia, prematurity, low birth weight, and neonatal death. However, in the transplant, when happens, the impact of kidney disease on these outcomes is influenced by the degree of renal dysfunction and extent of proteinuria. So we need to have a stable graft patient, that the one who has got a stable kidney functions, to plan the pregnancy or IVF, and pre-existing hypertension. So these patients should have should be on a proper hypertension drugs to make their blood pressure under control. What does the evidence say on effect of the pregnancy on the graft, effect of IVF on the graft, and the risk of the fetus? This is what my next slides will be on. Effect of the pregnancy on the graft. It has been found that the mild kidney disease, if you have, the pregnancy associated with a very little risk of the graft loss. So if the patient has a proper kidney function, that is when do we call it as mild kidney disease? When the serum creatinine is less than 1.5. Anything which is above 1.5 is a moderate kidney disease, which leads to irreversible graft loss and at the time of pregnancy. Hence, we should be avoiding pregnancy in these patients. Pregnancy per se leads to, in the graft patient, leads to a live birth, and live birth does not differ from the non-graft population. If a good functioning graft is present, it does not impact the life or the survival of the patient for next 20 years. The survival rate was found to be 92% at 10 years and 75% at 20 years. During pregnancy, the kidney physician should go for a vigilant surveillance of the immunosuppressive levels is recommended, which increase in the with the increase in the maternal volume, which is related to the pregnancy and hyperemesis. Because of the increase in the hyperemesis, that leads to increase in the glomerulofiltration rate. So we need to make sure that the immunosuppressive drug levels should be maintained at the pre-pregnancy levels during the pregnancy. What is the IVF effect on the graft? Patients, we all know that mainly the secretion of the gonadotropins, 90% happens through the liver and 10% happens through the kidney. So since this 10% which has been excreted from the kidney urine, the gonadotropin may have an enhanced effect in the renal transplant patient due to decrease in the excretion of it. Hence, we need to adjust the drug doses. Access to ovaries may be difficult because of the position of the kidney transplant, which may come in a way when we are doing the pickup. High estradiol levels during the IVF may be led to a higher risk of thrombotic episodes, which may, especially in the patients who have SLE with or without antiphospholipid antibodies. Again, the second iatrogenic complication, the ovarian hyperstimulation, is higher in the patients with the renal transplants. So we need to avoid it because OHSS can lead to internal dehydration, oliguria, and again, it will affect our kidney and leads to graft rejection. Enlarged ovaries, which happens during ovarian stimulation, may cause renal obstruction, again leading to renal dysfunction and oliguria. What is the risk of fetus? We all know these patients who have undergone kidney transplant, they are on lifelong immunosuppressive drugs to prevent the graft rejections. These drugs are potentially teratogenic, which may have a long-term effect on the child in the neurodevelopment. Cyclosporins may be related to cancers, likelihood of autoimmune disorders. It has been found that the gestational age, average gestational age for patients who deliver in the kidney with the kidney transplant is 34 weeks, with 50% having a low birth weight. 30 to 50 children who are born, babies which are born, have IUGR, and 22% have a low birth weight. Hypertension has been found in almost 73% of the kidney transplant patient. Preeclampsia and eclampsia is reported in 27% of the renal transplant patient. GDM, IUGR, preterm, stillbirth, and miscarriages are part of maternal risk in pregnancy with the kidney transplant. These things are all exaggerated, especially if the patient has a nephrotic syndrome or an inherited or acquired thrombophilia because of the risk of thrombosis. Lupus, if active, also carries a risk of miscarriage, preeclampsia, thrombosis, fetal growth reduction, preterm delivery, and stillbirth. So, plus during the pregnancy, the patients who are already at a risk of a UTI, and this incidence increases to by almost 10% in patients with the kidney post-transplant, and this risk of pyelonephritis is increased if the UTI is undertreated in these patients. Plus, there is a risk of cytomegalovirus, toxoplasma, varicella, HIV, primary herpes, and hepatitis B virus during pregnancy because of the immunosuppressive drugs which the patients are on. Anemia is also common in these patients, but we can treat it with intravenous iron or thrombopoietin. What are the commonly used drugs? It has been found that the immunosuppressive agents which can affect the fetal organogenesis and the growth during the pregnancy are corticosteroids, azathioprins, cyclosporin, and tacrolimus. I have put these 4 drugs, and plus after that it is sirolimus and mycophenol myofitil. The corticosteroids, azathioprins, cyclosporins, and tacrolimus are safe drugs. That is, I have put it in the red, which we can continue during pregnancy, whereas sirolimus and mycophenolate mofetil is contraindicated. So we need to change this drug at least minimum 6 weeks prior to patient planning for the pregnancy. Once these drugs are changed to the other safer drugs, corticosteroid, azithro, cyclosporins, and tacrolimus, we need to make sure that the graft is stable, the serum creatinines, the proteinuria is under control. Only then we can plan for pregnancy. Plus, sirolimus also causes male and female infertility. So, if the patient is coming with the total sperm count which is on the lower side, or a female coming with amenorrhea or menstrual irregularities, and we can change sirolimus from to the other safer drugs. Sirolimus is normally generally replaced by cyclosporins. Tacrolimus, if it is given by more than 2 mg per kg per day, can lead to ethinoteratozoospermia. Other commonly used drugs are cyclosporins, tacrolimus, and cyclosporins. When we are giving it to the patients, we need to make sure that during the second trimester, we need to look for obstetric cholestasis because it is known to cause this during the second trimester. Tacrolimus causes diabetes as well as intrauterine growth retardation. Mycophenolate and rapamycin, because of the congenital abnormalities, it is a category extra, needs to be changed at least 6 weeks prior to pregnancy. Tacrolimus and cyclosporin are category C drugs, and steroids are category B drugs. But knowing the benefit against the not using it, we are using these drugs during the pregnancy for the transplant patients. Other commonly used drugs, we need, if they are patients are antihypertensive, we know 70% of these patients have hypertension. If they are on ACE converting enzymes or angiotensin receptor blockers or atenolol, we need to convert them to the safer drugs like labetalol, nifedipine, or thiazide diuretics, which are the drugs of choice. So that because of the side effects of these ACE and the atenolol and the adverse fetal effect on the fetal growth. When do we plan the pregnancy in the transplant patients? As per the American Society of Transplant, a good graft function for at least 1 year or earlier, depending upon the age, because I just told the likelihood of having a premenopause is 4.5 years earlier than the normal population. So if a patient within 6 months is having a good graft function, we can go for an early planning of pregnancy. And we need to make sure that the protein secretion function is optimal, less than 15 milligrams for 24 hours, and serum creatinine less than 1.5 milligram. But in this, the chances that the kidney transplant or the graft is rejected is very low and minimal, and plus the complications are going to be less. So this is a function which we look for. If these are go, then there is a go ahead for the kidney transplant. There should not be any concurrent infection. Use of medication like MMF and rapamycin has been changed, and immunosuppressive dosage is at a stable and maintenance level. What about the males? If we are going for the IVF for the male indication, there has been no recommendation by the American Society on the regard to the post-transplant interval of fathering a child. So males can, once they are transplant, they are going on the drug stable, they can go ahead and go for a IVF. What are the management options? So we need to do a thorough counseling before we plan a IVF to ensure that the couples are aware about the risk involved when they are going for the IVF and the risk during pregnancy. This should be a multidisciplinary approach performed both by the obstetrician as well as renal function together. The welfare of the child should be discussed, the risk of handicap, the prematurity, the risk of inherited kidney disease, and the risk which is going in the mind of the couple is basically whether the graft will be rejected, the effect on the kidney, because that is the most precious thing. When we discuss about inherited kidney disease, there are two diseases which are important. One is Alport syndrome and polycystic kidney disease. For both of these, we can offer PGT, the pre-implantation genetic testing for these things. So during the IVF, what we need to understand is need to carefully consider, and the cautious approach is avoided during the choice of a protocol. So the best protocol for these patients are the antagonist protocol. We need to reduce the dosage of the FSH because we do not look for the iatrogenic complication of OHSs, and we need to decrease the OHSs. The gonadotropin releasing antagonist protocol with the agonist trigger, freeze all, and doing a frozen embryo transfer is a choice for these patients. Because plus there are patients who may go for ovum pickup, do making of the embryos, and then instead of transferring the embryo in them, they can opt for surrogacy. In case we have given a HCG trigger, we can use dopamine agonist for the prevention of OHSS. During the procedure of the oocyte revival, because of the position of the grafted kidney in the pelvis, we need to anticipate and plan opioid strategy on the day of the trigger, so that we know what is the kidney coming in a line of a pickup, how large is the ovary, and what are the precautions we need to take. Maintain adequate hydration. The fluids which are going should be adequately monitored. We cannot overhydrate or we cannot underhydrate these patients. Avoid nephrotoxic painkillers. The painkillers should be limited and should be avoided. Patient should, before going planning for an OPU, should have a pre-anesthesia checkup. Let the anesthetist see, because they need to understand what are the anesthesia drugs which need to be given and what needs to be avoided. Go for freeze all and a single embryo transfer, because we cannot anticipate or predict late OHS as prior. Secondly, single embryo transfer, because if we go for twins or a multiple pregnancy, it can increase all the risk of preeclampsia, diabetes, prematurity, lower birth weight, GDM, which is double in the multiple pregnancy. So single embryo transfer is a preferable choice in these patients. And surrogacy, of course, remains a viable option. If the patient do not want to, feels very apprehensive or feels about her graft, the kidney, we can always offer the patient the surrogacy. What about patients with the significant proteinuria approaching the nephrotic region, or inherited or acquired thrombophilia? Consider thromboprophylaxis during ovulation stimulation using the low molecular weight. The rule of thumb is basically thromboprophylaxis if indicated antenatally, that is, if you're planning to give thromboprophylaxis to any patients during the pregnancy phase, then it should be also considered during IVF. Although, as Jasneet said, that we need to omit it around the oocyte retrieval period. So any patients who has an indication of thromboprophylaxis during pregnancy should be started with thromboprophylaxis during the IVF stimulation protocol also. So with this is being my last slide. Yeah. So what is the take-home messages? Ensure thorough and pre-pregnancy counseling and a workup prior to IVF. IVF, if an embryo transfer, is a safe procedure in a female with a kidney transplant. So plus we need to avoid our two iatrogenic complications which we have, that is OHSS and the multiple pregnancies. So as long as we avoid this and we are able to take care of it, it's a safe procedure for these patients. To avoid OHSS, we need to start with the lowest dose of gonadotropin. Do not overstimulate these patients. Do an antagonist protocol. Do an agonist trigger and freeze all. Provide adequate thromboprophylaxis. Have a strategy and anticipate difficulties during the oocyte retrieval prior and make a plan for it. Aim for a single embryo transfer and a surrogacy. Do a genetic counseling for inherited renal disease patients and offer them PGT. So with this, I have one more slide here. So this is how we normally plan to do a pregnancy checkup for the patients. So we need to do a urine culture for each visit, CBC every 2 to 6 weeks to make sure that they are not anemic. Do creatinine, the proteinuria, calculate creatinine clearance, calcium, phosphorus as and when required. Liver function test needs to be done every 6 weeks. Do GTT every trimester, because these patients are at a high risk of GDM. Tests which are specific is IgM to toxoplasma, IgM to CMV in each trimester if seronegative because of the congenital infection. And in case there is a graft rejection, then I think renal physician can go for the renal biopsy. So this is a chart which will help to what are the pre-pregnancy and the evaluation during the pregnancy. So with this, I end my talk and thank you. Thank you, Dr. Saru.
Yeah, thank you, Dr. Shalu Gupta, for the wonderful insights and beautiful explanations on pregnancy.
Can you stop sharing, Shalu?
Yes, sir.
So the next topic will be the patient with thyroid disease by Dr. Kanimoli. So a few words about Dr. Kanimoli. Dr. Kanimoli is a...
Just 1 second, sir.
Yeah.
Shalu, can you stop sharing?
Yes, yes, I'm just doing that, sir.
Thanks, Dr. Shalu.
Yes, sir. So just 1 second, sir. Stop sharing.
The button will be the upper part, red. Okay, okay. Okay. Sarath,
Shall I go ahead? Yeah.
Yes, yes.
The next topic will be the patient with thyroid disease by Dr. Kanimoli. It's a pleasure to introduce Dr. Kanimoli because I'm proud to say she's the first qualified reproductive medicine specialist in India, and at presently she's a senior consultant in reproductive medicine at Apollo Hospitals, and she did her MCH Master of Surgery from Ramchandra Medical College, and she had finished her clinical embryology also from Monash University, Australia, and she has presented many papers both in national and international conferences, and especially she did FSH receptor of polymorphisms in ART. And we all know that thyroid disorders, both hypo and hyperthyroidism, will affect the fertility, and many a time we will not be able to understand how they affect the fertility. So Dr. Kanimoli is going to explain to us, or giving us the reasons how they affect the fertility. Dr. Kanimoli.
Sarath, she is not the specialist, she is super specialist.
Yeah, yeah, I agree with you, Dr. Reddy.
So can you see the slides?
Yes, yes.
Very good morning. Thank you, Shratha, for the introduction. I thank my teacher, Dr. Sanjeev Reddy, for this opportunity. And I wish all fellow women a very happy Women's Day. Today, I'm going to talk on the patient with thyroid disease. The importance of thyroid hormones has been highlighted ever since the discovery of TSH, its receptors, as well as thyroid hormones on the ovarian surface epithelium in oocytes of primordial, primary, and secondary follicles. Thyroid hormones seem to participate in complex regulation of ovarian function. Thyroid hormones may also influence the fertility aspects in an indirect manner, altering the gonadotropin releasing hormone secretion and prolactin secretion and SHBG levels and coagulation factors. Epidemiological data have shown the prevalence of thyroid disorders in women of reproductive age. The incidence of hypothyroidism ranges between 2 to 4% and it's largely attributed to thyroid autoimmunity. Subclinical thyroid anomalies, including subclinical hypothyroidism, hyperthyroxanemia, and or isolated TAA are much more frequent than clinical thyroid dysfunction. In women with TPO abnormalities, the relative risk of female infertility is increased. So what is the role of thyroid in reproduction? Basically, the thyroid hormone has role in every reproductive organ. Right from the oocytes, it has the T3 is in combination with FSH enhances the granulosa cell proliferation, and it causes the granulosa cell apoptosis by P13K AKT pathway. And the thyroid hormone transporters and receptors are always expressed in the ovary. In sperms, it affects the motility and morphology, and the count depends upon the type of thyroid disorder, either it's a hypothyroid or a hyperthyroidism. In fertilization and embryogenesis, it is associated with lower fertilization rates and embryogenesis. In endometrium, the deiodinases, the thyroid THRA and THRB receptors are expressed in the endometrium, and there is evidence on direct effect of receptivity lacking. Implantation, it stimulates the production of progesterone in the granulosa cells and upregulates the leukemia inhibiting factor. In placentation, T3 increases the expression of matrix metalloproteinases, fetal fibronectin, and integrin 5-1 beta 3 in the early placental extravillous trophoblasts. So thyroid dysfunction as such, we all know either it is hyperthyroidism and hypothyroidism, but autoimmune thyroid antibody is a totally different entity. So there are multiple hormonal changes which happens hormonal changes happens in thyroid disorders, both in males and in females. Out of that, the most important what I would like to touch upon is what happens during stimulation is the FSH levels and LH levels. There is a drastic difference in FSH and LH levels during stimulation in a hypothyroid or a hyperthyroid patient. And the menstrual disturbances which are common in thyroid disorders also, it can be both in hypothyroidism and in hypothyroidism. This was a study which is published in Endocrine Reviews in October 2010. So first to review this article, this was an article which was published in Reproduction Genetics in 2011. This study stated that serum prolactin and TSH in an in vitro fertilization population, is there a link between fertilization and thyroid function? This study stated that women with TSH level had significantly higher among women who produced oocytes that failed to fertilize, and this findings persisted adjustment of several covarieties, including sperm motility. So there was a statistical difference in the number women who had conceived. They have performed poor with IVF stimulation with a thyroid disorder. So to conclude, this study concluded that TSH may predict poor fertilization in IVF and reflect the importance of thyroid hormones in oocyte physiology. Then coming to hyperthyroidism, thyrotoxicosis increases the HSBG levels and serum levels compared to euthyroid women. The latter may result from an increase in SHBG or increased E2 and androgen production combined with an increased conversion ratio to estrone and estradiol. In addition to that, LH secretion is increased in Graves' disease, and compared to euthyroid patients, hypomenorrhea, polymenorrhea, oligomenorrhea, hypomenorrhea, and most prevalent menstrual abnormalities. Moving on to hypothyroidism, the hypothyroidism results in a number of hormonal changes. It increases the plasma binding capacity of SHBG. It increases the concentration of total testosterone and estradiol, and it causes a blunted LH response, and thereby stimulating the thyroid hormone releasing hormone secretion and increasing the serum prolactin levels. The prevalence of menstrual abnormalities is almost 25 to 60% in hypothyroid women. The predominant menstrual disturbances is oligomenorrhea. And the association of subclinical hypothyroidism and infertility is not consistent with the literature. Still, many studies are happening to decide on the ideal dose of TSH values. This can be partly explained by different cutoffs using to define the upper limit of normal of TSH concentration and lack of well-designed prospective studies. It's simple to see why ovulatory disturbances happens in the hypothyroid disorder is in hypothyroidism and autoimmune thyroid diseases. There is disturbances in the GnRH secretion and abnormal pulsatile release of LH, as I already told. There is a high release of TRH, which leads to hypergalactonemia. There will be increased ovarian volume and stromal spots. There will be altered peripheral estrogen metabolism, and there will be defects in hemostasis. All of this contribute to ovulatory disturbances and will ultimately lead on to anovulation. As I already told you, subclinical hypothyroidism, and again, is not. It's much more less comparable. It's more comparable to an overt hypothyroidism. What is basically about subclinical hypothyroidism? There will not be any symptoms of hypothyroidism. The TSH levels will be elevated. The T4 levels will be normal. The incidence is about 4 to 8.5%. Thyroid autoimmunity is another entity. It is the most frequent autoimmune disorder of women of childbearing age and increases the risk of thyroid dysfunction. The prevalence of thyroid autoimmunity is generally estimated about 10% and has been shown to be more common in women. So, many patients with PCOS have found to have increased having a prevalence of thyroid antibodies. The possible explanation of this is maybe due to a polymorphism in the PCOS related gene of fibrillin 3, which influences the activity of transforming growth factor beta, a key regulator of immune tolerance. So euthyroid autoimmune disease and infertility, because they will be also mimicking a state of subclinical hypothyroidism. Usually, as I already told you, it affects about 10 to 20% of women. What are the problems associated with autoimmune thyroid disease? There will be increased miscarriage rate, the decreased oocyte fertilization rate, decreased pregnancy rates in women, and there will be presence of thyroid autoantibodies in the follicular fluid. When we aspirate the follicular fluid, when you can see the presence of thyroid autoantibodies. And endometriosis and polycystic ovarian syndrome women are more prone for autoimmune thyroid disease, and there is chances of premature ovarian failure with autothyroid antibodies. What are the possible mechanisms of autothyroid antibodies causing infertility? Autothyroid antibodies is associated with impaired cellular and humoral immune responses. There is increased natural killer cell concentrations in women with unexplained infertility. There is no significant differences will be noted in cytotoxic activity of the natural killer cells. It has been suggested that the presence of thyroid antibodies and increased TSH increases the interleukin-2 production and interleukin-2 mediated natural killer cell activation, which ultimately leads to repeated reproductive failures and miscarriages. That's why in patients with repeated autoimmune thyroid disease, we see recurrent implantation failure and miscarriages. This was a study which was published in 2007 in Clinical Embryology, which stated that many studies have been combined, and what they said was there is a high risk of infertility in patients with autoimmune thyroid disease, which is almost statistically significant. And this was the same. There's another study which was published in 2011 in Human Reproduction Update, which stated that 334 patients with autothyroid antibodies and along with 1,679 controls. In an antibody positive women, subfertility occurred more frequently. So it is proven that women with thyroid dysfunction have more chances of developing infertility. So this was another study which was published to say that women had been treated with thyroid have performed well in ART and they have been able to achieve pregnancy with thyroid medications. So it is always, and they have said that it is always advisable to measure thyroid function and detect autoimmune thyroid disease in infertile women before ART and follow these parameters after COH and during pregnancy, because we usually tend to do the thyroid levels and check every 6 to 8 weeks apart to maintain the levels of TSH to a desirable level. So subclinical hypothyroidism and infertility, there is high chances of infertility. And the prevalence of subclinical hypothyroidism is considerably higher in studies based on TRH stimulation tests. So whenever a patient walks into our clinic with an infertility problem, it is always a routine part of workup. Thyroid disorders has to be ruled out. What are the tests for thyroid disease? We know that free T4 and TSH is used for both diagnosing hyperthyroidism and hypothyroidism. Free T3 in cases of suspected thyrotoxicosis. TSH alone is enough for follow-up. We don't have to repeatedly do it again and again. The free T4, TSH is enough. And there is no role for total T4 and total T3. So radioimmunoassay, third generation or fourth generation, is the one routinely used for diagnosing thyroid disorders. Chemoimmunorescence immunoassay is also done, but it is very specific for free T4. So the free T4 normal range is between 0.7 to 2.1 nanograms per deciliter. TSH is 0.3 to 4 milli international units per liter. But what we desire is 2.5 milli unit liters for achieving pregnancy and to treat infertility. What does the 2017 guidelines of American Thyroid Association say for diagnosing management of thyroid disease? They say evaluation of serum TSH concentrations is recommended for all women seeking care for infertility. Thyroid antibody testing is not routinely done because we don't do it for all women. What we see is only free T4 and TSH. But what the recommendation says that the American Association of Clinical Endocrinologists say that repeatedly TSH values is more than 2.5. But also when there is a history of any miscarriages as well as subclinical hypothyroidism that is between 2.5 to 2.4, it is always better to do a thyroid antibody testing. How do we treat hypothyroidism and ATD? Both of them has the same medication. We have to go for levothyroxine, that is LT4, 1.6 micrograms per kilogram per day, given on empty stomach. Repeat the TSH values at least 6 to 8 weeks intervals, and adjustment of dose accordingly has to be done. There are certain stages where we can increase the dose. Elderly women will require a lesser dose when compared to a women of young age. Malabsorption, concomitant drug therapy, lactation will almost increase about 25% of the requirement than a regular supplementation of an infertile patient. So this in the cases of malabsorption, concomitant drug therapy and lactation, we have to increase the dose by at least 25%. So this was a study which was published in 2017. In this study, subclinical hypothyroid women undergoing IV fixie has significantly lower, already I have discussed this again a slide in a different article. They have lower fertilization, lower implantation, significantly higher pregnancy rates compared to euthyroid women. So this was a meta-analysis which almost they have meta-analysis of three trials. This said that levothyroxine treatment resulted in significantly higher delivery date with relatively pooled relative risk and significantly lower miscarriage rates with pooled relative risk of 0.45. And again, this was again a guideline which was published in 2017 Thyroid Journal. This said that euthyroid but TPO or TG antibody positive pregnant women should have measurement of serum TSH concentrations performed at pregnancy confirmation and every 4 weeks through mid-pregnancy. And ATA guidelines of pregnancy and thyroid disease have also said that levothyroxine may be considered in euthyroid and thyroid antibody positive women who are undergoing ART, given its potential benefits in comparison to minimal risk. So it is always better in cases of euthyroid antibodies, if there is positive, it is always better to go for a small dose of levothyroxine so that it outweighs the risks when compared to in terms of pregnancy. So what happens when we go on what happens when we do a controlled ovarian stimulation on a patient with thyroid disease? Usually controlled ovarian stimulation causes a rapid increase in plasma estradiol concentration. Hence, the impact of controlled ovarian stimulation becomes more severe. So we need to increase the dose of levothyroxine earlier and to a great extent in these women in natural pregnancies. Almost please do remember that when we stimulate a patient who is a hypothyroid with the controlled ovarian stimulation, there is almost a one time increase of the thyroid levels. So we have to increase the dose of thyroxine when we start them on a COH. In case she is not pregnant following a controlled ovarian stimulation, serum TSH measurement should be repeated in 2 to 4 weeks because the levels may normalize. So effect of levothyroxine, this was another study which was published in 2011, effect of levothyroxine in pregnancy outcome. This was a prospective randomized control trial. In this study, 64 infertile patients with subclinical hypothyroidism, that is, they've been defined as elevated serum levels of more than 4.5. Please do remember this cutoff is not 2.5 to 4. Associated normal free T4 and without frank symptoms of hypothyroidism. The interventions they were divided into control group and levothyroxine group. The levothyroxine treatment group, they were given with 50 micrograms of levothyroxine from the first day to control day of stimulation. What they found out was the levothyroxine treated group had significantly higher number of grade 1 and grade 2 embryos, embryo implantation rate and live birth rate, significantly lower miscarriage rates. So this study stated that levothyroxine supplementation also improves the quality of embryos we are going to get. And subclinical hypothyroidism and autoimmune thyroid disease with ART. This was a study which was recently published in 2018 in Reproductive Biology and Endocrinology. This study stated that women who had been treated with levothyroxine had a lesser chances of miscarriage rate and lesser chances of preterm birth. So this was again published in 2017. This was a guideline. Women undergoing IVF-ICSI should be treated with levothyroxine. The goal of treatment to achieve the TSH concentration should be less than 2.5. So any women planning for IRT, the TSH should be less than 2.5. If not so, we have to supplement them with levothyroxine. And levothyroxine may be considered in women with subclinical hypothyroidism who are attempting natural conception, given its potential benefits in comparison to its minimal risks.
Dr. Kanimoli,
Sir.
One more minute, no? Yeah. One more minute. Time is up.
Yes, sir. I'm going to finish, sir. Management of hypothyroidism in a nutshell, women of infertile couples do a TSH and thyroid antibodies, as I already told you, it's not mandatory. If a TSH is more than 4, start them on levothyroxine, follow up for about 4 weeks, 4 to 6 weeks. If the TSH is between 0.3 to 4, do a thyroid antibody. If it is positive, then again start them on levothyroxine supplementation. If TSH is less than 0.3, rule out hyperthyroidism and then check the TSH after ovarian stimulation. This is a recommendation of the ITS and Foxy Society of 2019. This is a type evaluation, type 2 and type B, type level 2 evidence. It says the serum TSH concentration is recommended for all women seeking care of infertility, and it's recommended for all women with levothyroxine, recommended for all women with overt hypothyroidism, and levothyroxine should be considered in women with subclinical hypothyroidism. And please, women undergoing ART should be treated with levothyroxine if subclinical hypothyroidism is noted. And euthyroid women, antibody positive women also, levothyroxine levels should be levothyroxine should be considered. Just to touch upon hyperthyroidism, we have to think of the drug therapies available are propylthiouracil and methimazole, but propylthiouracil is preferred prior to IVF and at least up to 3 months of pregnancy. And male infertility, to touch upon, usually it has multiple changes. Both hyperthyroidism and hypothyroidism leads to infertility. The concentration, the density, morphology, erectile dysfunction, everything happens usually with male infertility. To summarize, thyroid disease is a common condition in reproductive medicine. Hyperthyroidism and hypothyroidism can have adverse effect on reproductive health and adverse pregnancy outcomes. There is increasing evidence for the role of autoantibodies in subfertility and early pregnancy loss, even in euthyroid women. Evidence suggests that treating thyroid disorders and keeping TSH levels at a lower end of normal in euthyroid women may improve conception rates in infertile women and reduce early pregnancy loss. Thank you.
Thank you, Dr. Kanimoli. Thank you so much. No? So we'll be moving on to the next topic. So you can close this one, no? Yeah, so that the next speaker will take on. Yeah. The next topic will be the patient with heart disease by Dr. Pavitra Tanikachalam. Dr. Pavitra, you are there.
Thank you.
Pavitra? Dr. Pavitra?
Sir, can you hear me, sir?
Yeah. You're there, no? So, shall I go ahead? Yeah. A brief about Dr. Pavitra. Pavitra is a reproductive medicine specialist at Chettinad Super Specialty Hospital. And presently, she is the Vice President for the International Fertility Research Foundation and Executive Committee member for Indian Medical Association at Kelambakam branch. And she's the editor for Chettinadu Health City International Medical Journal. And she is the consultant obstetrician and gynecologist and infertility specialist at Manasa Women and Fertility Clinic, Kelambakam. She had a brilliant academic career and she won many gold medals during her academic career. And her area of interest will be subfertility and polycystic ovarian syndrome. Dr. Pavitra, you are going to talk on the patient with heart disease. Yeah, go ahead.
Thank you very much for the kind introduction, sir. At the outset, I would like to thank the TAPISAR team for giving me this opportunity to present on heart disease in ART. I will just share my slides first.
She's your daughter?
Yes, sir. That's my daughter.
Good, she is.
Thank you, sir. So today I will be talking on ART in patient with heart disease. So we know very well that we have a lot of guidelines for heart disease, women with heart disease and pregnancy, but we still do not have guidelines about ART in these women. Though these guidelines mention just one blanket statement where pregnancy has to be contraindicated in women with certain conditions. But if women actually seek ART, when are we supposed to, what we are supposed to do for these patients and how should we go about? We do not have any guidelines for these. So I have actually taken few points from various articles and like out of the experience from other specialists, including cardiologists. And I have created this presentation. So I will be talking about, I will give an introduction to heart disease, then about the relationship of heart disease and pregnancy. What are the options available for these women? What are the things that we should take care of during ovarian stimulation? The different procedures that we have to do in ART and their implications. How do we prevent complications? And also important details about heritability and ethical aspects. So congenital heart disease is considered as the most common birth defect. And now we see that the rate of adult congenital heart disease has become more because there have been major improvements in the diagnostic modalities, in the medical, surgical and endovascular treatment. And we see that many of these children who have congenital heart disease actually come into adulthood and they would like to have a child of their own. And we know that pregnancy can have an effect on the heart disease and vice versa. So pregnancy physiology, like the hemodynamic changes, the vascular and metabolic changes can exacerbate the cardiac disease. Obstetric pathologies like preeclampsia, hemorrhage, infection and operative complications can again exacerbate the cardiac disease. And there's increased risk of heart failure, arrhythmia and thromboembolism in these patients. Again, the obstetric outcomes, there is increased risk of cesarean section. Fetal outcomes also we should be really clear about. There is an increased risk of preterm birth, low birth weight, fetal congenital heart disease, fetal death or teratogenicity due to specific cardiac drugs. So this is about pregnancy. But when it comes to ART, we know that there are additional risk factors with assisted conception, which compound to the risk of heart disease. Most women who come for ART are women with older age and they may have additional comorbidities like diabetes or hypertension. And with ART, we always have the risk of ovarian hyperstimulation, multiple pregnancy, and preeclampsia. Though I would like to stick to ART for today's topic, I would like to say a few words about pregnancy also. I will not go into much details about pregnancy. So there were not many studies about ART in heart disease women. I was able to find this one study where the author had clearly mentioned that the adverse cardiac maternal outcomes and fetal or neonatal outcomes were more common in women with heart disease who are going for ART when compared to women with heart disease who do not conceive with ART. And he had also said that the prematurity was also more common among infants in this series when compared with infants in a reference ART population. So there were not much details mentioned in this study about the ART, the stimulation protocol or the number of embryos transferred. So these details were not mentioned in this study. Only the only results mentioned were the outcome. So as ART specialists, do we actually have an advantage? Yes. More than obstetricians, we have an advantage where we will be able to counsel these patients preconceptionally. They don't come to us after they get pregnant. So we have time for preconceptional counseling where we can actually explain to them regarding the cardiac risks, the obstetric risks, and the fetal risks involved in pregnancy, going for a pregnancy and ART. So this is the European Society of Cardiology guidelines, where they clearly mentioned about a multidisciplinary, multi-step risk assessment, counseling, and management planning. There are a lot of details here. I've taken a few of these very important details. So preconception counseling is very important when it comes to ART. I was very happy to see like most of these speakers had actually mentioned about preconception counseling at some point of time in their presentation. I think this is the most important part. Both men and women with congenital heart disease, preconceptional counseling is relevant to address concerns on heritability. And we should also encourage women and men to understand health issues that may affect conception and pregnancy. We have to provide information in a frank, honest, and understandable way to the patients. There is no use holding back on information. We have to be frank when it comes to issues which can affect the maternal health. So we have to allow her to make an informed decision as to whether to embark on a pregnancy or not. So the effects of cardiac disease on pregnancy in terms of both maternal and fetal risks have to be explained. The effects of pregnancy on cardiac disease, including the risk of dying or even long-term deterioration, has to be explained. So whether these effects will change with time or treatment, whether it will worsen or it can become less, all these have to be explained. And we should also explain to them about other options like contraception, surrogacy, or adoption. So we have this modified WHO criteria where they have classified these women into WHO 1, 2, 2 and 3, and 3 and 4. So they have given us the maternal cardiac event rate in each of these criteria. And the guidelines say that pregnancy is contraindicated. Modified WHO grading of 3 and 4. And in this group, it is relatively contraindicated. So it is not just congenital heart disease, but of late, we may see women with who have also pre-existing coronary artery disease, or women who come after acute coronary syndrome because of the delayed pregnancy these days. So again, there are very few studies here, and the studies have shown that the risk is more. And again, the risk depends on the cardiac status of the woman when she gets pregnant. Okay, so the risk of maternal death during pregnancy is often difficult to quantify. For majority of women, studies say that the risk can be less than 1%, but still there are conditions which can have a worse outcome. So any form of conditions like any form of cyanotic congenital heart disease, women with poor systemic ventricular function, severe left heart obstructive lesions, women with Marfan syndrome, especially if the aortic root is dilated, if there is a history of previous peripartum cardiomyopathy, and the most important thing is the cardiac function at the time of conception. So as I said, a multidisciplinary approach is very important, especially when it comes to ART. And we do have time to discuss with the cardiologist regarding the patient's current cardiac status and whether she will be fit to carry a pregnancy and go through the ART procedures. We also have to involve the anesthesiologist even before we start the stimulation, because we have to do procedures under anesthesia. So as I said, the guidelines say that fertility treatment is contraindicated in women with class 4 and relatively contraindicated in class 3 or those who are anticoagulated. So women with, women with these significant medical issues, who desire a biological child, they can undergo IVF with oocyte aspiration, fertilization with their partner's sperm, and embryos transferred to a gestational carrier. So these women have this possibility where they can go for a surrogate. So we also have an opportunity to minimize the risk and optimize the cardiac function of these patients when we see them before we plan for a pregnancy. So we have to discuss with the cardiologist whether they will require any medical or surgical intervention. If there is any arrhythmias, it has to be corrected. Any hypertension or diabetes, that has to be treated. If there has to be some medicine change in the drugs which can cause teratogenicity, those changes have to be made. Anticoagulants have to be managed. If she needs any dental treatment, it is better to undertake it before we go for the procedure. And contraception until all the above cardiac problems have been sorted out, and appropriate contraception is really important till we plan for a pregnancy, till she is considered fit for a pregnancy. And we should never forget about the general pre-pregnancy advice, like including folic acid. And we should also discuss with the patient about the merits of optimizing their weight and being physically fit, both as a prelude to pregnancy, but also for her long-term health. We should definitely discuss about the fetal risks, where the risk of intrauterine growth restriction with cyanotic heart disease is very high. The iatrogenic prematurity is quite common. There can be fetal anomalies. The typical risk say is around 3%, and also the teratogenesis that can happen with the drugs. So still, even when we do, go through all these, there can be rare diseases, or there can be a new cohort of survivors who go to adulthood with surgically modified disease. So even again, in these patients, a thorough assessment of the current cardiac status is very important, and appropriate advice should be given based on how their cardiovascular system is likely to adapt to the physiological changes of pregnancy. So a woman comes with secondary infertility. She has had a previous pregnancy and delivery, but again, one successful pregnancy should not engender the complacency. They still have they still come under high risk women. There can be a high recurrence risk with peripartum cardiomyopathy, and there are conditions which also worsen with age and each subsequent pregnancy. So even without ART, we still have other procedures which can increase the risk, like a vagal reaction during hysterosalpingiogram, which can be dangerous for women with pulmonary hypertension or a Fontan circulation. And pneumoperitoneum and intestinal changes during laparoscopy can also lead to significant hypoxia, hypotension, and hemodynamic instability. We should be aware of all this, and we should make sure such complications do not happen. So coming to assisted conception. So dividing it broadly, we have the ovarian stimulation, we have the transvaginal oocyte retrieval under anesthesia, and the embryo transfer. So I will be talking about each of these. So when it comes to ovarian stimulation in heart disease patients, what we are worried about is the hyperstimulation. In hyperstimulation, when there is a fluid shift and hypotension, and there is increased risk of thrombosis also, where even mild forms of OHSS may be poorly tolerated in women with ventricular dysfunction, left ventricular outflow tract obstruction, Fontan circulation, or pulmonary artery hypertension. So what are we going to do for these women if they go for an ART cycle? We can go for a natural cycle or a mild stimulation cycle. Conventional cycle, definitely the risk of OHSS is much higher. So natural cycle, again, the disadvantages are high cancellation rates, low success rates, and patients may require multiple cycles. We should again be aware of these risks, where high cancellation, and again she will be she may have to undergo procedure of transvaginal oocyte retrieval frequently if we go for a natural cycle, which is again going to be high risk for the patient. So instead, the most appropriate stimulation would be the mild stimulation, where the advantages are low risk of OHSS. Later studies do show a comparable success rates. And if the disadvantage is less number of oocytes, recently studies have very clearly mentioned that less number of oocytes is not a disadvantage. The quality of oocytes and the quality of embryos and the pregnancy rates are good even if there are less number of oocytes with mild stimulation. So mild stimulation for IVF is, this includes both the antagonist protocol and the clomiphene protocol, when clomiphene or letrozole is given along with gonadotropins, very low dose of gonadotropins. And there are various studies which show that the OHSS risk is very low in these patients who undergo mild stimulation, and the pregnancy rates and cumulative pregnancy rates and live birth rates are also good in these patients. Let it be a hyper responder or a poor responder, they find that mild stimulation protocol works.
Pavitra, you have 2 minutes.
Yes, sir. So we know that So with the poor responders and good responders, mild stimulation is good. So that would be the option for us, especially in a heart disease patient. So when it comes to transvaginal oocyte retrieval, we should, the pre-anesthetic evaluation and the risk stratification is very important. A high-risk informed consent should be obtained. The choice of anesthesia, anesthetists opine that it is better to go for an IV sedation and if required, a paracervical block. Spinal anesthesia may cause decreased SVR and hypotension, so it is better to avoid spinal anesthesia. There is no guideline saying that these procedures require infective endocarditis prophylaxis. And if the OT is under our control, then we have to make sure there are emergency cardiovascular drugs available and cardiac equipments which are available to deal with emergencies. So what should we go for when we do an embryo transfer? A fresh or a frozen embryo transfer? Again, if we go for an antagonist protocol and an agonist trigger, if you're worried about the luteal phase defect, then yes, we can go for a frozen embryo transfer. Otherwise, a fresh embryo transfer would be the would be the best thing to do for a heart disease patient, because frozen embryo transfer, we know that the risk of preeclampsia is more. And again, with this, even if you are planning to go for a frozen embryo transfer, choosing a natural cycle frozen embryo transfer or an ovulation induction if required in an anovulatory patient would be a better choice for frozen embryo transfer. We have to restrict the number of embryos because we know that in multiple pregnancy, the cardiac output is going to be even more, and the hemodynamic burden can also be going to be more problematic in heart disease patients. And with multiple pregnancy, we also have the risk of other complications like preeclampsia, gestational diabetes, and preterm labor. So we have to go for elective embryo transfer, elective single embryo transfer, which would be the best option in a heart disease patient. So Turner syndrome, again, though patients can come to us for donor oocyte, still we have to do the risk stratification and involve the cardiologist to decide whether the patient is fit for going for is fit to carry a pregnancy. The risk of heritability also has to be discussed, and in some conditions like heritable iotopathies or certain syndromes, we can go for a pre-implantation genetic diagnosis before transferring the embryos. So coming to the ethical considerations. So sometimes a woman herself may feel that with short life expectancy, going for a pregnancy may not be a choice. But when they come to us to offer treatment, knowing the risks involved in the treatment and pregnancy is ethical, or to refuse treatment on the grounds of risk if the woman is willing to take the risk, we still don't know. So as specialists, what we have to do is we have to do the risk stratification, go for a multidisciplinary approach, preconceptional counseling, high-risk informed consent should be obtained, ART in indicated patients, and in high-risk patients, go for surrogacy. Go for minimal stimulation ART, best is to do a fresh embryo transfer or a natural cycle FET. Go for selective single embryo transfer and pre-implantation genetic diagnosis if we are worried about heritability, and a close antenatal surveillance for all patients. So as I always complete with a Tirukural. So this Tirukural says that we have to, before undertaking something, we have to first know the risks involved with it, and undertaking a thing and then saying that we will consider later, it will be a folly. I would like to thank my mentor, Professor Pandian, the cardiologist, Dr. Shekulingam, and Dr. Dilip Kumar, the anesthetist, who helped me with their inputs. Thank you.
Thank you, Dr. Pavitra, with your simple, elegant, and clear talk. No? Thank you so much. You made it such a dry subject quite an interesting one. Yeah, thank you once again.
Thank you, sir.
I request the speakers to stick to our timings because we have a lot of talks are there. Sarath, you can continue.
Yeah, sure. Thanks, Dr. Reddy. Yeah, the next topic will be the patient with the diabetes. No? Diabetes is not rare these days. We find many diabetic patients in our infertility clinics because of older age couple, increased incidence of polycystic ovarian syndrome. So, diabetes complicating infertility. Diabetes with infertility is a common problem these days, and Dr. Radhika is going to enlighten us on this topic. So a brief about Dr. Radhika. Dr. Radhika is a reproductive medicine specialist and clinical head at Oasis Fertility Vizag. And she did her fellowship in a minimal invasive surgery from World Laparoscopy Hospital. And she's a member of various professional bodies, and her interest in research leads to publishing many papers both in national and international conferences. Dr. Radhika, please take over. Dr. Radhika?
So good morning, sir. I'm just sharing my screen. Good morning, everyone. Thank you, Sharad sir, for the introduction. And I also thank Reddy sir for encouraging young speakers. And I'm very happy to be a part of this program today. So today I'm going to talk about ART in infertility. So coming to the incidence of diabetes in infertility, the WHO estimates that more than 180 million people worldwide have diabetes, and this number is likely to be more than double by 2030. So type 1 diabetes, which predominantly affects the youth, is rising, and the rate is supposed to be at more than 3% per year. So type 2 diabetes is also increasing among children and adolescents, as obesity rates are increasing in both the developed and the developing nations. So coming to the diagnostic criteria for diabetes, it includes, according to the American Diabetes Association, with the hemoglobin HbA1c of more than 6.5%, with the fasting plasma glucose of more than 126 milligrams per deciliter, or the 2-hour postprandial glucose of more than 200 mg per deciliter, or the random plasma glucose of more than 200 milligrams per deciliter. So now talking about how this type 1 diabetes affects the female fertility, it has been shown that patients with type 1 diabetes, they are prone for delayed menarche and menstrual irregularities, especially in those patients who are diagnosed with type 1 diabetes, who are having juvenile diabetes, or who are diagnosed with diabetes less than 10 years of age. They are prone for delay in their menarche. And also in the patients with onset of type 1 diabetes, which precedes menarche, they're more likely to prone to menstrual disturbances like oligomenorrhea and amenorrhea also. So it has been shown that patients with type 1 diabetes, they may have delayed menarche and also prone for premature menopause, which also causes to decrease their reproductive age. Now let's talk about how does this diabetes affect the ovarian function. When we're talking about diabetes, to control this sugar levels in subcutaneous insulin we usually administer subcutaneous insulin. So this insulin, it omits the hepatic first pass clearance of hepatic clearance. This causes hyperinsulinemia. So usually patients with the ovary usually has this insulin receptors on the stroma, the granulosa cells, and the theca cells. So these causes abnormalities in the ovarian function. And also hyperinsulin deficiency can cause decrease in the gonadotropin secretion, which also causes abnormalities in this ovarian function. And also hyperglycemia, it causes abnormal folliculogenesis, and this glucose toxicity causes insulin resistance, and this in fact causes abnormalities of the ovarian function in type 1 diabetes. So now let's talk about the autoimmunity. It has been shown that Hashimoto's thyroiditis is highly prevalent among patients with type 1 diabetes, and it's shown that more than 40% prevalence of thyroiditis is seen in patients with type 1 diabetes. So it's always recommended to do a thyroid testing, should be included for all patients with type 1 diabetes. Autoantibodies directed to ovarian steroid producing cells were found in girls with type 1 diabetes compared to the normal healthy controls. So now talking about the menopause, it has been shown that in type 1 diabetes, it may be associated with higher incidence of premature menopause. And this premature menopause is related to the autoimmunity aspects of this type 1 diabetes. And it has also been shown that because of this insulin treatment, it can cause prolonged hyperglycemia and hyperandrogenism can have this anti-ovarian antibodies. And it has been shown that patients with type 1 diabetes, there's a reduction in the reproductive period for at least more than six years. So it's very common to see male patients with sexual dysfunction with diabetes. There are also many studies which have shown that even in female there is impaired sexual arousal and inadequate lubrication was between 14 to 45% among diabetic women. And also the sexual dysfunction usually commonly seen in females also during the time of ovulation. And this in fact again affects the fertility. So now, can this type 1 diabetes lead to polycystic ovarian syndrome? So with a vigorous insulin treatment, which is given in type 1 diabetes to prevent these complications, this leads to supraphysiological doses of insulin, which in fact it causes hyperandrogenism, and this insulin resistance is also possible seen in type 1 diabetes. So type 1 diabetes patients are also more prone for PCOS condition, and it has shown that PCOS prevalence of 31 to 40% is seen in patients with type 1 diabetes mellitus. So now, does this poor glycemic control affects the ovarian reserve? It has been shown, this recent study which is done in 2020, it has showed that the ovarian reserve, when they compared the ovarian reserve for a patients with a poor glycemic control or a normal glycemic control, they have seen there's a decrease in the AMH levels and decrease in the antral follicle count, usually seen in patients with type 1 diabetes. And this is due to the time of autoimmune damage in the ovaries that is usually observed in patients with type 1 diabetes. So there is also studies which have shown that AMH values are either the insulin therapy, the insulin dose, or the glycemic control were not associated with AMH concentration. So the AMH concentration can be used for all patients to predict the risk and also predict the response for stimulation, even for a patients with diabetes. And the insulin therapy does not affect this AMH concentrations. So now, should we be worried about the oocyte quality while stimulating a diabetic woman? There are studies which have shown that in a patients with diabetes, all these studies are only animal mice model studies, and they have not, even the human studies have still not been done, but these studies have shown that maternal diabetes, it delays the meiotic progression of oocytes and causes mitochondrial dysfunction in the oocytes, and this defects in the oocyte may be maternally transmitted to the embryo and can manifest later as abnormalities in the pre-implantation embryo and causes congenital malformations and even metabolic disease in the offspring. There is a recent study which is done which has showed that when does this hyperglycemia affect the embryo? So if the hyperglycemic exposure of more than 24 hours is toxic to the early embryo development, it is also shown that it affects the implantation rates and also expected to increase the congenital abnormalities and early pregnancy loss. So we should be very strict in controlling the sugar levels, especially during the early embryogenesis. And all these are only mice models, still animal studies, the human studies are still not done. The recent study which is done in 2020, recently in April, this has showed that diabetic and non-diabetic female do not differ in regard to the number of oocytes obtained after ovarian stimulation, oocytes' ability to become fertilized, and embryo development in vitro. So diabetic status during pregnancy and not the preconception effects of diabetes on oogenesis leads to fetal growth restriction and congenital malformation. This is what the recent study says, but previously the many studies which have shown on mice model that type 1 diabetes might affect the oocyte quality also. So now, how does diabetes affect the male fertility? The glucose metabolism is of great importance for sperm cells. Either type 1 diabetes or type 2 diabetes could be detrimental effects on the male fertility, and it affects the sperm quality, such as the sperm motility, the sperm DNA fragmentation, and the integrins of the seminal plasma. So this slide, it shows clearly over here how does type 1 and type 2 diabetes affects the male fertility. They are shown that in type 1 diabetes, especially there is endocrine disorder which causes decrease in the testosterone, decrease in the FSH-LH, and also there is decrease in the motility, morphology, and viability of the sperm. This also causes DNA damage and disruption of the seminiferous tubules, and especially in type 2 diabetes, because of the oxidative stress and the diabetic neuropathy, it is more commonly seen that these patients would have raised DNA fragmentation, and also they are more prone for decreased sexual response, erectile dysfunction, and retrograde ejaculation. And it has been shown that more than 50% of males who are affected with diabetes are prone for diabetic neuropathy, and most of them would have sexual dysfunction. So this study recently has also said that diabetes may affect the epigenetic modification during spermatogenesis, and these epigenetic dysregulation may be inherited through the male genome germ cell, and this can increase the risk of diabetes in the offspring. So here in this study, they have found out the difference between the type 1 diabetes and type 2 diabetes, and they have said that usually patients with type 1 diabetes, because of the altered epididymal voiding causing low ejaculate volume and mitochondrial damage, results in decreased sperm motility. So low volumes and decreased motility is usually seen in type 1 diabetes patients, and patients with type 2 diabetes are more prone for increased DNA fragmentation and cause of increased leukocyte count in the sperm parameters. The next what we have to look into here is patients with urogenital infections. Mostly patients with diabetes mellitus are more prone for urogenital infections, especially we have to screen both the female and the male patients. When we have a patient with diabetes and we're planning for an ART treatment, it is always recommended to do a semen culture to see if they have any infection in the semen and treat the culture report. And again, in a female, it is important to do a high vaginal swab and frequently monitor the urine cultures to check, as the diabetes patients are more prone for urogenital infections. And if it is positive, then they should undergo a combined therapy with antibiotics, anti-inflammatory drugs, and fibrinolytic drugs. And also the partner should be treated if the female partner is affected. So now, does IVF have any impact on diabetes? So once we're planning for an IVF treatment, does it affect the diabetes? So the impact of IVF on diabetes, it has been shown that ovarian hyperstimulation is associated with increase in ovarian steroid hormone production. Such high levels of sex steroids may affect the lipid metabolism, leading to decrease in the cholesterol levels, triglyceride levels, while the HDL-C levels remains the same. But this ovarian hyperstimulation, it causes supraphysiological estrogen and progesterone levels, which can worsen the insulin resistance and hence might induce hypo and hyperglycemic episodes in these patients. So while undergoing an ovarian stimulation, it is very important to maintain the sugar levels with proper insulin treatment. Now, how do we prepare a patient for ART? So once we are planning for ART, so this is the optimized metabolic control from pre-conception through pregnancy can reduce the risk of maternal and fetal complications in women with diabetes mellitus. It is very important to strictly metabolic targets should be that the HbA1c should be from 4 to 6 and not more than 7. The cutoff is around 6.2, which should be maintained for planning for ART treatments of patients with diabetes. And rapid acting insulin analogs like insulin aspart and insulin lispro can be useful because this can reduce the postprandial hyperglycemia without increasing the risk of hypoglycemia and even produce a small improvement in the HbA1c compared with the regular human insulin. So when we're talking about non-insulin dependent diabetes mellitus, oral glucose tolerance tests might be used to evaluate the effect of weight loss and dietary measures. And short-term weight loss have been successful in reducing the insulin resistance and restoring the ovulation and fertility. It is very important to advise patient diet modification and exercise, and also other lifestyle factors including alcohol consumption, psychological stressors, and smoking should be avoided. And insulin sensitizers are widely used to decrease the insulin intolerance. So insulin sensitizers like metformin should be used during the stimulations. And now, how do we manage a patient with male diabetes? A strict sugar control is advised. In the recent meta and systemic review, which was done in 2020, has shown that exercise in patients, in male diabetic patients with diabetes, it has improved the sperm quality, had improved the sperm motility, and also decreased the DNA fragmentation. And it's also advisable to do a semen culture and DNA fragmentation index for patients who are going for fertility treatments with diabetes. Antioxidant therapy has been helpful for these patients, and also there are recent studies which have shown that daily ejaculations can be advised at least 4 to 7 days before an XC for a patient with diabetes to reduce the DNA fragmentation index. And this is a study recently done in April 2020, which they have, it is a prospective cohort study, which they have taken 1,034 women, and they have taken all Asian women around the age of 18 and 45, and they've compared the different tests like the fasting glucose, the 2-hour postprandial, and the HbA1c, and they've checked for the fecundability and the measure the time to pregnancy in these cycles, and it has been shown that reduced fecundability and delayed time for pregnancy, this is particularly evident for increasing in the fasting glucose. So HbA1c, however, is not associated with fecundability, but the results have showed that fasting glucose of 5.1 millimoles per liter or 99 mg per deciliter and above are associated with reduced fecundability and increased time for pregnancy. So the optimal fasting glucose for greatest fecundability, they have noted it has been around 70 to 88 mg per deciliter, and that therefore fecundability started to decrease if the fasting glucose levels are more than 90. So how do we manage a patient with diabetes in the IVF cycle? Metformin is a common treatment for women who have insulin resistance manifesting as non-insulin dependent diabetes mellitus. Both insulin-dependent diabetes mellitus and non-insulin dependent diabetes mellitus, adjustment of carbohydrate metabolism as well as use of insulin sensitizers seems to decrease the amount of exogenous FSH needed in the ovarian stimulation. And also it is important to have a close monitoring of the sugar levels while using growth hormone during ovarian stimulations, and we might need to adjust the insulin levels in coordination with the endocrinologist, especially when we have to need to administer growth hormone in patients with diabetes undergoing IVF. So what precautions should be taken during
Radhika, you can conclude in 2 minutes, please.
Yes, sir. So at least fasting, 4 to 6 hours of fasting, morning dose of insulin and metformin should be avoided, morning CBG should be checked, and proper glycemic control should be there. Proper perineal care and IV antibiotics should be given to prevent infections in these patients. And so the take-home message over here is type 1 diabetes causes shortening of the reproductive age. Counsel patients for early planning to check reserve as it causes autoimmune damage to the ovaries. Testing of thyroid should be done for all patients with type 1 diabetes. Strict glycemic control is advised, especially during the early embryogenesis. And HbA1c around 6.2% should be maintained, not more. It should be always less than 7. Fasting glucose is the reliable testing to detect the time for pregnancy, and it should be around 70 to 88 mg per deciliter. Insulin sensitizers to be used during stimulation, and close monitoring of sugars by adjusting the insulin dosage should be done when growth hormone is administered. Diabetic patients, male patients, semen cultures and DFI to be done, and antioxidants. More studies are needed to prove this, and close watch on the genitourinary infections should be done for patients when treating for ART treatments. Thank you. Thank you.
Thank you, Dr. Radhika. Your talk is excellent, and I can say it's practical and informative. Thank you so much.
Thank you, sir. Thank you very much. Thank you very much for the opportunity, sir. Thank you very much.
Radhika, just stop sharing. Okay. Dear delegates, you can post your questions. We'll have discussion after the last talk. And you can download your participation certificates after 1 p.m. That's it, you can.
Thanks, Dr. Reddy. Yeah. The next speaker will be Dr. Rajapriya Ayyappan. She'll be talking on the patient with estrogen positive cancer receptors. So Dr. Rajapriya, she's a senior reproductive medicine specialist at Srinivas Priya Hospital and Om Fertility Center. And presently she's the secretary for Indian Fertility Society for Tamil Nadu chapter. And she's the executive committee member for FPSI, OXY and ATN RCOG. And she won the Best Doctor Award from IMA in 2018. And she's a member in endometriosis committee for FOXY, and she is the woman wing secretary for PIMA, PIMA, and she's going to tell us about the patient with estrogen positive cancer receptors. And Dr. Reddy is very apt to select Rajapriya for this topic because her husband, Dr. Ayyappan, he's a surgical oncologist, and he'll do the surgeries for breast cancers and hand over the patients for Rajapriya to manage the infertility in them. Dr. Rajapriya.
Thank you so much, Dr. Sharad. That was a very nice introduction in detail, I must say. And thank you, Reddy sir, for this opportunity. Without further delay, I would go into today's topic of how we plan ART with estrogen receptor positive, particularly the commonest cancer, breast cancer. Now, we do understand it's a malignancy which is of concern in the reproductive age group. And in this age group, because of the toxic chemotherapy, there's a loss of fertility. And with today, the oncologist doing a great job. The young survivors on the rise, and with that, there is an expectation for quality of life, which is most importantly attaining motherhood. And that's how oncofertility has become a new specialty, where there are a team of people like the oncologist, the clinician, the obstetrician, the psychologist trying to do their best to help in decision making of these young women affected with breast cancer. Now, does the therapy involved affect the fertility? Ovarian reserve, if you say, per se starts dropping with age, which can be assessed by the anti-Mullerian hormone and the antral follicle count. On top of it, when breast cancer affects the young girl, there's a body image distortion which can lead to some amount of sexual dysfunction. And the chemotherapy can be toxic depending upon the drug chosen by the chemotherapist, the duration, and the number of the dose in which the particular drug is used. The more number of cycles, the more is going to be the damage. So there's a lot of importance given to the chemotherapy-related amenorrhea, and particularly if the oncologist is careful in choosing non-DNA damaging agents, the amenorrhea is less, and even the effect on the follicle reserve is less. And today, with oncofertility on the rise, there's a lot of planning done, not just by the fertility preserving clinician, but also the fertility conscious oncologist. Of course, breast cancer in the past was involved a lot with oophorectomy as part of the management, which was worsening the amenorrhea, which was iatrogenically induced, and a drop in the fertility. Now, if you look at the young woman's future as a quality of life for the surviving cancer patient, the very discussion of oncofertility is a lot of positive energy. It gives her hope, the prospect that she's going to live longer and to become a mother, and it boosts her morale. That's how the American Society of Clinical Oncologists in 2013 brought in a protocol. Whenever you're dealing with a reproductive age cancer, you offer referral for fertility preservation discussion, or at least reproductive counseling. Particularly with breast cancer, all the prognosis is so good in stage 1 and stage 2. It's almost 98.9 and 85.2%, the 5-year survival. So this makes this discussion a meaningful and important discussion. Now, if you look at breast cancer, it's fundamentally an endocrine sensitive cancer. The estrogen plays an important role in breast carcinogenesis. And obviously, in pregnancy, with the rise in estrogen, we are afraid that pregnancy can worsen breast cancer prognosis. So fear of pregnancy is on both sides, on the clinician side as well as on the patient side. And the worry is whether the cancer would recur or it would have a poor prognosis. But with a lot of time, science has now found that pregnancy is not going to have a detrimental effect. The disease-free survival or the overall survival is actually not that major a fear. And even today, things have changed with respect to abortion. So interruption of pregnancy is thought about so much before that advice is given for a woman who is desiring a baby. Now, if you look at 80% of breast cancer, they are estrogen receptor positive, of which 65% are also progesterone receptor positive. So with respect to breast cancer, immunohistochemistry is offered to understand the hormone receptive nature of the cancer. Now, what is the advantage by studying the receptors? We know who is responsive to hormonal therapy. So the adjuvant therapy given is either toxic chemotherapy or endocrine therapy in the form of hormones. And the hormones usually chosen are those which bring down the estrogen level. It's either a selective estrogen receptor modulator like tamoxifen, or a third generation aromatase inhibitor like letrozole. Now, what is the advantage of using hormonal therapy? It reduces the recurrence and death from metastasis. Now, if you look at a 15-year time period, about a less than 15-year-old individual affected by cancer, if adjuvant therapy is introduced, it halves the risk of recurrence. If adjuvant therapy is not used, the risk is somewhere around 50% for the disease to come back again. That is why just by doing surgery, the therapy doesn't end. The multimodality therapy brings in an adjuvant therapy either as endocrine or hormonal therapy. Now, further looking into the whole thing, molecular characteristics wise, 15% of all breast tumors are luminal A and 60% are luminal B, and the rarer types are around 10 to 15%. Now, if you look at luminal A and luminal B, luminal A is where the person has estrogen, progesterone positivity, but no HER2 positivity. But with luminal B, It is estrogen progesterone receptor positivity, but HER2 positivity also, and that's a more faster aggressive growing tumor. Now, based on this, the adjuvant therapy is chosen by the oncologist. Now, adjuvant therapy, as I just said, because luminal A is estrogen progesterone positive, the hormonal blockade is used for a period of 10 years. That's adjuvant therapy you use, and usually it is tamoxifen. This may be used with ovarian suppression, where either GnRH agonists are used or bilateral oophorectomy was advised in the past. But today oncologists have gone back on this. They don't do a routine bilateral oophorectomy whenever it's a reproductive age group. Now, with luminal B, it is mostly the chemotherapy which is given, and this we know chemotherapy is toxic. Now, what happens when chemotherapy is used? A lot of counseling has to be done with respect to the amenorrhea it can cause. A single cycle of chemotherapy can accelerate ovarian aging by 3 years, and you can imagine if a whole regimen is used, up to 10 years ovarian aging can be accelerated. And whenever we give chemotherapy, we can anticipate 3 to 6 months period of amenorrhea. For some group of patients, it can give you premature menopause. So just because the menstruation returns at the end of therapy, we cannot assure fertility. It can still say compromised. So this chart particularly shows that over 60% of them over a period of 6 months will have amenorrhea. Another 30% will have up to a year's amenorrhea. Post chemotherapy this is, and for 7% of individuals, even after completing the therapy 1 year later also, the menstrual cycles don't resume, and this peak problem is where you're going to encounter infertility for sure. Now, what about tamoxifen? Tamoxifen is the mainstay of hormone positive breast cancer. I just said it's a SERM, and it competes at the receptor level in the breast, and it's an endocrine receptor which is cytostatic rather than cytotoxic. That's why we have to understand when we use it long term for around 20 milligram a day to improve survival. If it is around the 30-year-old individual, when you're going to use it for 10 years, she would turn 40 years by the time the therapy is over. So the duration of therapy is of major concern that we cannot improve her fertility prospects. Now, it is also teratogenic, so we always advise contraception when they are on these drugs. And if she's coming off the drug, the washout period is at least 2 months before we plan a fertility rescue for her. Now, what about letrozole? The very company that introduces is not ready to use letrozole for anything related to pregnancy. That's the status of Novartis. However, with a lot of ongoing experience and study, we have found that letrozole has a great role in planning ovarian stimulation modalities for fertility preservation. However, the other side information is when gonadotropin is used by itself, we have a very good response of oocytes, but letrozole and gonadotropin as a combination generally has a reduced number of oocytes for cryostorage. This is a study by Ravelli et al. In 2015, and those who are practicing aggressive fertility preservation know it is a challenge to get sufficient number of oocytes in breast cancer afflicted patients. However, where letrozole scores over is maintains a lower estradiol level, which is obviously an advantage in a estrogen receptor positive cancer. So the clinician is caught on one side by safety issues, on the other side by an efficacious program. Recently, there is more and more thought coming, why not just 8-day stimulation with gonadotropins? Why can't we use gonadotropins alone? Is it such a dangerous situation? However, I would not like to go into that debate. Benedetto showed in October 2020 by a systemic review and meta-analysis, as of today, letrozole is the best bet to be used with gonadotropins whenever you plan stimulation for fertility preservation. Now, fundamentally, is fertility preservation an essential tool for breast cancer afflicted women? Yes, it is, because around 10 to 20% of them fall under less than 40 years age group. The age per se and the pre-treatment fertility potential can decide the need for fertility preservation. And this being a multi-modality therapy, it has to be used to improve the survival and to reduce the recurrence. You have surgery, radiotherapy, chemotherapy, endocrine therapy, and a neoadjuvant therapy. And what is neoadjuvant therapy? Here, the oncologist introduced the chemotherapy before surgery to reduce the size of the tumor. And we all know that chemotherapy is inevitably gonadotoxic, and particularly the alkylating agents. The taxanes and anthracyclines are more forgiving, but alkylating agents are pretty damaging. And what about endocrine therapy? We just discussed the natural age-related ovarian reserve plus the duration of almost 10 years of using tamoxifen can delay planning pregnancy. So there's a lot of counseling involved when you are encountering a hormone sensitive cancer patient, and consent has to be in place. There's so much of fear in the patient about cancer recurrence with pregnancy because of the rise in the estrogen hormone, the very safety of the future pregnancy, what would happen to her, what about treatment related complications, what about the child inheriting cancer and hereditary cancer. Now, all this has to be addressed. We have to counsel talking about the risks versus benefits. In hormone positive breast cancer patients, the risk of stopping tamoxifen prematurely to plan treatment of pregnancy would obviously increase the risk of relapse. What about the primary cancer treatment? The patients should be advised to be on a non-hormonal contraception with either barrier methods or intrauterine copper T. Now, what about timing for fertility preservation? When would you refer them for fertility preservation? If surgery is being done, it is done it is done soon after surgery, because we know we have a buffer time of 6 to 8 weeks before adjuvant chemotherapy starts. So it's always between surgery and chemotherapy. But when it is neoadjuvant therapy, the oncologist has to refer them for treatment even before the treatment starts. Obviously, the clinician has a very limited time frame, and there is also the fear that with the controlled ovarian stimulation and the rising estradiol, the tumor growth can become worse with estrogen receptor positive tumors. So what are the various options in our hands? We have the traditional ICSI with embryo freezing, but this is applicable only if a partner is available. We have oocytes vitrification. Today it is no longer an experimental method. It is ideal for a young woman who doesn't have a partner. GnRH injections are always used to suppress when chemotherapy, during the chemotherapy phase. And there is also ovarian tissue cortex freezing if a woman is in a particular state where there's a short time frame to work in. But with BRCA mutation carriers, we have to be very careful because there's a risk of ovarian cancer as well. In vitro maturation is available in limited centers where the expertise is available. So ASCO in 2006 revised its guideline in 2013 as to which are the established methods and where we have to counsel these are experimental methods. So coming to the random stimulation protocol, this is a special boon to us in the hands of the fertility clinician, because at any day of the cycle, in the time constraints available, we can recruit the patient. We don't have to worry it has to be on day 2 of the program. We can even do it a luteal phase stimulation as well. So why is it? Because we believe the follicles keep coming up in waves. Yes, sir. Right, sir. So the random start protocol is a boon in our hands. The antagonist protocol again gives us a short program, and GnRH agonist trigger whenever we want to avoid the OHSS. With day 2 introduction of letrozole or tamoxifen on day 4, we can lower the estradiol level. We try to keep it less than 50. So safety of controlled ovarian stimulation has come out with systematic reviews as well as with meta-analysis. Now this shows that how letrozole is introduced on day 2 and how 150 to 300 units of FSH is being used. And once the follicle size comes to 14 or 250 picogram of estradiol, the antagonist is introduced. The HCG trigger is used whenever there's no fear of OHSS. If there is a fear, we use the GnRH agonist trigger. Once at the time of the HCG shot, the letrozole is stopped and oocyte revival is done. On day 3, the estradiol level is checked. If the level is rising to anything more than 250 picogram, again we reintroduce the letrozole so that you bring down the levels to less than 50. So with oocyte vitrification, we know a skilled embryologist is needed. The reproductive autonomy of the individual is there if she is partner free, but it has its advantages on the religious, ethical and legal grounds. And we are getting better with the oocyte survival rate of almost 85%. What about OTC? It is not an experimental method in Europe, but in many countries it is experimental. Again, we need a lot of expertise. It is a boon when neoadjuvant therapy is planned because there's hardly any time. But with BRCA mutation, it is not recommended. And we already discussed about GnRH agonist covering during the course of the chemotherapy. With BRCA 1 and 2, the role of PGD is beautiful, where we can select the embryo which is unaffected by this particular mutation. And the difficulties are that basically there's a lot of lowered ovarian reserve in this particular group of cancer afflicted patients. So whenever we plan pregnancy,
you can conclude in 2 minutes.
Yes, sir. So whenever we are planning pregnancy, we have to remember the recommendations by the ESMO and the Green Top guidelines. If it's a good prognostic patient, 2 years post-treatment. But if it is estrogen receptor positive cancer or node positive, it is 5 years later. And there is an ongoing multinational trial positive, which is looking at the safety. particularly in elderly patients where there's a compromised reserve. Even 6 months post chemotherapy, we can do the fertility preservation, and if it is 3 months post ET, we can plan the pregnancy. This is about once we've created the embryos or we have the oocytes, when we can plan pregnancy. Now, why is FP not so popular? Because the awareness of the oncologist, the acceptance of the patients at the end of counseling being only 10%, and only 25% of them come to use it, and there's a long waiting period before they use it. Now, why is FP no longer a deterrent now? Letrozole and tamoxifen are here to keep the estrogen levels low. Random stand protocols are now available. Vitrification has become a revolution. And egg freezing has its own advantages and is now licensed by ASCO. And we have PGD for BRCA mutations. Now, I would like to conclude this presentation saying this beautiful slide shows that once you have a woman with breast cancer, we have to look at if they're going to receive adjuvant chemotherapy. If it is yes, and we have adequate time, we can plan embryo cryopreservation, oocyte cryopreservation, offer GnRH protection, use letrozole and tamoxifen during the controlled ovarian random start stimulation, offer PGD whenever there is a BRCA carrier. If there is inadequate time, then you have to offer ovarian tissue cortex cryopreservation. What about if tamoxifen is being used? You know you're going to use it for a period of 5 to 10 years. So you look at the woman, if she's more than 25 years, a lot of reproductive counseling and fertility preservation has to be offered because you're going to lose time. But if it's a young woman who's less than 25 years old, you just have to offer counseling, not necessarily do fertility preservation. So with this, I would like to conclude my presentation. Thank you so much for the time.
Thanks, Dr. Rajapriya, for your detailed talk on managing fertility in post-cancer patients. And I feel you should start a specialist clinic for post-cancer patients to manage the fertility.
Sure, sir.
Right now, they will be benefited. Thank you, Dr. Rajapriya.
Thank you so much, sir.
Now we will have audience interaction.
So we start, Dr. Reddy.
Yeah, no, there is 2 questions are there. Vijay, if you are there, can you?
Yes, sir. Yes, sir.
The 2 questions we asked, then Dr. Sharath will take over.
Sure, sir. So this is from Dr. Neeru Gurgaon. This is to Dr. Jasmeet, if she's still on. Dr. Jasmeet?
Yes, ma'am, I'm there.
Yeah, her question is whether HCQ to be continued throughout in pregnancy in a patient after ART in autoimmune positive.
Yes, ma'am, HCQ is found to be safe, and it is rather recommended that we continue HCQ during pregnancy because it prevents the disease flare and also decreases the dose of the glucocorticoids which the patient might need. And also in patients who have anti-Ro anti-La antibodies positive, it decreases the incidence of congenital heart blocks. So it should ideally be continued, and a rheumatologist should be consulted also. But yes, it is per se found to be safe.
Thank you, Doctor. And the other question is from Dr. Radha Venkatachalam. I think this is for both her Madhupriya and Kamalarsi. Even after washing, even after using the washed semen, HIV and hepatitis B positive husband, and wife is negative, what is the chance for her to get infected? In spite of wife being negative and the semen of the positive husband being washed and used, her doubt is, in spite of washing the semen and doing the process, is there any chance for the negative wife to get infected? What is even the smallest possible chance for the wife to get?
If they are not there, anyone
yes.
can answer.
Yes, as far as hepatitis B virus is concerned, if the wife is negative or vaccinated, husband is positive, there is no risk of transmission. Moreover, we are going to give immunization, immunoprophylaxis for the baby. The risk of transmission is very, very low because wife is vaccinated. So that is like the antibody is going to neutralize the antigen. So the risk of transmission is very, very low as far as hepatitis B virus is concerned. Regarding hepatitis C virus, if the viral load is undetectable, again, the risk of transmission is going to be low. If the viral load is high, like more than 10,000 copies per ml, then definitely there is a risk of transmission. The baby is going to be the risk increases to 80 to 90% when the viral load is high, even after washing.
What about HIV?
HIV. The question is whether the wife will get infected by inseminating in IUI cases.
Yes.
In
So
spite of
regarding wife, like if she's vaccinated, so like we are going to do IUI only after knowing that the wife is vaccinated in hepatitis B virus. I mean, like Madhya has to answer for HIV. But
yes.
so in that case, the risk of transmission to the wife is low. Before knowing that the wife is vaccinated, you're not supposed to do IUI if the male partner is positive.
Yes. Thank you, Dr. Kamalas. Is Madhya is online with us?
Sarath can take over and proceed.
There are two questions for
for that question. So there are a lot of studies where they've seen, like after preparation of semen sample and in thousands of patients, sero-discarded couples, and they found that none of the the female partner has been infected. So there are studies which, say that there's been no infection after semen preparation and doing an IUI. So I just
there are reports where saying up to 5% there's a risk of wife getting the HIV infection after IVF procedure in a negative female partner. Up to 5% we can risk is there. Then we go to the other questions like Dr. Shalu Gupta is there, no? Yeah. Dr. Shalu, there are two questions for you. One is precautions for oocyte retrieval in kidney transplantation. Is there any role for abdominal route for oocyte retrieval in this particular group of patients? And the second one is AID. When you are planning for AID in a renal transplant patient, how to prevent infection in the female partner when she's opted for donor insemination?
So normally the transplant kidney is retroperitoneal. It is not in the abdominal. So it is very rare that it comes in a way. So in case if it is coming in a way and you're not able to get any, and our ovaries are in the peritoneum. So it is, we can always move the ovaries, whereas the kidney being a retroperitoneal, it do not move. So if you put little pressure from the abdominal, the ovaries will come towards the probe. But in case you are not able to, you feel that kidney is coming again and again in a way when we are doing, yes, go ahead with the abdominal thing. Do not touch the kidney at all. Do not go through the graft. We cannot put a needle in the graft or touch the graft at all. These patients, for them, the graft is very important. Okay, baby comes secondary, because if you see when the patients comes to you, they are so much high strung. They want to have a child, but they do not want the graft or the kidney to have any effect on the kidney. So, and if my practice, if I see, I had 10 patients who must have seen in last few years, 4-5 years, but none of the patients were ready to risk their kidneys. It was only when they got a green signal from the renal physician, they had gone for the IVF and the fertility treatments. And secondly, for during the AID, for these patients who are kidney transplant patients, I normally do a high vaginal swab for them to make sure there is no vaginal infection, and then plan for the IUI. And as we know, the chances with the IUI, if any infection is very low. Plus, if you want, you can give a prophylactic antibiotic, which is kidney safe antibiotic to these patients. Otherwise, there is no nose for any antibiotic. And in this, just do a high vaginal swab when you're doing a IUI for these patients.
Thank you, Dr. Shalu. Dr. Kanimoli is there? Hello, Dr. Kanimoli.
Yes, sir. I'm here, sir.
There are two questions for you. No, one is TSH monitoring is required during stimulation, ovarian stimulation? Is by Dr. Radha Vembuno for you.
Yes, sir. So this prior to stimulation, we have to go for TSH monitoring, and you don't have to do it during stimulation, sir. The level has to be adequate. It should be less than 2.5 before we start the stimulation. There is no guidelines saying that during a COH you have to do it. It is prior to COH we have to do, and we have to make sure the levels are less than 2.5.
Thank you. And the other question is, how does anti-thyroid antibodies interfere with fertility?
So as I've already told, basically it alters the natural killer cell modifications. So interleukin productions will be there, which alters the implantation and the pregnancy losses. It causes pregnancy loss. It is because of the natural killer activation.
And same way, another question for you. If the patient TSH level is between 3 and 4 during ovarian stimulation, how should we monitor? As you said, no, it should be less than 2.5, no?
Yes, because what the studies say, what the guidelines of American Thyroid Association 2018 says, if it is if it is not less than 2.5, supplement with a very small dose of levothyroxine, because it is always better than to have risks. So it is always better to start with a smaller dose like 12.5 micrograms before we start the stimulation.
Thank you, Dr.
Thank you, sir.
So, Dr. Reddy, I think questions.
So there is one question from Jayarani, ma'am. Can I answer that question, sir?
Yeah, please.
Yes. She had asked about ovarian cancer survivors. Like basically today, generally ovarian cancer has poor prognosis, but with better treatment, there's a very good survival. So with borderline ovarian tumors, there's always a role to offer it at every stage of the survivor. But if it's the other cancers, the epithelial and non-epithelial, we have to go by early stage and late stage. But fertility preservation is not at all given as an option for those who are BRCA carrier, mutation carriers, the clear cell carcinomas and the carcinosarcomas. So that group alone, it is not encouraged. But for most other cancers, based on how aggressive the tumor is, the fertility preservation options is offered if the survival rate is looked at more than 80 to 90%. Thank you.
Thank you.
Thank you, Dr. Sarath, for moderating excellently and extracting all the answers from the speakers. Okay, I also thank the speakers, Dr. Shalu Gupta, Dr. Kanimuli, Dr. Puvitra Tarikachalam, Dr. Radhika Potluri, Dr. Rajapriya Ayappan for your excellent talks. Thank you very much for making this session wonderful. We will go to the next session.
I thank all the presenters for their excellent talks.
I request Dr. Jayarani Kamaraj to take over the podium and conduct the session 3.
Good afternoon, dear friends. A special thanks to Kamala Madam and Sanjeeva sir. And it's a very interesting topics he has selected, and it's really, I'm really very astonished by your efficiency in selecting the cases. The topics, sir. It's really amazing, and thank you for that. And thank you for including me in this session. And we have very nice lectures coming ahead in this third session. And I have the great pleasure and honor to introduce Dr. Hema Deepthi, who is a senior fertility specialist at Nova IVF Center, Banjara Hills, Hyderabad. And she has been trained in reproductive endocrinology and advanced fertility training at the University Hospital in USA. And she had a hands-on training in ART in the Cleveland, USA Center. And also she had done her course in the management of infertility by B.N. Chakravarti's Institute. And she's been the organizing committee member for ISA 2020. And her area of interest is poor ovarian reserve and recurrent implantation failure. And Dr. Hema will be talking to us about a very interesting topic, that a patient with hyperprolactinemia. We all know when the prolactin level comes with patients with a slight increase, the patients are very anxious, and we don't know whether to treat them, whether to clear them, what is the advice we are going to give them, and how we are going to proceed with a borderline prolactin and a high prolactin level. There are a lot of intricacies in that. And this will be, I hope that Dr. Hema will be making us very clear in managing such patients. Over to you, Dr. Hema.
Thank you, ma'am. Thank you for that lovely introduction. In fact, a very detailed introduction. And I would also want to thank Dr. Sanjeev Reddy sir and the organizing committee for this.
Hema Bindu, your audio is not good. Can you adjust?
1 second, sir. What about, can you hear me now, sir?
It's better. It's breaking.
Is there fluctuation in the tone?
Now it's okay.
Now it's okay. Just stop.
It's okay, sir. Okay, thank you. So I would also want to thank Dr. Sanjeev Reddy and the organizers before I started. And for the next 15 minutes, I'll be talking about an infertile patient with hyperprolactinemia.
No, the audio is not good. Can you do something? Just adjust that one.
So you don't have a column mic or something like that? That will be better.
No, I'm so sorry. I never had this problem, so I'm just worried. can I just disconnect my internet and connect in a second?
Okay, shall we ask the other speaker to speak? Then you can address.
Sure, sir. Sure, sir.
Okay, Jaylani, you can just stop sharing. Can you go to the next speaker?
Yeah, yes, sir. So I'm very happy to introduce Dr. Aditi Trivedi. I hope she is logged in and ready for the presentation.
Yes, ma'am.
And she will be talking about a very interesting topic, the bariatric surgery patient who is facing the fertility issues, which is very quite common with an obese women. And when a PCOS woman comes with all the options of weight reduction, and the last one we put is the bariatric surgery. And it's really quite interesting and very rarely to see a patient with bariatric surgery planning for a fertility. And I hope Dr. Aditi will be showing a lot of insight about this bariatric surgery women, how she can get a pregnancy and how she can go through her pregnancy. Over to Dr. Aditi for your presentation.
Thank you so much, ma'am, for that lovely introduction. I'll just share my screen. First of all, I would like to congratulate the entire team of Tapisar and Dr. Sanjeeva Reddy for such a wonderful academic session since morning. And thank you so much for having me here today. So I'll be talking about ART after bariatric surgery, and we are going to face such situations in our clinical practice much often in near future. Obesity is now a global pandemic. There are more than 135 million people in India suffering through obesity. And the point of importance here is that in India, the prevalence of overweight and obesity is increasing faster than the world average. We all know the impact on reproduction, how obesity affects the hormonal milieu, resulting in anovulation, increased androgenization, irregular cycles, increased miscarriage rates, and antenatal complications. Lipotoxicity, how it affects the oocyte quality. Now, what it does is it causes endoplasmic reticulum stress. There's dysfunction of mitochondrial and apoptotic pathways. Now, this will cause disruption of the oocyte development and maturation. Obesity definitely affects our ART outcome. Now, before starting any stimulation, the most important thing which we look at is the BMI of the patient, because our gonadotropin dose will depend on that. Because there is increased gonadotropin dosage used due to poor absorption and metabolism, FSH threshold in this woman with higher BMI is increased. There is gonadotropin resistance due to a high intrafollicular leptin levels, which has inhibitory effect on FSH-stimulated steroid synthesis by the granulosa cells. Oocyte quality is definitely affected. We'll get lesser number of growing follicles, lower concentration of intrafollicular HCG, lower peak E2 levels, lower number of mature oocytes, fewer oocytes on retrieval. This will result in higher cancellation rates, lower fertilization rates, poor embryo quality. There will be arrest of the embryo growth before blastulation, so you'll have lesser number of embryos to be transferred, poor implantation and clinical pregnancy rates. Even the endometrial receptivity in obese women is affected due to different pattern of endometrial gene expression, resulting in recurrent implantation failures. Now, WHO has recommended bariatric surgery for patients with BMI more than 40, that is morbid obesity, or with BMI between 35 and 40 who have associated comorbidities. What is important for us is that more than 80% of this population undergoing bariatric surgery are women, and approximately half of this belong to reproductive age group. So we are going to face this situation much more often. Before treating any patient who have undergone bariatric surgery for ART, it is very important to know what kind of surgery the patient has undergone. Now, bariatric surgery can be a restrictive procedure where the size of the stomach is decreased, or it could be an absorptive procedure where it causes malabsorption of nutrition. So first, let's understand the basic behind this procedure and how the physiology changes. Now, Roux-en-Y gastric bypass, in which a small surgical stapler is attached near the upper part of the stomach, causing a small new pouch which will act as a new stomach. The lower end of the stomach will secrete the gastric secretions but won't receive any food. They will again create another stapler near the small intestine. The lower end is attached to the newly created pouch and the other end is attached to the small intestine. Food will pass through this new pathway causing less absorption, less amount of calories absorbed, resulting in weight loss. Similarly, there's another procedure, restrictive procedure called as gastric banding, where a restriction is caused due to constriction of the upper part of the stomach. The food has to pass through this small pathway and enters the lower stomach, which causes decreased absorption and early satiety, resulting in weight loss. There's vertical banded gastroplasty, also known as stomach stapling, where the surgeon creates a small opening in the upper part of the stomach, and it is stapled near the lower end of the esophagus, causing a small new conduit through which the food has to pass. A plastic band is attached to the lower part to prevent stretching. Food will pass through this lower new conduit, and there's less absorption of calories, resulting in weight loss. Similarly, laparoscopically also we can attach an adjustable gastric band, where a band is attached near the upper part of the stomach, and it is inflated from the outside through a reservoir, causing constriction, and the food will pass through this small conduit, resulting in less absorption of calories, resulting in weight loss. Now, what is the aim of bariatric surgery? Loss of up to 15 to 25% of body weight that is sustained in the long term, which will normalize the metabolism, help in improving the psychosocial development of the patient, enhance the fertility, improve our pregnancy outcome and neonatal outcome. Now let's go on the studies. Milon et al. Had published a study where they had shown how bariatric surgery improves the ART outcome. What was interesting to know is that in their study before and after surgery, if you see the comparison, the total dose of gonadotropins, the duration of stimulation has decreased. The number of follicles retrieved, the M2 oocytes have increased. And especially the pregnancy rate and the live birth rate have drastically increased in patients after surgery. Now PCOS and obesity goes hand in hand. So how bariatric surgery improves the markers of PCOS which affects fertility, like sexual dysfunction, anovulation, hirsutism, hormonal imbalance, and insulin resistance. Does it decrease the miscarriage rate? Now there are very few studies which has result. It's so difficult to evaluate. I have come across only two retrospective studies. One found no difference in the miscarriage rate, and another recorded a reduction from 17% to 11%, which is quite significant. Now let's talk about men. Does it improve semen parameters and sex hormone concentration in males undergoing bariatric surgery? Overall, semen parameters were not affected by bariatric surgery, but what was more interesting in this paper was, if you see this table, the pre-op and post-operative semen analysis parameters of patients with oligospermia has drastically improved, both in terms of count, motility, with increase in progressive motility, improvement in morphology, increase in the testosterone levels. And they also found that 6 azoospermic men in their studies, they were able to retrieve sperms after the surgery, and they had freeze those sperm and had used for ICSI. Now we saw the rosy picture about how bariatric surgery helps in improving the ART outcome, but there are many contradictory studies as well. Cristofolini et al. They studied the influence of bariatric surgery on the oocyte quality and the embryo quality. It was very astonishing to see these findings. Now, what you are seeing, the G1 column are the patients who have undergone bariatric surgery. G2 is general population, and G3 is those obese patients without any surgery. What they saw was there were lesser number of developing follicles, lesser number of oocytes retrieved, lesser number of M2 oocytes after bariatric surgery. What was the reason behind this? They concluded that because of bariatric surgery, there is a lot of nutritional deficiency, which causes failure of fertilization and embryo dysplasia because the signaling pathways are affected. Another retrospective cohort study, they studied IVF outcome in patients with a history of bariatric surgery. They definitely found improvement in the cumulative pregnancy rate and implantation rate after the surgery, but there was no statistically significant difference in the number of oocytes retrieved, mature oocytes, and the number of embryos. So et al. Also studied the effect of bariatric surgery on oocyte yield and embryo quality. Here as well, they found no difference in the oocytes retrieved and the quality of the embryos, but definitely there was reduction in the number of gonadotropin ampules and the less cycle cost. Now, whenever we are starting stimulation, a patient who has undergone bariatric surgery, we are going to face obstacles. The most dreaded obstacle is empty follicle syndrome. Now, it is a nightmare for any ART specialist. The first thing which we want to hear from embryologist is first egg. Why this happens in these patients are because they have abdominal skin redundancy, which results in altered absorption of subcutaneously administered HCG trigger. So in such patients, intramuscular route of administration is preferred. Malabsorption is very common in such patients, so you should avoid subcutaneous injection for stimulation. Always be cautious while using aspirin, because many of us use in our patients who are undergoing IVF during stimulation and after embryo transfer. So it can cause gastric ulceration. This study by Doblado et al., they had published case series of 5 studies in which 4 out of 5 patients conceived after bariatric surgery. The important point to note in this study was one of the patients had developed mild OHSS. Now that can lead to ascites and increase intra-abdominal pressure, potentially increasing the risk of 2 late complications of gastric bypass surgery, that are intestinal obstruction and internal hernia. Now it is very important to distinguish between OHSS and internal hernia. Patients undergoing Roux-en-Y gastric bypass surgery have potential internal spaces through which a herniation of small bowel can occur. Now they also present with the similar symptoms like in mild OHSS, like abdominal complaints like nausea and abdominal pain. So it is very important to distinguish between the two, because internal hernia is a surgical emergency and immediate surgical intervention needs to be done to prevent bowel necrosis and perforation. So as a clinician, we should always strictly monitor for signs and symptoms of OHSS and have to be guarded about this thing. What should be the time to conception after surgery? This is very important because the recommendation is 12 to 14 months after surgery. Because during this time frame, women are actively losing the most of their weight. This delay is done in an effort to optimize the weight loss and reduce the potentially adverse effect of the bariatric surgery. Now, it is very difficult to counsel women in elderly population because we are asking them to wait for almost 2 years after the surgery. This will progressively diminish the ovarian reserve. So in such patient, you have to measure the pros and cons and then take the decision about the surgery. Contraception after bariatric surgery is very important in this period, and avoid using oral contraception due to malabsorption, and a non-oral route is preferred. Now, once a patient is conceived, the story doesn't end there because they require a very good antenatal care, that intensive diet support, and a nutritionist should take consult of a nutritionist as well. In all patients, regardless of the surgery, monitoring of the ferritin, vitamin levels, folate levels should be carried out. Weight should be monitored. Also screen for gestational diabetes and screen for fetal growth. Active band management. In patients who have undergone laparoscopic adjustable gastric banding during the first trimester, to decrease the nausea and vomiting, the fluid from the gastric band can be removed or lessened during pregnancy. Cochrane review doesn't agree with that because there are no randomized control studies, and deflation of the band has the distressing consequence of weight regain, renewed risk of gestational diabetes, and relapse from diabetes. But definitely bariatric surgery, if you see, the incidence of PIH and GDM has drastically decreased in the patients who have undergone bariatric surgery compared to the obese population. Now, does type of bariatric surgery matter? Yes, definitely. Roux-en-Y procedure gives us better outcome in terms of weight loss, diabetes, and even fertility outcomes because it is malabsorptive as well as restrictive procedure. But sleeve gastrectomy or laparoscopic banding causes less micronutrient deficiency because it is just a restrictive procedure, doesn't cause malabsorption. So there's lesser incidence of growth restriction and small for gestational age babies. Labor delivery, the mode of delivery doesn't change, though the incidence of cesarean delivery are higher, up to 62% in patients who have undergone bariatric surgery. But bariatric surgery itself should not be considered as an indication for cesarean delivery. Effect on fetal and neonatal outcomes as compared to general population, there is no increase in congenital anomalies, but definitely will face more growth restriction due to nutritional deficiency and more small for gestational age fetus. So what are the take-home points? One should counsel patients about undergoing bariatric surgery with morbid obesity. Therefore, pregnancy for at least 18 to 24 months post-bariatric surgery and avoid oral contraceptives. During control ovarian stimulation, step up protocol with antagonists. Anyhow, you need to prevent OHSS, be very vigilant, monitor the patient carefully, look for internal hernia complication, prefer intramuscular route of injection to overcome malabsorption. Avoid using aspirin because it can cause gastric ulceration in such patients, both during stimulation and after embryo transfer. Prevent empty follicle syndrome by administrating your HCG trigger intramuscularly. Watch for OHSS. Being vigilant during antenatal care to avoid nutritional deficiency. Diagnose GDM early and treat them early. Look for fetal growth restriction during entire pregnancy period. So with a little more persistence, a little more effort, and what seemed like a hopeless failure for all of us with patients with morbid obesity, with a small efforts, we can turn these failures into glorious success. Thank you so much for a patient hearing.
Thank you, Aditi, for the nice talk about a very interesting and newer topic, the bariatric surgery patients. And it's really interesting to come across such patients. And I'm very happy to see the two beautiful researches that you have collected about their outcomes. And definitely obesity, the dosage, calculation of gonadotrophins, everything plays a very important role in the decision of the ART success. So thank you, Aditi, and we'll be seeing the questions in the last. Stay with us. And I think, Dr. Hima, you are ready now with your presentation?
Hello, Dr. Jairani. Can you hear me, madam?
Yes, I can hear you.
And is it clear this time?
Yes, it's clear. You're right.
I've tried to get some headphones.
Right, that's good. That's great. Keep going.
Oh, okay. Let me share mine. Hello, ma'am. Should I proceed?
Yes, Hema.
Yes, thank you, sir. Thank you. So for the next 15 minutes, I'll be talking about an infertile patient with hyperprolactinemia. Now, as practicing fertility specialists and gynecologists, we all know the importance of hormones in an infertile couple. And FSH, LH, E2. These are the three hormones that take a priority in our daily practice. Now, do you really think we need to spend this 15 minutes on a Sunday afternoon talking about one single hormone, prolactin? Let's see. So hyperprolactinemia is the most common pituitary hormone hypersecretion syndrome, not just in females, but also males. And the prevalence in the asymptomatic population with infertility is around 5%. And 14 to 17% of women in reproductive age group suffer with hyperprolactinemia. Now, what is even more important to understand is the mean time to pregnancy in these hyperproteinemic females is 2.4 years longer. So very important for us to pick up our patients with hyperprolactinemia. Now, we all know what prolactin is and that it is secreted by the anterior pituitary glands. A point that requires mention here is the control. So this hormone, prolactin, is predominantly under the catonic inhibitory control of dopamine and the stimulatory effect of thyroid release hormone, thyrotropin release hormone. Now, it is the balance between the dopamine and the thyrotropin release hormone that actually decides the amount of prolactin that is left into the blood. So it is a very delicate balance between these two. Now, there are other hormones also that affect the release of prolactin secretion, like our estrogen, VIP, serotonin. But the point to remember here, dopamine is the predominant regulator. Now we know that the presence of abnormally high level of prolactin in blood is called hyperprolactinemia, and normal levels are between 10 to 35 nanograms per ml. But the point that I want to stress here is please don't take this range, because the normal range for every center is different. So that depends upon the lab you're associated with, and depending upon your lab normal, you need to be able to pick up your patients with hyperprolactinemia. Now, when we're talking about etiology and when you have a patient with hyperprolactinemia, are you always suspecting some pathology to be a reason for this? Not really. Yes, there are some physiological conditions like pregnancy, lactation, after coitus, after vigorous exercise, sleep, and stress. All of this lead to transient hyperprolactinemia. And then you have your pathological, a huge list of pathological causes. Your hypothalamic pituitary stalk damage, pituitary lesions, systemic disorders, patients with chronic renal failure, our very own PCO patients, hypothyroidism, all of these lead to hyperprolactinemia. And definitely mention of the drugs that lead to hyperprolactinemia is a must, because drug induced hyperprolactinemia is the most common cause of hyperprolactinemia among the non-tumor causes. So the day in and day out drugs that we use, like our antiemetics, the OC pills, estrogen, tricyclic antidepressants, antipsychotics, there is a list of drugs that can lead to hyperprolactinemia, and we need to be aware of them. Now, how does prolactinemia, one single hormone, a little bit of increase of it, how does it actually affect fertility? Now, it leads to a decrease in pulsatile secretion of the hypothalamic gonadotropin release hormone that impairs the pituitary gonadotropin secretion. And it also inhibits gonadal steroidogenesis. So what it actually does in a female is, it inhibits the granular cell aromatase activity, leading to hypoestrogenic state and anovulation. And it also causes a luteolytic effect, leading to a shortened, inadequate luteal phase, leading to impaired implantation. A topic that is always neglected is males. Yes, does hyperprolactinemia in males, does that also affect fertility? Definitely. There is the activation of prolactin receptors on the Sertoli and Leydig cells that leads to low testosterone levels, which further lowers spermatogenesis. So you might have a young couple sitting in front of you with low sperm count, and we've missed out the prolactin level in male, and we're suggesting them IUI or IVF cycle. Probably a simple correction of prolactin in this male might actually help this couple get pregnant. So very important to measure prolactin levels even in the male counterpart. Now, coming to the diagnostic workup. Yes, blood test is the definitive diagnostics, gives the definitive diagnosis, but what is even more important is when it is done. So it has to be ideally done in the morning, because our hormone prolactin has a circadian rhythm and has high values at night and low values in the morning. So measuring a morning sample gives us accurate values. And we also advise a patient to have 8 to 10 hours of fasting, because food intake can actually give us altered prolactin levels. And preferably this has to be done in the first half of the cycle. It is important to mention to your patient not to have any sexual contact or stimulation of breast or nipples a day prior to the test. And also very important to suggest our patient to avoid any strenuous exercise before the blood test. Now, most of the ladies have this habit of going for a morning jog or a yoga in the morning or a vigorous exercise, and then they come fasting and give a sample, and that is going to be a spurious report. So very important to pass on these instructions to your patient before they give their blood sample for testing. You need to document at least 2 prolactin values, increased 2 prolactin values, for you to label your patient as hyperprolactinemic. Now, coming to other important points, a detailed medical history, a history including whether the patient has any history of hypothyroidism, any renal dysfunction, any hepatic dysfunction, and definitely a detailed inquiry into the drug history is a must. Clinical examination, something most of us neglect in patients with hyperprolactinemic. Examination of the breast is very, very important. Now, this is a small table I've picked up from a review article by Dr. Crosignani, where he has summed up very beautifully the important tests in just 4 points. In women with menses, yes, it is important to measure prolactin and also progesterone in the luteal phase. This is for us to pick up the patients with luteal phase inadequacies. And in women with oligomenorrhea, doing an FSH is also important, and this helps us to pick up the patients who are landing up in premature ovarian failure. Imaging of the pituitary must be performed in all patients with hyperprolactinemia, and it is a sin if we forget to measure the thyroid levels, thyroid function, thyroid profile in a patient with hyperprolactinemia. Coming to imaging, MRI with contrast with pituitary cuts is what we're looking at. And in the MRI, we're looking for the lesions and any mass effects onto the adjacent structures. Now, prolactin values lower than 100 nanograms per ml. It does not mean that the lady is just suffering from functional prolactinemia. The patient can also have microadenomas. So values less than 100 do not really exclude adenomas. And higher values are definitely indicative of prolactin secreting adenomas. Pituitary imaging is a must for all patients with persistently elevated prolactin levels, and all the endocrinological societies do suggest pituitary imaging for patients not just with persistently higher values of prolactin, but also for ladies with or patient with just an increase in prolactin level, a mild increase in prolactin level. Even for those patients, pituitary imaging is a must. Now, when we have prolactin values less than 200 nanograms per ml, mostly it excludes macroadenomas, and values more than 200 nanograms per ml, yes, we need to suspect if this patient has a macroadenoma, and probably this is a patient that needs further guidance of an endocrinologist, and some of them might actually require a neurosurgeon too. So very important for us to know this cutoff. Now, hyperprolactinemia and spontaneous pregnancy. Is that even a possibility? Yes, several spontaneous pregnancies have been reported in untreated cases, but like I've already mentioned, the time to pregnancy is 2.4 years longer in these untreated patients. So definitely lowering the prolactin secretion becomes the best treatment option to help this patient, to help this couple conceive. Now, coming to the management of this condition, the management is directed to treating the cause of hyperprolactinemia. Now, whenever we have a patient with drug-induced hyperprolactinemia, so it is ideal to actually discontinue the drug. But now I might be having a patient who on antipsychotic drugs, and I cannot just stop her off the antipsychotic drugs. So whenever the underlying condition warrants that the patient has to continue the medication, it is important to switch to another similar drug that has a lower impact on prolactin levels. Now, if you have a patient with hypothyroidism that is responsible for hyperprolactinemia, controlling hypothyroidism beautifully gets prolactin levels to normal values, and we do not really have to treat hyperprolactinemia separately. Yes, dopamine agonists are the first line of choice for any kind of hyperprolactinemia, not just tumors, even for functional hyperprolactinemias. So what happens here? The dopaminergic agonist, the drug that binds to the D2 receptors on the lactotropes, and it reduces the adenyl cyclase activity, leading to inhibition of prolactin secretion. For patients with symptomatic prolactinomas, medical therapy is the treatment of choice, and these have been shown to be very effective in normalizing prolactin levels, in restoring reproductive hormones, in shrinking the adenomas, and in increasing the bone density. And when you have a prolactinoma, just the presence of microprolactinoma does not warrant medical management. So for in asymptomatic patients, it is not really required that we start treating them. Surgery and radiotherapy are rarely required, especially for patients with macroadenomas. And in patients with hypothalamic and pituitary lesions or with mass effects, yes, a referral to a neurosurgeon might be a priority. We have 3 important drugs in the market which we can use to the benefit of our patients: bromocriptine, cabergoline, and quinabolide. Bromocriptine is started at a dosage of 1.25 to 2.5 milligrams per day at bedtime, and it is adjusted with the dosages of 1.25 milligrams. And gradually we increase the dose, and you can go to a maximum of even 5 to 7.5 milligrams per day. Coming to cabergoline, we started at 0.25 to 0.5 milligrams, either weekly dose or twice weekly dose. We adjust it at a dosage of 0.25 milligrams, and we can go to as high as 1 milligram twice weekly. And these dose adjustments should be done every 2 to 4 months. Our third drug, quinabolide, we started at 25 milligrams per day, and you can go to as high as 75 milligrams per day. The advantages of bromocriptine are the long history of usage. It is actually safe for the fetus, inexpensive, but 60 to 70% of our patients might find it very difficult to tolerate bromocriptine because of the gastrointestinal side effects, and some of them might even complain of headache, dizziness, orthostatic hypotension. So when it is like this, cabergoline becomes a drug of choice for these patients. And not just the side effects of bromocriptine, cabergoline per se is a very efficacious, has high efficacy levels in controlling prolactin levels. And the twice on the weekly and twice weekly dosage makes it very comfortable for the patient to use it. Yes, definitely a point to mention is the risk of fibrovascular heart disease. Quinagolides, even though they are highly efficacious and tolerable, we do not really use them because of increased congenital malformations if you use it during pregnancies. Now, we all know that dopaminergic agonists are the treatment of choice in patients with hyperprolactinemia, but then how long do we use them? Some of us are using it for 2 weeks. There is another doctor who's using it for 8 weeks. Now, what is the protocol? It is important to maintain the effective prolactin lowering dose for at least 10 to 12 months, since it actually takes time to re-establish the ovulatory cycles. And studies have shown that half of the pregnancies occur only after 6 months of therapy. And even after normalizing prolactin, if your patient is not conceiving or if your patient is not ovulating, then you need to take the help of the ovulation induction agents like clomiphene citrate or letrozole. And if your patient does not conceive even after 6 to 8 ovulatory cycles, this is a couple that which requires reinvestigation, and we need to look for other causes of infertility. Now, there are other treatment managements too. Pulsatile administration of gonadotropin release hormone, and this beautifully establishes normal ovulatory cycles. And recent evidence of kisspeptin infusion, this is something that has restored pulsatile LH secretion and increased fertility. But do we really use these two therapies in our daily life? No, because it's very easy to use dopaminergic agonist drugs. Now, once you put your patient on dopamine agonist therapy, it is also important to follow up your patient. It is not just starting the drug for 4 weeks or 8 weeks and then stopping at that point. So a periodic prolactin measurement starting 1 month after the therapy and then 3 monthly thereafter, at least for 1 year, is what the recommendations are telling us. And the repeat MRI has to be done after 1 year. This is to see in case the patient has an adenoma, is there a progression in the adenoma or is it still static? So it is very important to have a repeat MRI. And visual field examinations are a must in patients with macroadenomas, especially with the risk of impinging the optic chiasma. So this is how we follow up our patients. Now, just to sum up in 3 simple points. Yes, hyperprolactinemia is an important cause of infertility, not just in females, but even in males. So we need to start working up this hormone even in the male counterparts. And then a proper drug history, exclusion of pregnancy, hypothyroidism, any renal dysfunction and hepatic dysfunction are a must before pituitary imaging. And dopaminergic agonist drugs are the cornerstone of therapy. Thank you.
Thank you, Dr. Hina, for the nice lecture. And now we are moving to the next interesting topic. May I have the CV? Yes. So I have the great pleasure to introduce my dear friend, Dr. Priya Selvaraj. She is the Scientific and Clinical Director of the GG Hospital, Fertility Research and Women's Specialty Center, Chennai. And she has been widely trained in ART in the clinical procedures with assisted reproductive technology. And she has credited a lot of achievements in the field of ART for the past 13 years. And she has been a faculty in many national and international conferences. And her main area of interest is pre-implantation genetic screening and diagnosis and the fertility preservation and the related techniques. And she will be now talking on a very, very important question that every ART specialist should know, whether to flush or to not to flush, or the follicles when you're doing an oocyte retrieval. Will it definitely have an impact on the oocyte quality? Whether it has any impact on the outcome? I hope that Priya will explain us, or rather make us very clear about the flushing and its outcome in an oocyte quality. Over to you, Priya.
Jairani, she's also my daughter.
Ma'am, that's always known, ma'am.
Thank you so much, ma'am, for that kind introduction. And first of all, I'd like to thank Reddy sir and Kamala madam for giving me this opportunity. And I also would like to know why he chose such a different topic for me when everyone has a clinical topic in hand. So anyways, I hope I do justice. And so I'm just going to share my screen. Okay, it's visible. And can I proceed?
Yes, Priya.
Okay. Just a second. So, like ma'am rightly said, my topic is to flush follicles at oocyte retrieval. And by the end of the talk, we'll probably be clear on this. And at the outset, I'd like to say it's a very much individual decision. But let me put forth certain studies for you all to debate. Okay. So before anything else, what is the success of a good oocyte retrieval? Because on one hand, as a clinician, you have worked up the patient, but there are other variables that actually contribute to success of good oocyte retrieval, which are good visualization and accessibility of ovaries, and how you want your approach to be, which is also a very clinically determined variable. So is it trans-vaginal, trans-abdominal, or more lately, people can go percutaneous into the abdomen. And also this involves a lot of technical skills and expertise. And also your choice of technique is based, as I said, on the clinical patient and how accessible the ovaries are. But by and large, I think we will all agree that the advantages of transvaginal is more when compared to transabdominal or even a laparoscopic approach, although the other two are there to stay. So what is the advantage is that there is better visualization and shorter distance of ovary from the transducer. There's also a higher recovery rate of good quality oocytes with minimal discomfort for patients. And also these can be performed with paracervical block or mild sedation instead of a full general anesthetic. And you can have decreased risk of intestinal trauma or injury to blood vessels. It also has a lower learning curve, more easier for people to grasp, especially if they have good ultrasound training. There's also a decreased cost for the patient and also quick recovery post-procedure. So what is the ideology behind flushing per se? So basically, we all know this, that it increases oocyte yield. It also causes detachment of the cumulus oocyte complex from the follicular wall. And over the years, it has been studied that flushing all the follicles up to 6 times will increase the yield by 20%. But we also know this, that the primary aspirate would have already sucked out 70% of the oocytes. So when 10 or more follicles are present, it becomes debatable, do you really want to do it or not? And let's discuss that further. So the technique is, if the first aspirate is sucked appropriately, if your technique is good, which I will explain during the videos, with the follicle wall collapsing around the needle, then equal chances of oocyte being present is there in the first aspirate itself. The remaining might get caught in the dead space. So another interesting thing we need to know is that the single versus double lumen needle, which is again according to every clinician's preference and what they've used in practice over the years. I've used a single lumen in a very, very small group of patients when I was trying to do IVM and it did not work. And so we use the double lumen always, and we do believe in flushing, and I'll come to that later. So the single lumen needle, what you need to know is that there is a dead space volume along with its tubing, which is 1 ml. So there will be a bidirectional movement of the oocyte. So, it could get caught in that space. And the double lumen, however, eliminates this because you have a flushing channel and aspiration channel, which are independent of each other. So you'll have a unidirectional flow of the oocyte in the aspirating channel. And of course, in the flushing channel, you will be able to perform your flushes.
So what are the disadvantages? So the main thing is you're going to prolong the procedure. And if the patient is going to be under a local anesthetic or mild sedation, and she's going to be aware, then, she will have increased discomfort because you're going to prolong it. And also the most important thing is that you will be increasing costs because of more use of media. Now, over the years, again, by view of experience, we have now concluded that there are indications when you will do follicular flushing, even in the current scenario, which is poor responders, and then when you're performing monofollicular IVF, if there is a group where, the follicles are less than 10, not particularly poor responders, and also another one, which I've included, which is unequal follicular response or growth. So here's our video. So this is a poor responder I recorded recently. So you can see they're all dominant follicles, but however, being a poor responder and left with only this many follicles, I will be flushing each and every one of them. So you can see we first stabilize the ovary with a transducer against the vault. And then you can see my needle entering there. And you can see how it is positioned in the center of the follicle, and the follicular wall is collapsing around the needle. I also sometimes to kind of scrape the walls, and then you can see the flush happening there. Usually I only do a single flush. Very rarely I do double flushing or more than one flush. You can see how you're supposed to flush out or aspirate all your follicles in a methodical manner so that you puncture the vault very minimal, only few times or maybe just once, and that's about it. And you go from the periphery located follicles into the internally located follicles. You can see flushing happening there and the wall collapsing. So certain studies have utilized a particular volume of flushing media, but as experience says, what amount you aspirate, that's the amount that you flush the follicle with. Now, this is in a poor responder. Let's go to the next video. Yeah, so this is an unequal follicular response. Like I said, this is a category, again, which you see clinically. You've given your standard conventional hyperstimulation protocol, and you find that there are about 8 to 10 or 12 follicles, of which only few are dominant, like say 3 or 4, and the rest are all coming in the category of 1.4 to 1.6. So do you go ahead and aspirate? Yes, you do, because you can get M2 oocytes from 1.4, 1.5 onwards. And so over here, you can see if I enter a dominant follicle, I'm not flushing it. But when I enter a follicle which is suboptimal, then I'm performing the flushing right there, as you can see it. So this I decided to include because I wanted to share my statistics at the end of the presentation. So you can see that's a small follicle. Yeah, that's actually even smaller. But there, when we go into a dominant follicle, then I don't flush it, I just let it collapse around the needle. So let's see what the literature has to say. I've put together a couple of studies, which each one has a different information to share. So the first one is a study by Anna et al. And this is from Brazil. And they had studied, it's a retrospective study, and they had performed it on 384 patients with poor response, and they conducted it with a parallel arm. So they had one with poor response, where the criteria was when they procured 5 oocytes or less, and then they had a very strict Bologna criteria. And in both these set of patients, they concluded that the follicular flushing improved recovery rate irrespective of the definition. So as you can see, if you have a strict Bologna criteria, then obviously your group of patients is a very very niche patient where the response is poor, and also the aneuploidy rate will be high because of the age factor. So their pregnancy rate was only 12%, whereas in group A, which is just the regular poor responder, is about 22%. So when you go to a very strict criteria and you know that the prognosis is poor, the flushing actually did not have any connection with the number of M2 oocytes retrieved or the pregnancy outcome. So there again, it's a deliberation. Then there is this paper from Turkey where they had 80 poor responders, and here he compared the double lumen versus the single lumen technique and of aspiration. And when they performed the flushing, it was 3 times in each follicle with 2 ml, and this was a fixed volume. And they found that the metaphase 2 oocytes were similar in both groups, and the clinical pregnancy and live birth rates were also similar in both groups. Only a disadvantage, obviously, which they were trying to highlight is that the follicular flushing is time consuming, and it doesn't make any difference, but it prolongs the procedure and anesthesia time for the patient, and it has very similar results compared with direct follicular aspirations in poor responders. So it did not show highly anything efficacious about flushing. So in this study, which is from Shanghai, again conducted on poor responders, they found that, again, this was a retrospective study done on 224 patients, where they fixed it, like they would not have more than 3 dominant follicles on retrieval day. And only first they will aspirate the follicle, and only if they did not find the oocyte in the first aspirate, follicular flushing was repeated up to a maximum of 9 times. So what they've concluded is, yes, you do get a higher recovery rate of oocytes when you flush it, but your advantages of flushing it more than 4 times was not advantageous if you flushed it between 4 and 9 times. Whereas when you flush it between 1 and 4 times, you did have a higher oocyte recovery rate, which is something good for us to know, because people used to flush it up to 9 times and 7 times, 20 years ago. And this is a 2020 study by Schwartz et al. It's a study from Zurich, where here they performed it on 164 women who are allocated to 2 different groups, where it was only first aspirate, primary aspirate, and the secondary aspirate with flushing. And over here, again, they found that in a monofollicular IVF scenario, where the stimulation is, very minimal or natural cycle, it did significantly increase the oocyte yield and fertilization rate without affecting the quality, but by and large, the outcomes were similar. And here they used a single lumen needle, and they found that it increases the efficacy of aspiration. This is one of the few studies that I have read where they say that using the single lumen was actually advantageous or convenient. And the last study is one by our own Dr. Neena Malhotra. Actually, she had presented it both as a poster and as a printed, as a published article. Both were contradictory, but initially it was mentioned that it does have benefit and in poor responders, and you do have a higher oocyte recovery rate, and also better pregnancy rates, because the more oocytes you get and the more M2 you're able to get, then they had higher pregnancy rates. But in the published paper, which is 2020, follicular flushing does not result in a significant improvement in ART outcomes, despite increasing procedure and anesthesia times. So this is something to ponder about. So based on our own experience, so I had to quickly put this together because Sir had given me this very different topic. So we quickly collected data, retrospective data. So we have another name for this. So we'll say first tube, how many eggs, then, second, it automatically means I flushed it. And so she will say first tube, yes, second tube, yes. First tube, no. Second tube, yes. So that's how we give it. But now I know a better way to call it. So I'll call it the first aspirate and the first flush. So here we have 166 poor responders, and you can see we had 840 follicles, of which we got 513 oocytes. And you can see that mostly if the performance is good, if your technique is good, you will recover at least 60 to 70% in the first aspirate. But you can see that an additional 40% I can get if I have flushed it even just once. So I feel it is a good method to follow where poor responders are concerned. And this one, I picked out the data from unequal follicle response. So these people had follicles anywhere from 8 to 12, and they had fewer dominant compared to intermediate sized follicles, despite thorough COH protocol. So you can see that the number of oocytes retrieved were 2790, of which dominant was about 63% and unequal growth was 36%. And you can see that in those unequal grown follicles, the oocyte recovery rate was increased by 56% with the first flush. It's just a concept of more the merrier, especially if you know that you have a higher chance of getting a dominant, N2 metaphase 2 oocyte when you take any follicle above 1.4 or 1.5. So I'd like to conclude by saying that follicular flushing does have its advantages in specific scenarios, such as poor responders and in those who respond unequally to standard protocols of stimulation. And the oocyte retrieval rates in the first flush and in poor responders is increased by around 40%, like I've shown you. And in an unequal follicular response, you get an additional 56%. Clinical pregnancy rate in the former group was 37%, and in the latter, it was 56%. So overall, this influences the number of embryos that are available for transfer and thereby the final outcomes. Of course, now that Sir has started this for me, I might have to, going forward, I can do more on trying to find out, maybe associate this with PGTA and see aneuploidy rates and etc. Many things can come out of this. So I thank you all for giving me this opportunity. And I want to congratulate all the previous speakers who've done a brilliant job, and also happy Women's Day to all the wonderful she heroes out here today. Thank you, sir, for this opportunity. Thank you so much.
Thank you, Priya. Thank you for this lovely presentation and highlighting the two situations where you have to specially use your double lumen needle for their ART procedures, because sometimes in an inexperienced hand, that it is always matters to have a flushing to get the oocytes. So that is very important that we have to understand who are all the patients who are ideal for the flushing. And thank you for this nice wishes, and we wish you all for a very happy Women's Day.
Thank you. Thank you.
So we are moving to the next topic. So I have the pleasure and honor to introduce Dr. Madhubala, who will be speaking on a very interesting context of this IVF. There is a luteal phase support, not as a regular support in special situations. And she is the executive director of the Lakshmi Madhavan Hospital, Tirunelveli. And she practices high-risk obstetrics, vaginal surgeries, laparoscopy surgeries, and IVF. And her interest is in all walks of obstetrics and gynecology. And she has a passion she attributes to her alma mater, Sri Ramachandra Medical College and Research Institute, Chennai. And she has submitted various articles in both national and international journals. And now she'll be talking on the luteal phase support in special situations in ART. Over to you, Dr. Madhubala.
Delegates, you can post your questions and you can download your participation certificate.
Can you see my screen, madam?
Yeah,
No,
yeah,
just
clear. No. Yeah, we
share your screen, please.
Share your screen, Madhubala.
I just request the speakers to kindly stick on to time, not exceed. Accordingly, make the number of slides. Okay. Thanks a lot. Thank you.
So Madhubala, you have to share screen. There's a green button that's coming down.
Presentation.
You open your presentation, keep it, and minimize your this.
And there is a share screen button, green button at the bottom of the screen. You just check, click on that.
So, sir.
Session, can you help?
Can you have a presentation session?
Dr. Madhubala, I don't believe you have mailed me the PPT. May I request you to kindly press the share screen button at the bottom and choose the first option as screen.
1 second, it's all gone. I don't know.
You can make it ready.
Yes, sir. I think
Go to Mohan.
Yeah, I'll do that. Right. So we have the next session, which is the last session of the today.
This is.
I think who's sharing?
It is there actually. Dr. Madhubala is sharing. Just click on your presentation.
Your presentation.
Just click on your mother.
Yeah. Your LPD one. You just yes.
Okay. Fine. Now click on the share screen. Green button down.
Share. No, there's a share. There's a share. Already she's there. You have to put as a PPT.
Just
the play only. Yeah.
Yes.
Okay.
Yes.
Good afternoon, everyone. Sorry for the delay. I bring greetings from my place, Tirunelveli. Hope you all know everything from this. Of course, the Halbar. And LPD's luteal phase support is always a subject of controversy. And when a thing ceases to be a subject of controversy, it ceases to be a subject of interest. And that's why we are here talking about this. So LPD is a very common condition that may occur during controlled ovarian stimulation and hyperstimulation programs. This is a complex problem when you adopt different mechanisms to induce ovulation, and it takes a different route altogether compared to the national route for making a safe nidation as like this. So luteal phase starts from ovulation, everybody knows, and ends at the onset of menstruation or when the pregnancy is diagnosed. Corpus luteum is the most hormonally active gland, and progesterone secretion is the hallmark of this phase. So progesterone, what does it do? It gives secretory changes to the endometrium, vasodilates the endometrial vessels, downregulates the inhibitory factors, upregulates the factors like all these interleukins and IGF-1, relaxes the uterus and increases the endometrial receptivity. So what happens in this defect? There will be abnormal folliculogenesis, which has deficient progesterone 4 secretion from corpus luteum, which leads to unhealthy follicle, thereby giving low estradiol, and inadequate LH surge, which is the hallmark again, and gives to low progesterone. So what to use for luteal phase support and when to use? We know the progesterone is the hormone for luteal phase, and along with that, HCG, GnRH agonists and addition of estradiol can also be added. Progesterones, the common routes will be oral, IM and vaginal. Of course, oral route is not much used because of its metabolites and the slow serum progesterone level of about 1.5 nanogram per ml when we expect 4 and 5 nanograms per ml. But now sustained release tablets have come, which maintains a very good serum progesterone levels of more than 20.6 nanograms. Coming to IM progesterone, it has a high serum concentration, but it's very uncomfortable and painful and inflammation at the injection site. Subcutaneous preparations, aqueous preparations are available, which is of course less painful. Transdermal progesterones are also available, but it's not an option again because of its destruction with the 5-alpha reductase in skin, and large doses of progesterone cannot be administered through this mode. Vaginal route is the preferred route because of its first uterine pass effect and targeted delivery. And about 300 milligrams of vaginal progesterone is effective in reducing the spiral artery pulsatility, PI and SD ratio. And the newer technology, the effervescent tablets, which disintegrates in 7 to 10 minutes, and the concentration it gives is about 10 nanograms per ml. The conclusion is this is vaginal progesterone is superior to IM progesterone because of its counter current exchange mechanism appears to be the progesterone transport in the course of uterovaginal area. Vaginal rings are also available, which releases 10 to 20 nanomoles per ml for 90 days. And progesterone gel is also a newer methodology which has come, which has got micronized progesterone and emulsion system. It is once a day, and so acceptance is very good. Combinations with progesterones, estradiol is combined only in long protocol, and of course in GnRH agonist trigger. Ascorbic acid, prednisolone, aspirin are also added as and when needed. Coming to synthetic progesterones, it is lot assessed in Lotus trials, but not efficacious alone though, but in combination with other endogenous progesterone. HCG supplementation, it stimulates the theta lutein cells, produces more progesterone than other steroids, Used every 3 to 4 days. The dosage, as we all know, 2000 international units on day 3, 7, 10, or 5000 international units 5 to 9 post-ovulatory days. Excellent for poor responders of IVF, but not used in cases where the estradiol is more. The disadvantage is only thing we cannot use when the estradiol is more than 1600 units in the case of IUI. But low doses like 1500 units can even cause OHSS if you prefer HCG stimulation. But microdose supplement of 100 to 150 units per day throughout the luteal phase without the exogenous progesterone is sufficient, but delivering this microdose is very difficult. Coming to GnRH agonist for LPS, which increases LH secretion, acts on the endometrium through the locally expressed GnRH receptors, but used along with progesterone, given after 6 days of oocyte retrieval or 3 days after embryo transfer, increases the implantation rate, very much supported by the Cochrane meta-analysis. E2 supplementation is needed for endometrial preparation for embryo recipients in IVF cycle. There is a drop in the mid-luteal and mid and late luteal phase. This low estrogen depletes the progesterone receptors and thereby changes the entire endometrial receptor dynamics. So estrogen supplementation is useful in long protocol, the dosage being 4 to 6 milligram for securing higher pregnancy rate. For GnRH agonist trigger, addition of E2 is definitely necessary as there is a deficiency of LH and the corpus luteum is not at all stimulated to produce estrogen and progesterone. So when to use this luteal phase support? Coming to this ART cycles, LPS and gonadotropin cycle. LPS is needed for all the stimulated cycles with agonists and antagonists because it gives supraphysiological estradiol levels and progesterone, which inhibits LH. Luteal phase support with SCG trigger in follicular phase, LH low because of the agonist or antagonist. So this is rescued by the early luteal phase by a bolus of HCG, which can be 5000 or 10,000 international units. This secures growth factors and cytokines for the implantation. And progesterone is also a must because to cover the luteal gap, which happens 5 to 8 days post-trigger. LPS with GnRH agonist downregulation, it starts from the 21st day of the previous cycle and continues as a half dose till the ovulation. So judicial luteal phase support is needed because of the low levels of LH, which continues even in the luteal phase. Luteal phase support with antagonists, it is the preferred protocol nowadays, which is started in the 5 to 6 days as fixed protocol or when the follicle is more than 14 mm. Suppression of LH continues again in the luteal phase, so luteal phase support is always needed when you have a fresh transfer. In a fresh embryo transfer, there is an intensive support needed, which will be intramuscular progesterone 25 to 75 milligrams per day or micronized progesterone 800 milligram vaginally with estrogen as a patch or as an oral estrogen validate 2 to 8 milligrams. The objective is to maintain estradiol levels of more than 200 picograms per ml and progesterone more than 20 nanograms per ml should be maintained. In case of frozen embryo transfer, if only vaginal progesterone is given, then the progesterone level is less than 9.2. So definitely vaginal progesterone should also be supplemented with the IM progesterone for better results. There are instances where we can see progesterone resistance in luteal phase in cases of endometriosis, PCOS with androgen elevation, pituitary ovarian dysfunction, abnormal biomarkers for endometrial implantation. So what will be the duration of luteal phase support? 10 to 12 weeks or more than that? It depends upon the clinician who uses that. We are seeing lots of support continuously used till 34 weeks. But the dependency of corpus luteum is over by 8 to 10 weeks and placenta takes over. At 5 weeks, SCG is more than 1000 international units and this would be sufficient to maintain the pregnancy. But in frozen embryo transfer cycles, the continuation should be, the LPS should be continued till 9 to 10 weeks for the luteoplacental shift to happen. So the take-home message for all these protocols will be all superovulated cycles require luteal support and GnRH agonist trigger luteal support is mandatory. In cases of fresh transfer, judicious use of estrogen and progesterone with the dual trigger or 1500 units of HCG at the time of ovum pickup. They give remedies for fresh transfer. You can avoid OHSS by freeze-all technique. Estrogen supplementation for long protocol and for agonist trigger can be used. LPS cannot be started after 3 days of ovum pickup, and all FET cycles, LPS should be continued for 10 to 12 weeks. So now let me come to some special situations where we have to be cautious during the luteal phase support because of the inherent problems we have. LPS and autoimmune disorders, the sexual dimorphism is most apparent in autoimmune system, and the female predominance is quite obvious. SLE is enhanced during pregnancy, and multiple sclerosis and rheumatoid arthritis is decreased during pregnancy because of the progesterone levels. And ovulation induction with gonadotropins is successful in these patients. And whatever protocol we use, along with progestational support, hysteria should also be continued depending on the FET cycle or not. Supportive therapy like preventive anti-inflammatory therapy, heparin, anti-aggregant therapy, prednisolone should be used. And in cases of antiphospholipid antibodies or prior thrombotic events, all these should be used judiciously. And any antihypertensive medication, if been previously taken by the patient, should be changed to pregnancy-favored anti-HT medications. So adequate anticoagulant, immunosuppressant, and antihypertensive medication will be the key for these autoimmune disorder patients with progestation and estrogen support. Luteal phase support in renal transplant patients. OHS is a serious complication which we should avoid in these patients because the recombinant FSH we use during the ovulation induction is cleared through the urine. So this has to be kept in mind. This is not for people who have got moderate renal impairment. And the enlarged kidneys which happens in OHSS causes more renal obstruction, and this worsens the problem compared to the biochemical parameters. In patients with rituximab, IVF is successful and 5GG levels are kept under the normal range despite the depleted peripheral B cells. But we always should have a multidisciplinary team which is required to address the complex ethical, medical, and psychosocial issues concerned with these renal transplant patients. So the points to be noted and to be cautious is giving general anesthesia during OPU for these renal transplant patients, care of the pelvic organ, risk of thromboembolism should be seen, avoiding OHSS, and single embryo transfer at blastocyst stage can be planned. Proper counseling and informed consent of the couple is always necessary. Coming to thyroid disorders, as we know, as we've heard clearly from the previous speakers, thyroid function is of paramount importance in fertility, and adequate screening and treatment accordingly can improve conception. Pregnancy rate and delivery rate are significantly higher in those treated with levothyroxine than placebo, and thyroid peroxidase levels should be kept under 120 for preventing miscarriages. So thyroid function may also be affected by the administration of HCG to trigger ovulation because they both share the same common alpha subunit and the hormone-specific beta subunits. Surprisingly, they share 85% of sequence homology. So it is likely that HCG can cross-react with the TSH receptor. So free T4 levels seem to be increased, and the increased thyroid hormone demand the imposed by the ovarian stimulation and early pregnancy. They require increased dosage of levothyroxine. Because hypothyroidism may cause structural changes in the epithelium and that of the endometrial thickness, and also affects the implantation and clinical pregnancy rate, we have to be very careful with the levothyroxine dose. LPS and luteal phase support in heart disease, it was recently found that there is a 7-fold increase in the incidence of pulmonary embolism during the first trimester of an IVF pregnancy compared to the spontaneous pregnancy. And this is because of the estrogen surge during the ovarian stimulation, which is hypothesized to be the initiating pathophysiological event. This increased risk coincides with the persisting increased estrogen level. So another way to avoid the risk could be a delayed embryo transfer by adopting a freeze-all strategy. So in heart patients, in IVF has since more than 4 decades fulfilled the desire of many women to conceive despite the decreased fecundity in heart diseases. However, pulmonary embolism is a potentially life-threatening event. There is an 8-fold increase in the first trimester. To avoid this risk, we have to use the freeze-all technology and the judicious use of low molecular weight heparin to decrease the risk of VTEs, thromboembolism. Coming to diabetes, monitoring the sugar levels is utmost important. In type 1 diabetic patients, progesterones in the luteal phase tip the balance, so counseling and frequent monitoring is essential. Insulin titrations and the medication.
Can you conclude in 2 minutes, please?
Yeah, sure, sir. Better than the home monitoring. Type 2 diabetes mellitus, oral hypoglycemic agents along with the lifestyle modification. In hyperprolactinemia, bromocriptine is the drug of choice. In recurrent pregnancy failure, we have advanced immunotherapy in the form of corticosteroids, G-CSF, IV fat emulsions, tacrolimus, and adalimumab. But immunotherapies have insufficiently investigated to make final recommendations for their use. Thank you. Thanks for patient listening.
Thank you, Madhubala. Thank you for the nice presentation. We'll be seeing your questions at the end of the session, and we are moving on to the final talk of this webinar. We have finished a luteal phase and we are entering the pregnancy, and the pregnancies, what are the issues that you are going to see in the first trimester. To enlighten about this content, we have here Dr. Mohan Kamath, who is the HOD of CMC Vellore, Professor of Reproductive Medicine, CMC Vellore, who is the editorial board member of Cochrane Fertility and Gynecology, and he's the associate editor of Cochrane Clinical Answers, and he's the associate editor of ESHRE Journal and deputy editor of Journal of Human Reproductive Sciences, that is the ISAR Journal, and he has done a lot of publications, over 75 international publications, and has reviewed and had received the peer reviewer for indexed international journals. And he has been the faculty for many of the postdoctoral FNB fellowship courses in the DMD, MCH Reproductive Medicine and Surgery. Over to you, sir, for your presentation on the post-ART pregnancies issues in the first trimester.
Thank you, madam. I'd like to thank Dr. Sanjeeva Reddy, sir, and Kamala Savravansh, madam, for having me over here. I'm just trying to put this presentation together. Without wasting any time, we have 15 minutes. So I'll just touch upon some very important aspects of pregnancies following IVF. And because we have 15 minutes, I'll probably just touch upon it. And of course, if there are queries on it, it will be good to answer those. So I'm mainly focusing in this talk on the first trimester issues following ART. So what the clinician should know, whether the ART specialist or the person, the obstetrician who is managing the first trimester of a IVF pregnancy. So what are they supposed to be aware of? So all of us know now that ART pregnancies have their own issues. It's because they have multiple pregnancies is a kind of a norm in ART. You also deal with the advanced maternal age, but it is also known now with all the literature supporting that infertility itself is an independent risk factor. Apart from that, of course, it's the patient's profile. It's like a long duration of infertility plays on our mind whenever we are handling the pregnancies following IVF. So in this context, what are the important variables that we need to keep in mind? Now, as we know that, yes, there is a reason for more complications in IVF because of multiple pregnancies. But my talk mainly is focusing on the singleton pregnancies following IVF. And now there is enough literature to support that even the singleton pregnancies following IVF are at a higher risk of obstetric and perinatal outcomes, adverse outcomes. Now, it is not clear what is the reason. Is it because of the altered endocrine milieu, or it is because of the in vitro handling of gametes, or it is because of the patient, the couple's profile itself? So these are things that are being still dissected out, and it's not clear why this happens. But one of the important point that was raised by Anya Punborg et al., she did this groundbreaking work way back in 2005, was the role of vanishing twin, and I probably will focus most on this, that's an important contributor to the perinatal, adverse perinatal outcomes in IVF. And this is, I'm talking about only singletons. So this is definitely associated with practice of transferring more than one embryo, which is kind of a norm in this part of the world. We know that single embryo transfer hasn't been taken up big time because of so many reasons. But what we need to understand is what's the incidence of vanishing twin. Let's say look at the incidence in the European continent, it's around 10%, and it's a dependent variable on the number of embryo transfers. We did our own study way back in 2016, and we found it as 31%. Now, this is again, as I said, it's a function of mean number of embryos being transferred in a unit. So if your mean number of embryo transferred is higher, you're likely to have more vanishing twins and subsequently the problems related to vanishing twin. So this is a data that we looked at, that was the UK data, and it can clearly show that when you have a singleton following a single embryo transfer versus singleton following more than 2 or more embryos, you have a problem not only in the first trimester, the problem carries on till the third trimester. So again, it is related to the number of embryos transferred. So that is why the IVF specialist has to be very aware that it's about counseling. We always stress on the pregnancy rates and so on, but the smoother and a complication-free pregnancy is also important for a healthy live birth. Now, vanishing twin, when we move on, we have a lot of couples, anxious couples coming back with first trimester bleeding. This is something we all deal with all the time. Pregnancy has happened, but they report in an emergency in our unit all the time that they have bleeding. Now, this is because IVF pregnancies are again more commonly associated with first trimester bleeding as opposed to the spontaneous pregnancies. Now, this is where the role of vanishing twin comes. The vanishing twins are known to be associated with more incidence of first trimester bleeding. So the higher the mean number of embryos, higher the vanishing twin, higher is the rate of couples where the patient reporting with first trimester bleeding. So it's all related. So this is something that we should all ponder upon. And if somebody has had a first trimester bleeding, it also has been associated with second and third trimester bleeding. And in third trimester, we know it becomes antepartum hemorrhage and it can have its own impact. So it is associated with higher preterm birth as well. So first trimester bleeding is an important event, that is complication which needs to be looked at, but it has also implication for the remainder part of the pregnancy. Now, moving on to a different aspect of first trimester screening. Now, prenatal testing and screening is an issue with IVF pregnancies. Why is that? Because you have, again, the advanced maternal age. Then you have the problem of multiple pregnancies. It's not an easy thing to do a prenatal testing in this group. But again, the problem of vanishing twin complicates our interpretation of biochemical screening. We also are aware that there are higher rates of anomalies with ICSI babies. But more importantly, there was a study done which clearly found out that the women who have IVF pregnancy are less likely to take up invasive testing. So we need to keep these things in mind when we are offering prenatal testing following IVF. Now, what is known, and this is a fantastic review published way back in 2012, that they looked at the literature, and what you can see here is the free beta HCG is actually lower, the mean beta HCG levels in early pregnancy in an IVF. That is pregnancy following IVF, less than 8 weeks, the beta HCG, which is a part of the biochemical screening, is on the lower side when compared to natural pregnancies. However, this reverses, and by the time it crosses 11-12 weeks, the mean beta HCG level following an IVF is higher. So we need to keep this in mind whenever we are offering biochemical testing in a prenatal setting for an IVF. Again, there's another observation, that was that the PAP-A, which is again a part of the biochemical screening, is lower in first trimester in IVF pregnancies. And this is something that has been consistently shown in many of the studies across the literature. Now, why is it lower? There are some studies which have indicated it's the ovarian stimulation that is responsible for this. The bottom line here is that knowing this, there needs to be a correction factor added in the algorithm when you're looking at a prenatal testing and specific for your own population. So many times this is not done. And what happens is there is a higher false positive rate for prenatal testing, and which is something that we need to be aware of in the context of women actually not taking up confirmatory PND testing. So we have to balance this. We have a risk of higher false positives because of the factors that I've just mentioned. At the other side, the women are not likely to take up the invasive testing, which we can understand that's the anxiety factor with the prenatal testing. So a very proper counseling and a lot of attention has to be given in the prenatal screening for an IVF pregnancy. If it is twins, it just complicates things further. And if it's a vanishing twin, then it can really complicate your prenatal testing. And many this particular update did suggest to rely more on the maternal age and the NT screening as far as the prenatal testing in twins is concerned. And they in fact went on to suggest that second trimester triplet test is not advisable because of the huge variability of HCG component. So what they have recommended is NT, of course, remains largely unaffected. And if you're using any of these biochemical testings, you have to try to get the correction factor added for IVF. But the problem is now there is literature coming in which shows that there is variation when it is frozen transfer versus fresh transfer and so on. The data is still being collected. It's not very clear, but we need to be cognizant of the fact that all this information needs to be collected, and all its caution is advised when we are interpreting the first trimester screening results. Moving on to other fairly rare event in a natural pregnancy, which is monozygotic twinning. All of us are worried when we look at a monozygotic twinning following IVF. Now, this happens for 0.4% in natural conception, but it happens for 1.4% in post-IVF. Now, why is it happening? Most of the studies have clearly attributed it mostly to blastocyst culture, assisted hatching, and now the embryo biopsy. So we have a lot of PGT cycles going on, but we run a risk of adding one extra monozygotic twin for every 100 pregnancies. And in monozygotic twinning, we are more worried about the monochorionicity, which is of more clinical importance because it leads to twin-to-twin transfusion and so on and so forth. So when you're doing a first trimester screening, which is the best chance for you to identify chorionicity, we need to focus as clinicians. If you are diagnosed monozygotic twinning, whether it's the chorionicity is monochorionicity or it's dichorionic, because it's got implication for the next 2 trimesters. So this particular data from the human, the UK data, again, we looked at this and you can clearly see that there is a dramatic increase from 0.4% in natural to PGT cycles have a 2.5% risk of monozygotic twinning. And all of us who are offering PGT need to be aware of this and probably should be counseled for the same. Another aspect that we deal with, of course, pregnancy comes and then we deal with higher order pregnancies. So it's good that we don't fall in that category, that our patients don't go through a higher order pregnancy complication. It's good to probably restrict the number of embryos to 2 max. Single embryo would be ideal, but okay, 2 would do well in most circumstances. However, I do understand that there are situations where there has been recurrent failure and advanced maternal age and so on. We end up putting more than 2, and then you have higher order pregnancies. So what are the options for us as clinicians? You could probably go for an expectant management or a fetal reduction. So how do you counsel this group? So there's a fantastic paper way back in 2006, which clearly showed the advantage of fetal reduction versus the risks. So if you quantify for a clinician, 1/3 reduction in very preterm, that is less than 32 weeks. But the stats is staked up like this. For every 7 fetal reductions that you perform, you'll prevent 1 preterm birth. Okay. But for every 26 fetal reductions performed, we will add up 1 miscarriage because of the procedure itself. So this is a very interesting stats from the study, and probably it can be used in your counseling as well. So that's for the higher order pregnancies that we see in first trimester in IVF. Moving on to certain other complications that we see late OHSs, which is more of a rarity now because we are more and more embarking on freeze-all cycles. But then those who don't follow freeze-all for all the cycles and inadvertently once in a while you land up with late OHSs. If a patient comes who's early pregnancy following fresh IVF and it's got a hyperstimulated ovary, pain with pregnancy, you have a DD of late OHSs, ovarian torsion, and heterotropic pregnancy. So for the beginners, it's very easy to go back and check. So if you are confused between late OHSs and ovarian torsion, don't rush in. If the symptoms are not very acute, you don't have to rush in. they present similarly because they are early pregnancy, abdominal pain, and enlarged ovaries, and so on. Simple blood tests like hematocrit would give you a good idea along with a Doppler performed, and you can wait for some time for things to unravel. Most of the times between 6 to 12 hours, you will figure out that either this is an OHSS or it's an ovarian torsion. It could be a subacute ovarian torsion as well. So things are never very crystal clear in clinical practice, but these are two diverging tests and they will give you some idea of which one it is. So if the hematocrit is on the higher side, like 45% and so on, then it is moving more towards a late OHSS and we should manage accordingly. Whereas if the hematocrit is normal and there's an issue with the Doppler flow being reduced in one of the ovaries, then we move more towards a ovarian torsion. Heterotropic pregnancy, of course, is one of the final rare ones, but then it happens again more commonly in IVF. So all of us as clinicians need to be aware of it. So in a natural conception, it's between 8,000 to 30,000, but in IVF, it's actually lower than 1 in 1,000. It was, in fact, could be 1 in 500 as well. And again, it's a function of number of embryos being transferred. So higher the number of embryos being transferred in a unit at a mean level, you're likely to encounter more of this. And of course, if the underlying pathology like hydrosalpinx and tubal blockage is there, those are also at a risk of heterotropic pregnancy. Couple of practical points. It's a diagnostic challenge to go for diagnosing a heterotropic pregnancy for those who are beginners. Keep in mind that beta HCG, of course, is not very helpful when you're looking at these kind of conditions. What happens in practice is sometimes when you see a pregnancy and an intrauterine sac, we kind of are quite happy and we drop our guards. And sometimes because there's a pregnancy and some vague complaints of pain, we kind of ignore those warning signs. And if it's a fresh cycle, multiple corporeal make it a lot more difficult to detect any extrauterine pregnancy as well. So this is something that we need to be cognizant of. Now, practical tip here is when your unit has a particular level at which the beta HCG is positive and you can correlate. If you find the beta HCG to be much higher and you have transferred more than one embryo, and if you find only a single gestational sac, always make it a point to have a good look at the adnexa and rule out any suspicious mass. Focused ultrasound, concentrating, not going mechanically about it, is a good point to detect. If you find something suspicious, you don't have to alarm the patient too much. We just kind of keep a track, probably call her for a more early scan to just corroborate what you have been suspecting. But of course, if the woman is complaining of pain in abdomen and it's been continuing for some time, then you should start suspecting all these clear-cut case of heterotropic pregnancy. Most of the times they are managed surgically because you don't want to really disturb the intrauterine viable pregnancy, and role of local therapy like injecting KCL in the extrauterine pregnancy is limited, but however, you can explore it if at all there is a strong reason to avoid surgery. So that's, I could probably capture most of the complications, but overriding message, if you ask me, this paper clearly showed that the perinatal outcomes right from first to the last pregnancy, singletons following elective single embryo transfers actually do exactly very similar to singletons following non-IVF treatment. So the overall message, if you ask me, is there has to be a constant drive to reduce the number of embryos being transferred, because that will reduce the complication, especially the first trimester complication that we see during IVF. So that will be good for our patients. Take home message, ART is an independent risk factor for most of the pregnancy outcomes. In the first trimester, a very focused ultrasound with all the points that I have mentioned needs to be done. And the vanishing twin phenomena has to be taken cognizance of because it's linked to so many other problems that we might face. Quite often in practice, late OHSS, ovarian torsion, these are two things which present, and there are ways to go about it clinically and identify which one with simple testing. And prenatal screening, I have mentioned the reason that post-IVF pregnancies, the biochemical parameters are not exactly like the spontaneous pregnancy parameters. So we need to be cognizant of it and accordingly plan the testing. Thank you.
Thank you, sir. Thank you for the nice presentation. So now we have a lot of questions. So first question for the Dr. Hina. There's a question by Dr. Meenambal Nagarajan from Coimbatore. Hyperprolactinemia is often associated with hypothyroidism. She wants your view. Perimetry is it mandatory? Just she wants to add on to it.
Thank you, ma'am. Thank you for the question. And yes, hypothyroidism is an important
All of you
cause
switch
for...
on your videos, please.
So hypothyroidism is an important cause for hyperprolactinemia. And when your patient has hypothyroidism, what happens here is the thyrotropin release hormone is increased. And this TRH has a very stimulatory effect on prolactin secretion, thereby leading to hyperprolactinemia. So whenever we have patients with hypothyroidism and hyperprolactinemia in the same patient, so just correcting a simple hypothyroidism with thyroxine supplementation is all that is required to normalize the prolactin values. And coming to perimetry, perimetry is not really required for all the patients. It has been suggested only for patients with visual field defects or some visual abnormalities. So I hope that answers both the questions.
Yeah, thank you, Dr. Hina. I think Dr. Jasneet from Chandigarh, she was asking about the aspiration pressures. I saw in the chat box, Priya has answered her question. I hope it's very clear. Do we have any questions? I think so. There is one more question. Yes, there's
Whoever
nothing.
is there, just switch on your videos, please. I want to take big photo. I will charge only $25 for each snap.
You will give us, sir? For showing our face, you should give us, sir.
Okay. Madam, you are there? Hello?
Sir?
Anyone else? Smile. Okay. Continue with your questions now.
There's no much of questions, sir. I think there's no much of questions.
We move on.
Yeah, I think over to you, sir. And thank you for the nice webinar, sir. And I thank you, Madam Kamala, Madam, and Dr. Sanjeev Reddy, sir, for giving me these opportunities. And we had a very nice presentations. All the presentations were wonderful, very practically selected, and very useful for all the ART specialists, from the beginners till the expertise. Thank you, sir.
One second. So each one is joining slowly. I think they are getting ready, makeup. Okay. On behalf of TAPI, sir, I thank the moderators for their excellent moderation and extracting all the questions and updating the delegates. I also thank all the speakers from all parts of the country for their excellent talk. Usually in a webinar, 50-60% of speakers will speak well, other people like just that average. But here it is 125%, you can say like 200%. Each one is prepared very well and spoke very well. And topics also, as Dr. Jairani was telling, it is fantastic. You may not get this problem each day, but when you get this type of problem, we don't know what to do. So if the people who are going to speak on, listen to this one, or we are going to share the recording also, they can keep this presentation, and really it is going to help them as a ready reckoner. And I should thank the award company for sponsoring, particularly Mr. Ananda Kumar and Isaravelan for from coordinating from the beginning. Also, Mr. Sheshan and his team from Science Integra, without any hitch from the beginning to end. He provided this platform very well. And for the technical staff also, I thank very much. Anybody you want to share your opinion on this, we will be happy. Speakers and other people.
Sir, it's really very interesting Sunday. Though it is most of the topics have been covered in all the meetings and CMAs, but this is something special. So there are a lot of, how many ever times you repeat the topics, every time when a different speaker speaks, they come out with new points, new studies. So very interesting, sir. You keep rocking, sir. What else I can say? It's all, and it's the right day to keep just the previous day of Women's Day and keep all the women. I mean, all the speakers, moderators, everybody was beautiful. So happy Women's Day to all.
We didn't plan like that actually, but it came on this way. That's very nice. For Women's Day, this is dedicated to all women of
Thank you,
India.
sir.
This way, dedicating this thing.
Thanks for keeping the time up.
Okay. Thank you.
And one more, some of the viewers, she asked me, see, normally in other seminars and CMEs where we attend, they'll be served snacks and food. But here nothing is there, so you can arrange something else also.
No, we served academics, no, without wasting time.